from the very end, from the very beginning to the very end. And in summary, of course, PCI of the left main is a huge topic and regards many aspects. We should qualify wisely. We should always use imaging, if possible, also FFR and physiological assessment. We should look at the hemodynamics. We should be prepared perfectly, so if possible, always use 7 French guiding catheter and have a plan for the bifurcation complication. Should keep it simple. We should also cover correctly all the lesions and protect geometry, preventing the longitudinal stent deformation. And of course, if the left main PCI occurs during ACS, we have to act fast. Thank you very much.
Thank you, Dr. Michael Havnik, for that awesome talk. We have missed you here. I think in interest of time, we proceed to the next session. We take a quick picture and proceed to the next session.
Thank you to all the panel. We now move to our next segment, Learn from the Masters, the Eminence session, a unique opportunity to gain insight from pioneers whose experience and vision continue to shape the field. To chair this session, I invite Dr. Imani Satyamurthy, Dr. Asha Mahilamar, Dr. Shiva George, Dr. P.K. Hazra. The session expert panels are Dr. Rashi Khare, Dr. Nana Borotani, Dr. Ankit Agrawal, Dr. Bhushan Shah, Dr. Nidhi Bhimsen. To moderate this session, I invite Dr. Shiba Chabra. Over to you, ma'am. Requesting all the chairpersons and panelists to join on stage, please.
So thank you so much. And now we are on to our next session. And the session is none other than Learn from the Masters, the Eminence session. And when we talk of masters, who can be a master? None other than our very worthy Dr. Satyendra Tiwari, President-elect CSI. We are happy to have you with us, sir. Thank you so much. And Dr. Satyendra Tiwari is going to deliver a lecture on how can we predict the ACS occurrence in the future. All off to you, sir. Can we have slides? Yeah. Yes, sir. There.
Good morning, everybody. Thank you, Shiva, and other panelists, chairpersons, Dr. Hazra. Thank you, Dr. Sarita, for inviting me on a very prestigious conference, WINCAR. And thank you very much. So a very important topic which I take you for a couple of minutes. So it's a problem for all of us to understand and to predict. How can we predict the acute coronary syndrome occurrence in the future? As I said, that it remains a leading cause of mortality worldwide. And, short-term 30-day mortalities ranges from 5 to 10% in the developed countries. And even developing countries, it is even higher, and which contains a very high mortality in our region, developing countries. And the long-term complications lead to recurrent ischemia, left ventricular dysfunction, and finally the heart failure. So it is often occurs without warning. That is the most challenging to predict the acute coronary syndrome. When can it occurs? And the injury begins so fast, within 1 hour. It's a golden hour time. And the challenge for all of us as a clinical cardiologist, physicians, that how to monitor, and it's practically impossible to track all these coronary artery disease patients who are going to develop some acute coronary event. And for this, you need a robust risk prediction models. How can you predict any model which can lead to occurrence of coronary syndromes? So there are challenges like assessment of the stenosis, the silent plaque, which is stable, and the clinical risk factors, and modifiable risk factors, genetic factors. And however, many ACS arise from non-obstructive plaques. So one should understand the plaque biology and hemodynamics, which is very critical to predict the future occurrence of coronary events. So the coronary, the assessment of the coronary stenosis is very important, and equally important is the plaque characterizations. So identification of the adverse plaque characteristics, which includes low attenuations plaque, the napkin ring, which is an important sign, the postal remodeling can lead to acute coronary syndrome, and the spotty calcifications. So that is very important. And along with this, we also should understand the hemodynamics of these plaque ruptures, because once the ruptures occurs, one should understand its compositions and what are the mechanical stress which can lead to rupture and acute coronary syndromes. So there are various hemodynamic markers which we should know to predict its occurrence: the FFR-CT, the wall shear stress, and the axial plaque stress. So that is very important, and the delta FFR-CT. So exploring the mechanism, the Emerald study, which shows the mechanism plaque ruptures in using coronary CTA and the flow dimensions. It was a multi-center study of 11 countries and determines the non-invasive hemodynamic assessment plus the plaque characteristics to understand which later ruptures and lead to acute coronary syndromes. So here in this study, we included the ACS patients and patients who have a prior coronary CTA done from 1 month to 2 years' time. And we excluded patients of bypass surgery or those who need angioplasty in the future, and those who have a poor CT imaging. So these patients were excluded, and the study flow was 72. Initial of Emerald 1 study included 70 patients. 1/3 were having a culprit lesion, and the 2/3 have a non-culprit lesions. So adverse plaque characterizations, the features of low attenuation plaque, less than 30 units, positive remodeling can lead to rupture, napkin ring sign, and a spotty calcification. So these are the 4 basics characteristics of the adverse plaque characteristics. At the same time, one should also understand the hemodynamic assessment by the coronary flow dimensions, and which includes the FFR by FFR-CT, and the FFR-RCT, wall shear stress, and axial plaque stress. And the mean stenosis was around 50%. The mean FFR-CT was 0.78. The median time of ACS was of around 1 year, and the majority presented with MI. So if you can see, after doing the CT, after 4 months, the top graph shows the LAD involvement, and patient had acute myocardial infarction. So the culprit lesion in LAD artery has both adverse hemodynamic characteristics and adverse plaque characteristics. So if you can see the napkin ring, spotty calcifications, and low attenuations, it's a very high adverse plaque characteristics. The bottom line shows the right coronary involvement, which is a non-culprit lesion in a right coronary artery, has only an adverse plaque. So all these 3 important 4 features suggest the occurrence of plaque ruptures in the recent times, and after 4 months they develop acute myocardial infarctions. So if you can see the culprit versus non-culprit lesion, the culprit lesion have a greater stenosis, the longer lesion length, higher adverse plaque characteristic prevalence, and the worse hemodynamics. So they make 3 models. The model 1 is shows there is a stenosis, there is a long lesion length. The model 2, they have added the adverse plaque characteristics like napkin ring, spotty calcification, and low attenuation plaque. And the model 3, they added the hemodynamic parameters. And these hemodynamic parameters were equally important, so it's become additive factors to predict the future occurrence of acute coronary syndromes. And this model performs that. The model 1 is a baseline, as you see here in this graph. The model 2 is a better discrimination, and the model 3 is the best predictions, where the role of artificial intelligence comes. So the adverse plaque characteristics along with the hemodynamics, it leads to a better outcome, better predictions, and the risk of ACS is highest in both the presents. So comes the role of Diamond FFRCT. The Emerald 2 study in which the hemodynamics were assessed by the artificial intelligence, and this improves the outcome and prediction of the ACS in the culprit lesions. In the Emerald 2 study, they have taken around 450 patients, 300 patients were included. So the cohort of around 243 patients, and it is basically the AI based, which assess the plaque features, plaque burden, total plaque volume, and the low attenuation plaque volume. And all these 4 features are responsible for the poor adverse plaque characterizations. Along with that, AI-based hemodynamic features were already, which shows the wall shear stress and the myocardial blood flow. And the key predictive features includes the plaque burden, total plaque volume, low attenuation plaque volume, and the percent myocardial blood flow. And all these features lead to make it more predictable. And this model improves the discriminations, and so the outcome and the prediction is become much better and more effective. So the AI features that within 1 year and beyond 1 year, you can predict the consistency across time intervals. So as I said, the AI-based model has shown that Diamond FFRCT had the strongest impact in prediction of the future occurrence of acute coronary events. So the future ACS predictions improves when it is integrating into anatomical severity, the plaque characteristics, add on the hemodynamics parameters and AI-based analysis. But there are limitations of this study that it was retrospectively designed for a shorter sample size, and it needs larger prospective validation for its occurrence and predictions. So to conclude, ACS risk is determined by plaque biology and hemodynamics, and it is a powerful predictor, the Diamond FFRCT. So it has an AI-enabled CT analysis, it significantly improves the risk predictions. The integrated model may allow preemptive intervention for high-risk patients. So the message is, if the future is unrealistic, so fortunately it will remain the future. That is the bottom line. Thank you very much.
Amazing talk. Yes, the future is unrealistic, but it will definitely remain the future. And the way AI and SHAP analysis is going up. Sir, we have a few questions and comments from the
please.
chair.
Thank you. A very thought-provoking talk. And ACS prediction is definitely a million-dollar question. And but to do a CT-FFR and CT coronary angiogram on a population level is going to be difficult. So what do you think about a combination of biomarkers like HS troponin or CRP in prediction of ACS?
So not only the blood biomarkers, but the biomarkers of prediction of the adverse plaque characterization, along with its hemodynamic occurrence is equally important. So when you combine these 3-4, the predictions become more predictable. That is the point. Which is,
yeah, I think, what do you think? All high-risk plaque on CT scans are vulnerable plaque on imaging as per the PREVENT trial is concerned, and vice versa, all vulnerable plaques seen in PREVENT trial by 4 criteria are high-risk plaques. They should be treated differently, or they are same.
I think the Emerald study, which I have quoted here to put my point, it was a short study, a retrospective study. They studied the small group of patients, both culprit and non-culprit, and then they have shown that the adverse plaque characterizations, there are 3-4 features of adverse plaque characterization like spotty calcification, napkin ring sign, and other features, low attenuation. So this is one part. Other is the role of artificial intelligence in assessing the hemodynamics of the plaque. So that is very important to predict better prediction in future.
Thank you for the wonderful talk. I would like to ask you, how do you apply it to the general population? Such a complex test.
It is still a challenge.
How do you choose the patient?
Yeah, it is still a challenge to predict in large cohort of the patients. But certainly, if this model is useful and it is user-friendly, then probably a larger cohort study can be planned for the prediction of a future coronary event in ACS patients.
Yeah, yes.
these factors which are predictive, can they be applied for plaque erosion?
Plaque erosion is itself is one of the markers of early plaque ruptures. So, but it is not the only factor, because unless you also demonstrate the mechanical stress over the plaque, when it will rupture and leading to acute coronary syndrome is still a challenge.
So that aspect cannot be predicted, plaque erosion.
Yes.
So I think it's really been a great talk, and was wondering if we could actually have a score, which combines imaging as well as AI and everything for preventing the future recurrence events. So generated a lot of interest. Thank you so much, sir, for an amazing talk.
Thank you very much.
As
Thank
always.
you.
And we move on to the next talk of
Sir,
the day. Is there some quick
one
comment?
comment. I think one more important link which is missing is the inflammation. Markers of inflammation, if integrated.
Exactly
inflammation, hemodynamics, as well as plaque characteristics.
Perfect. So that's exactly what Dr. Asha also pointed out. So maybe a score which combines all these things can help us for future predictions. Moving on to our next speaker, and that is none other than Dr. Shailendra Tiwari. Dr. Sarita was telling me that he's one of the senior most cardiologists in Indore, and she has such an awe and respect for him. He heads the department of cardiology at Jupiter Hospitals, and he's going to talk on non-pharmacological treatment of heart failure. All off to you, sir.
Thank you for that introduction, and I thank at the outset to Dr. Sarita and Dr. Roshan Rao for organizing such a beautiful meeting. So I'm going to talk on non-pharmacological management of heart failure. We know that heart failure is...
Can we have the slides, please?
Heart failure is our day-to-day problem, and as the longevity of the patients is increasing after the better treatment of coronary artery disease and valvular heart disease, we are getting more and more patients of heart failure. And HFrEF and HFpEF both are very important clinical problems to manage. So, we know that guideline-directed medical therapy has helped us in improving the mortality and morbidity in our patients of HFrEF, but device interventions can address many of these unmet clinical needs and are becoming an integral part of the management of heart failure. Device-based interventions can overcome some of the limitations of drug therapy like intolerance, non-adherence, inconsistent delivery, and recurrent and long-term cost. So, what are these measures? It's a combination of lifestyle measurement, catheter ablation, resynchronization therapy or physiological pacing, use of ICDs, cardiac contractility modulation, use of left ventricular assist devices or mechanical support, cardiac transplantation, certain surgical interventions like basilar ventriculoplasty, and a special subset of patients of HFpEF. So I'm going to talk about this in a limited amount of the time, whatever I have available. We know that arrhythmias, that is atrial fibrillation, is very common in patients of heart failure, and lifestyle management is very important for these patients. I would like to highlight that diet and cachexia is very important thing which we have to manage in these patients, and all those patients who have fluid overload, we need to restrict their salt and liquid intake. We have to manage the obesity. Many of the patients have sleep disorders. So in our day-to-day practice, when we are very busy, we tend to ignore certain situations like obstructive sleep apnea. So we have to address these problems. Similarly, the psychological support to the patient is also important. And it's not that if the patient is having severe heart failure, we have to give an exercise program to them. And these are the lifestyle measures which will definitely improve the quality of life. Coming to the catheter ablation, many of these patients are troubled with atrial fibrillation. So those patients who have symptomatic AF and or reduced quality of life from atrial fibrillation, in these patients of HFrEF, in whom class 1 antiarrhythmic drugs are not allowed, or class 3 may have significant tolerant issue, there is a role of catheter ablation, It has been shown in this Kessel AF trial and Cabana trial, where the level of evidence is class 1 for patients of AF with HFrEF with level of evidence recommendation of level 1. So in selective group of patients, we have an option of giving catheter ablation option to the patients of HFrEF. Similarly, ventricular tachycardia and ventricular extracystosis, particularly outflow tract and fascicular origin BPCs are important, and they sometimes reduce the benefit of CRT therapy. So catheter ablation of these patients is important, particularly these patients have ventricular tachycardia. So in SURVIVE VT trial and PART-1 trial, it has been shown that compared to antiarrhythmic drugs, if we offer catheter ablation to these patients, it improves the composite endpoint of MACE. We all know that resynchronization therapy and physiological pacing are very important in these patients. So patients who have criteria for qualification of ICD therapy, like those who have severe LV dysfunction, to prevent sudden cardiac death, we should offer ICD therapy to these patients, and patients who have lead bundle branch block with QRS morphology of more than 150 millisecond and ejection fraction of less than 35%. Definitely the CRT therapy has economic value, and it improves quality of life, and it improves the mortality also. Patients who are in NUHI class 2 or to class 4, and if they have ejection fraction of less than 35% and QRS duration of more than 150 millisecond with LVV pattern, and if they are in sinus rhythm, this class 1 indication, and all these patients should receive CRT therapy. Patients who have a QRS duration of 120 to 149 millisecond, the benefit is still there, and it is reasonable to perform the CRT therapy. But in patients who have non-LVV pattern of QRS and QRS duration is less than 150 millisecond, probably there is no benefit of doing CRT therapy. How can we improve the results of CRT therapy? So now we have evidence that patients who have, now we can choose these 3 sites for myocardial desynchronization. The bundle of his left bundle and the left part of the septum. Out of these 3, the LOT CRT, that is left bundle branch optimized CRT, where we put a lead in the coronary sinus, preferably the left lateral vein, and if we pace the left bundle. So left bundle optimized CRT, it gives maximum benefit to these patients, and as we know that now we have evidence that even in normal patients we are going to do conduction system pacing. So when we combine this conduction system pacing with left ventricular pacing, it gives maximum benefit to the patients as regards the cardiac resynchronization is concerned. While we are doing cardiac resynchronization, it restores appropriate AV synchrony. There is electrically restored mechanical ventricular synchrony, improves symptoms and quality of life. But there are certain patients where we cannot provide CRT therapy optimization. So in these patients, the cardiac contractility modulation is one of the options. There is delivery of the biphasic electrical stimulation to the ventricular myocardium during absolute refractory period to augment the left ventricular contraction. And it is the potential mechanism is to increase the intracellular calcium. The clinical benefits are in the form of improved 6-minute walk test and improved VO2 capacity. And there are future applications in when we can provide this benefit to the patients who have QRS duration of less than 120 millisecond. We can use left ventricular devices, dual mechanical support with left ventricular assist device. We have these patients who have frequent hospitalization of heart failure, and they are symptomatic despite CRT. Cardiac transplantation in chosen patients for selected advanced heart failure despite guideline directed medical therapy. Cardiac transplantation is indicated to improve survival and quality of life. Mechanical circulatory support is class 1 indication in select patients with advanced HFrEF with NYHA class 4. There are certain additional device therapies like baroreflex activation therapy, vagus nerve stimulation, and splenic nerve stimulation, which are under experimentation, and they are likely to improve the outcome of HFrEF patients. Similarly, certain basilar ventriculoplasty procedures like Acculink system or LV reconstruction or V-sling system, they are also likely to improve the outcome of HFrEF patients. Additional device therapies for guideline-directed medical therapy is one of the therapy we can offer to patients where secondary mitral regurgitation is there is mitral wall repair using edge-to-edge repair through mitral clip. It has been shown that there is 73% reduction in heart failure hospitalization rate and decrease in the recurrent hospitalization after mitral clip procedure. In HFpEF patients, we know there are various pathological mechanisms, and we need to address all these mechanisms. And for this, there are certain therapies, electrical therapies available like vagal nerve stimulation, low intensity pulse ultrasound, transcatheter insertion of atrial shunt, personalized atrial pacemaker, renal denervation. So all these are experimental procedures which we can offer to the patients. And in HFpEF patients, the comorbidities need to be addressed, and we can address the presence of atrial fibrillation, we can control their arterial hypertension, coronary revascularization can be offered to these patients, renal dysfunction, type 2 diabetes, sleep apnea, obesity, all these need to be addressed in HFpEF patients. So I would like to say that pharmacological approaches are increasingly gaining scholarly attention. Device interventions are becoming integral part of the heart failure management. The currently available device-based therapies for heart failure generally target similar patients, and some patients may be eligible for more than one approved device. This knowledge underscores the need for a better understanding of comparable and additive effects of these therapies and possibility of multi-device interactions. Thank you very much.
Yeah, thank you, sir. It's really been a great talk, and you've exposed us to the vast armamentarium of available device interventions, not just for HFrEF, but also for HFpEF. Of course, it's such a vast topic, and this time. Of course, yes. But I think you've done great justice. Any comments from my co-chairs and the panel? Well, I think that everything has been well done and covered. Any quick comment from the audience? Right. Thank you so much, sir. It's been a great talk, and a big applause is counted for. Thank you so much. And so we are going to move to the last concluding talk of the day. Dr. Praveen Chandra's flight got delayed in the morning. He'll be joining us probably for the next session. He's just on his way. So I would now like to invite Dr. Sujata Viparla. We all know that Dr. Sujata Viparla is the chairman for the Wincars Association, but I don't think that that is just what defines her. What defines her is not just also her poise and grace, but what more defines us, the silent strength that she imbibes in all of us. Ma'am, all off to you for an amazing case. We're all just wanting to listen that what happened in that hidden short circuit, rescuing acute heart failure through a targeted endovascular intervention. All off to you, ma'am.
Thank you, Shiba. So hopefully it's not match fixed. So Sarita told me to present a case, so here I am with a case. So we had an interesting case with a 70-year-old man, no history of diabetes, hypertension, 30-year history of smoking. He presented with 10-day history of chest pain, tightness, and rapidly progressing dyspnea and pedal edema and abdominal tightness. So we had a working diagnosis of heart failure, and we did a BNP which was elevated, D-dimer was elevated, troponin was negative, renal parameters normal, and there was respiratory alkalosis. But when we did a echo, we had a dilated right atrium, right ventricle, so with a moderate PAH and a severe tricuspid regurgitation. So we did a CT pulmonary angiogram looking for pulmonary embolism. There was no pulmonary embolism. We did a venous Doppler. It was negative. So we had a working diagnosis of COPD because we had a long history of smoking and carpalminal, and we managed with diuretics, aldosterone antagonists, and we stopped heparin initially, with a diagnosis of PTE being ruled out. Then we did an ultrasound as a routine evaluation as part of the carpalminal workup, and what we find is large aneurysms arising from bilateral iliac vessels. The hepatic veins were dilated, significantly dilated in inferior vena cava. So this is how there were massive aneurysms, bilateral, and we had an AV fistula, which was communicating between the left common iliac artery and the common iliac vein. We had normal infrarenal aorta, renal arteries, and bilateral femoral and profunda. And we had on an arterial Doppler, we had decreased flow in the left lower limb arteries as compared to the right arteries. So when we did a CT with this, you can see that there were bilateral iliac aneurysms. There was an AV fistula, which I already told you. So we were planning to do an endovascular intervention in this patient. So we did an evaluation where, interestingly, we found that there were landing zones. So we, both in the right common iliac and the left common iliac, but the aneurysms were massive, and the iliac arteries, internal iliacs, were 5.8 to 6 millimeter, and both on the left and right we had, as I said, good landing zones. So interestingly, there was a very large arteriovenous fistula, as you can see, between the iliac artery and the left iliac artery and iliac vein, and it was measuring 9.5 millimeters. So we made an endovascular plan with the vascular surgeon. We did a bifemoral access, left femoral vein access. So we did it we planned it in 3 phases: closure of the AV fistula, occlusion of the iliacs, and occlusion of the aneurysms with the stent grafts. So this is to give you what we were dealing with. So both on the right and the left, you can see huge aneurysms which were arising. Then this is another view to see. You can see there is a tortuosity in the left common iliac artery. So first stage, we tried to close the AV fistula. We tried to go through the vein, but we could not enter into the artery. So we came from the artery to the vein. We did an AV loop. Then we took a Cook sheath across. Then we closed with an ASD device, a 14 mm ASD device across the AV fistula, as you can see, and we released it into the AV fistula. Then we went to the stage 2. We deployed we cannulated the left iliac initially we used steerable introducers and JR guides. Then we closed the left with a vascular plug. The right, because of the tortuosity, was giving us more problems. We were having difficulties in entering, and almost we took an hour to enter the left iliac and entering, and from there, after crossing this tortuosity, entering the the right internal iliac also was difficult. So we managed to enter the right common iliac and again deliver a vascular plug. Once this was done, this is phase 2, we compared phase 2, and now because we also were prepared to do the aorta also, we had material if we wanted to do from the common iliac and then do the extension into the left common iliac and then do a fem-fem bypass. But in view of the good landing zones, what we did was we deployed 2 stent grafts in the left common iliac and 2 in the right iliac, and we used the Ancura stent graft systems. As you can see, I put so both sides we did it. Then these are the final angios. So the CT would be more useful. So patient improved symptoms of heart failure, RA-RV dilatation, came down stable renal parameters despite a prolonged phase. He had an elevation of liver enzymes which improved spontaneously. We did a follow-up CT at 2 weeks and 3 months. Non-opacification of right side, but left side what happened was the plug has moved into the aneurysm, segment and there was faint opacification, whereas the ASD device was doing good. So this is the CT, you can see it's well excluded aneurysms. Only thing was the ASD device is intact, you can see, but the iliac has, the internal iliac plug has moved into the aneurysm. So we plan to close it again, the internal iliac, through the aneurysm sac because it's 3 months and there's no thrombosis. So basically there was a diagnostic trap, unusual presentation and heart failure, presentation as right heart failure necessitating workup for PTE. It was an incidental detection. We did a meticulous planning and then we did the execution in 3 stages as I already said. Thank you.
Thank you, Dr. Sujata. Indeed, a diagnostic trap managed well with planning and execution. Any comments from the co-chair and the panel?
Very well managed. So you had 3 stages now, till now.
Yeah.
You have one more stage.
Yeah, we have one more stage to go.
There are a couple of questions. If you put a stent graft, automatically the AV fistula also will get covered, provided you take slightly oversize the stent graft, number 1. Number 2, it is a good option to have an aortofemoral bypass in such case, which is both can be excluded, both aneurysms can be excluded.
We were in continuous discussion with an aortic surgeon and we felt that it will be difficult to close the AV fistula because that was the major cause of symptoms, so we did not take any chance. So we closed the fistula and then we did the thing. And as you said, it could close, but like now again we are facing a problem with the internal iliac artery being occluded. You can see it's faintly filling. So the same thing could happen, the vein could fill the artery. So that's the reason why we did it. And your another question was?
Regarding the surgical intervention, like...
Yeah, we considered surgical intervention, but we felt that he was frail and we felt that we could do it endovascularly.
Truly speaking, it doesn't come under the definition of heart failure. It is IVC obstruction rather than heart failure.
So ma'am, in the regular follow-up, how frequently now would you be using which imaging and?
We following up with CT. So 3 months CT is also showing faint opacification, which we plan to close. Okay. After that, I think once a year or...
yeah, ma'am, closing the AV fistula was the right thing. I think it was coming from that sac and it was quite away. Even after putting that graft, it wouldn't have closed immediately. It would have taken much time.
Thank you.
I don't think there was any need for ASD device. The simple oversizing, as Satyamurthy was mentioning, oversizing the graft could have avoided ASD device. Anyway, the end result is very good. Now, how do you prevent these endo leaks? You know, we are least bothered about the internal iliac arteries. You know, if you have PPH, postpartum hemorrhage, the gynecologists, they occlude both the internal and they do develop collaterals. So what will happen? Either the sac will shrink in size, sac will remain stable in size, or sac will enlarge in size. So follow-up CT scan is definitely not 2 weeks, at 6 months, 1 year down the line. Suppose the sac is now enlarged. Instead of coming down, it is because of the type endoleak 1 or 2, the sac is enlarged. What will be your plan now?
We thought we had 2 options we were thinking. We'll puncture the aneurysm and then enter the iliac or close the
come out.
and
Thank
come
you.
out. That's
Thank
what
you.
we thought.
I think the addition of that AV fistula indeed, kind of complicated. But of course, I think that must have contributed to some kind of high cardiac output state as well, and maybe, mimicked the presentation of this patient. Any comments or questions from the audience? So, ma'am, how do you decide, to the panel, the device which is to be chosen? There's so many, like she said, the cerebral. So a question from someone who is non-endovascular, how would you kind of simplify it for the audience, the kind of device that we can,
There are two types of device. One is self-expanding, where the device size is fixed. Second is balloon expanding. So balloon expanding, you can make it 8 to 12 millimeter. You can take 8, you can make it 12, 14, 15, depending on the final size of the balloon. The CT scan, basically CT scan will give you the answer, as she has mentioned, like aortic aneurysm. Everything is basically the metrics are determined by CT scan, pre and post.
Right. So I think it's been a very interesting discussion. If we do not have any comments and questions further, a big round of applause for Dr. Sujata. It's indeed been a great session. And as Dr. Sarita has labeled it, the eminent session and learning from the masters. Thanks to all the masters for the great experiences. Thank you very much. I think we can join in for a photograph. I would request all the speakers to please join us on the podium.
Thank you so much. Thank you to all the chairpersons, expert panel and the speakers, the moderators. Requesting all to please collect the mementos. I request Dr. Rupa to do the honors. Can we have a big round of applause for the experts here? Moving to the next topic on the agenda, a dynamic session focusing on sharing practical insights, innovative approaches, and real-world experience that help push boundaries and advance clinical practices. School of Rock, Breaking the Barrier. To chair this session, I invite Dr. Praveen Chandra, Dr. Satyendra Tiwari, Dr. Stephen Herb, Dr. Anupam Goyal, requesting the panel expert Dr. Preeti Gupta, Dr. Monica Javanjal, Dr. Sumit Bhatnagar, Dr. Seema Ajay Naksani, Dr. Martha Kuzello to join the stage. I request Dr. Sarita Rao to moderate this session. Over to you, ma'am.
Yes, that is also on OCT. Okay. These are high-risk plaques on CT scan.
So welcome everybody to the School of Rock session, Breaking the Barrier. I welcome all my esteemed chairs and experts for this session. And we are going to start this session, the very interesting session by Dr. P.K. Hazra. And he is going to be giving the spotlight lecture on When I See Rock, I Orbit.
When I see rock, I'm in orbit. So in my hospital, like Sarita's, we have everything, orbit, orbital, rotor, laser, IVL, etc. Can I have my first slide?
Technical team, can you have Dr. P.K. Hazra's slides, please, on?
So if you're really contemplating to tackle calcium, my sincere request for everybody who is starting their career to have imaging in your lab, or CT scan at least. The latest is photon counting CT scan. But once you see the rock, you must be prepared that you need some kind of device. So my talk is on orbital, So what are the advantages of having orbital in your lab? The setup time is very short. Time consumed to bulk these type of calcified lesion is little longer than your rota. Rota is just like a go and come back sometimes. And distal target sometimes very difficult to tackle with rota, but it's possible with IVL laser and orbital. Slow flow phenomena is less. Pacing wear is not required. The orbital wear is very user friendly, like BMW wear, and tip load is 1.4 gram. Wear maneuver is very easy, and that same wear can be used for your IVAs or OCTs or your balloon. Wear kink is very unusual, and one size fits all. That means you take out one orbital bar that can suffice up to 4 millimeter of left main. Unlike a rota or IVL, you have to take a differential size of the rota bar from 1.25 to 1.5, 1.75 to 2.12, etc. It can go backward and forward. Suppose you have ostial lesion, you can enter, but you cannot come out with the rota. You can get a stuck rota. But those phenomena are not seen because you can come out backwardly. 6-pin guide is good enough for most of the laser and orbital. Visibility little poor. Now, unlike rota, you can't see the speed drop. What you have to judge by your manual feeling, mechanical feeling, and some noise, the change of pitch. Very safe. Anybody sitting here after seeing 2-3 orbital, you can start your orbital program like rota. Same with the IVL. Now, this is not meant for very severe medial calcification. It can work under expanded stent, and calcification does not work. IS calcification may work. Be very careful. CTO calcifications may work. STEMI calcification only after removing the thumb, because that can pulverize and can cause slow flow and no flow. Non-crossable gears, like if you're not able to cross the lesion by microcatheter or a simple balloon, your rota or your orbital or IVL may not go, pre-dilate and go. Cost is little lesser than laser and IVL nowadays. And half orbital. Suppose you're not able to cross the lesions, either by rota or by orbital, you can stop there, like doing half orbital or half laser or half rota. Still it works. Gear directions is always elliptical, and the volume reduction depends on the motion. Slower you go, better you get. Now, if you have a smaller size of the lumen, less than 2.5 millimeters square to start with, you get the best reduction or best outcome from orbital. If you start with more than 2.5 millimeters square, you get less. Venous graft are contraindicated. What are the trials, evidences? You have only one trial. Eclipse is disappointing, but I'll tell you what are the limitations of Eclipse trial. You have many trial on rotacart, plenty of trials on IVL, and plethora of IVL, which can deliver up to 200 atmospheric pressure. Now, doing rota IVL laser is kind of macho woman feeling or macho man feeling, just like doing a retrograde PCI, TAVR, mitra clip. It's not such a feeling when doing the calcifications just by a balloon. You won't feel like Sarita Rao or boss sitting or madam sitting here that you have done something really good until unless you use this kind of device. So the macho feeling definitely comes with this kind of device, but be very careful because it can produce a lot of complications like perforations. Reusability, only laser in Indian. Those who are Japanese and American, European don't listen to this. The laser can be reused and sometimes free of cost. Debulking, etc. is possible. Fatigue, like if you are doing orbital from 3 vessels to 4 vessels, branches, etc. Remember, the diamond there will be rota fatigue or orbital fatigue. Size 2.5 to 4 millimeter, and if you go from 80 to 120,000, you can tackle a bigger size. But remember, if you used 120 at bend, that can produce a lot of complications. And the last applications of orbital will be to take out the rota, stuck rota. So there is a case in WCC2025, nothing worked. The rota can be rescued, the stuck rota, by an orbital. Sometimes it is a kind of off-label indications. So eclipse trial, there are a lot of good and bad things about eclipse. Rota has not disappeared, orbital has not disappeared, will not disappear, because sometimes it's very, very useful tool where the balloon do not work. There are a lot of crossovers and there are a lot of criticisms. So here is a case, you can see calcium. You can take out anything and everything. The most important for tackling calcium is the support, the guiding support, good support. You can see calcium on angiogram. This is orbital initially 80,000, did not cross distally, then you use the Dynaglide, slowly cross, then you can go to 120 or 80,000 depending on your skill and the comfort level. And once you're not happy with your orbital, you can use a cutting balloon. You can test the water by simple compliant balloon. If the compliant balloon is not showing dog boning, then you can go ahead with your stent. Nowadays, we do not bother about the stent diameter. We bother about the stent length. Now, Nagomi 2.75 can go up to 4.5. So, smaller the size of the stent does not matter with the modern stent, only preparations and the final MLA, which can be achieved further by imaging and bigger size of the balloon. So, stent's diameter is not important, stent length, normal to normal is important. That can be achieved only by imaging. It is a class 1 indications. I'll just finish in 30 seconds. So OCT a must because of final MLA, nodule protrusions, tissue protrusion, the malapposition. But the proof of the pudding is the MLA. Nothing else matters in this world. You can achieve those things by IVUS, but it's always beautiful to see beautiful women in beautiful color sarees or lehengas rather than black and white shirt, and black and white shirt of men. So we could debulk, we could modify, then you can use coated balloon and send, it is your choice. So ladies and gentlemen, there are a lot of devices, Indian devices will come in terms of plaque modifications, especially balloon-based IVL balloons. So macho doctor, the macho balloon. The macho balloon is now can reach up to 100 atmosphere. 100 atmosphere. OPN is 35. The macho balloon presented in TCT. Carbon material can go up to. My last slide. That's my last slide. Whether I can play. So I want to finish that orbital is very handy, and yeah. Play this slide. So friends, all these devices are quite handy and these are costly and produce complications. So don't try at home. It's not like a kid's toy. Get trained, supervised, see something, see some cases under your boss's guidance and then apply in the human beings. Sometimes, these things are people can have a choice. You can always, you have to put a little bit of extra dollar to have your Pepsi rather than going for the Coke. Thank you.
Thank you, Dr. Hazra, for that wonderful presentation. So we do know that orbit is actually very handy. It's very safe even for the early learners, and it's 6 French compatible. The wiper wire is very easy to use. The particulate is very small. A lot of positive things whenever we use orbital. My question to you, Dr. Hazra, is when do you not like to use orbital atherectomy?
When there's a lot of calcifications with a lot of thrombus, and you have already screwed the vessel by doing a balloon angioplasty, you have to produce a lot of dissections. Now you want to do rota or orbital. These are not the cases for orbital. So pre-decide. You can use IVL now. You can use laser because your wire is still there, but not now. If you have the IVL is king of corners and queen of corners and king of posterior. Posterior lesions and tortuous lesions, IVL is better and magnetic balloon is better. So if you have calcification at the bend, lot of tortuosity is not very ideal. Only if you have like high extension catheter, especially in Europe, if you have a large liquid system which has got best, largest internal diameter, go as near as possible, or you can cross with guide extension catheter, then pass the orbital distally and come and back rather than forward cutting. So that will produce a lot of application like perforation.
Yes, Dr. You wanted to ask.
Right. So venous graft is another contraindication. So if you have done orbital, lot of spasm will be there. If you do laser, immediately there will be heat, a lot of spasm will be there. So a lot of nitro has to be given, unlike your IVL and rota. Now, sir, do not see the distal vein. After, you have to make sure that your wire is interluminal. So once you are sure that your wire is interluminal, you can do anything. You can go for this cocktail in the distal vessel by puncturing simple and best economic cocktail delivery to the distal bed is just puncture 2.2 millimeter balloon, 1.5 millimeter balloon, and inject with your nicorandil, adrenaline, nitropris, whatever you want. And next best is your aspiration. Sometimes there are a lot of plugging distally, so you can use penumbra, thrombosuctions, and ultimately the imaging. The imaging shows that there is a dissected plaque which is stopping the flow. You have to do the balloon dilatation. So a lot of things can be done.
Dr. Hasra, you're obviously an expert in all those devices. I would like to ask you, if you need to restrict yourself to just one of those, which would be the one?
Look, if you go by the Eclipse trial, both are good. But if I'm just beginning here as a calcium specialist, I use IVL.
Sir, I'd like to know your take after the publication of Eclipse trial, which showed no advantage of orbital or a simple LED balloon at high pressure in a Eclipse trial, which was
Eclipse trial. So Eclipse trial, Eclipse trial, unfortunately, a negative trial. It took 6 years to complete. In 6 years in America, there will be 1.5 president. One president will go, the another president will come, so another philosophy, another principle. It took a lot of time to complete this. Now, orbital, it is a tool for bed preparation. The stent thrombosis rate in Eclipse is 1.2%, in balloon 0.8%. So it's quite surprised why after having the calcium preparations. So what has happened in Eclipse trial, because of the long duration, there are many operators, they do not know how to apply orbital. Second, the orbital has also improved, device has also improved. Your imaging has also improved in last 6 years. In America, the penetration of imaging, in Europe, the penetration of imaging has improved. Unlike Japan, if you do imaging, you get paid. In US and America and India, you don't get extra payment. So imaging has improved, we understand better now. Now 120,000 speed was used frequently in Eclipse trial. Now we know 80,000 is good enough.
Thank you.
Thank you, Dr. Hazra, for that wonderful presentation. We would now like to invite Dr. Annapurna Kalia for her talk on I Shock the Rock.
Good morning, respected chairpersons, moderators and my dear friends. At the outset, I would like to thank Dr. Sarita Rao for inviting me to the conference WCC 2026. And today my job has been made very simple by Dr. Hazrat, called IVL as Queen and King of Ostium. Also, he said it's any calcium debulking modality, IVL should be the first one for the beginner. So now coming to when about calcific lesions, there are clinical, unmet needs. First of all, coronary calcium prevents safe and predictable PCI, because we know that these calcific vessels are very prone to perforations and dissections. Secondly, they we may not be able to implant the stent. So stent tracking also is a very big problem when we have calcific lesions. Thirdly, it prevents stent expansion. Stent expansion does when we are doing angioplasty, the stent malapposition or under expansion, which will lead to short-term stent thrombosis or long-term increased MACE rates. Also, there are some limitations with the pre-existing calcium debulking modality we have been using. The NC balloons or OPN, high pressure OPN NC balloons, there is high risk of perforations. The balloon would give more pressure to the healthy side, which will lead to perforation of the healthy side. That's not one. Secondly, when we're talking orbital or even rotational, you cannot save the side branch. So if you have lesion in the side branch, it will be a big problem with rotation. Also, rotational atherectomy, taking it down at the tortuous vessels is a big problem. Small vessels is a problem. So whatever problems are there with the modalities, we are much more safe to handle these calcific coronaries with IVL. Now, IVL is simple to use. We do not require nitrogen or any other solutions to debulk or basically modify the calcium. So now, what are the principles on IVL works? All of us know there are two emitters which create electrical sparks, which create vapors, and with the sonic pressure waves are created, and these lead to cracking. So these are important of IVL balloon. One is compression, the refractory waves which go into the calcium. Secondly, there is a shearing stress which when the sonic calcium, and third, the refractory waves, so the reflecting waves. So the ongoing waves and the reflective waves, the summation waves cause a lot of cracking in the calcium, and the squeezing effect. One wave going through the calcium, other waves around the calcium will summit and cause more calcium fractures. Two things we need to remember balloon, that the maximum power lies perpendicular to the emitters. So whenever we are debulking, please choose on stent boost the maximum calcific lesion and keep your emitters there. And very importantly, emitters are not what you see the edge of the balloons you have radiopaque markers. Proximal marker is 2 millimeters and distal marker is 4 millimeters away from the emitter. So whenever we are tackling the longer lesion, come back by 2 millimeters. Thereby there won't be any geographical miss. Secondly, prepare the balloon very well. If you say, many of you might say that there is a perforation of the IVL balloons, rupture of the IVL balloons. So why this happens? Because we do not prepare the balloons well. If there is air in the balloon, this will give dry shocks. It will be inefficacious. Secondly, it will lead to the rupture of the balloon. So it is very important to prepare these balloons very well. Third most important thing when we are doing IVL balloon, correct size of the balloon is very important. If you use a smaller size of balloon, there won't be efficient therapy delivery to the other wall. You can see in this picture, the above wall, there is no apposition to the wall. It is opposed to the MLAs. So do not choose the size of the IVL by MLAs, choose it by the size of the vessel for the better efficacy. Now when we are tackling with the bifurcation lesion, calcific lesion, choose the balloon as per the proximal. Now all of us are used to choosing stents or balloons as per the distal diameter of vessel, right? Diameter of the vessel. But here you can use proximal diameter of the vessel and go up to only 2 millimeters of mercury, not 4 millimeters mercury, pressure. This was a very beautiful paper published by Dr. Anirbad Chaudhary. He showed that excellent efficacy with larger balloon and smaller pressure. You can see here, you can beautifully modify the calcific nodule. When we are talking about calcific nodule, again, if you take 1:1, and you can see calcific nodule is eccentric phenomena. It is not concentric. So what will happen, you can see the lower one, actually when we need to break the calcium, you have to hit at the base of the calcium, because there is a plate of the calcium above which there is a nodule. Do not try to rupture the tip of the nodule, because it's not the just tip of the iceberg. Whatever lies below is more important for debulking the calcium, extracting the calcium. So this is a very famous pillowing effect when we are doing with the calcific nodule. So take a larger size balloon, maybe 0.5, nodule documented on imaging, and go 2 millimeters of mercury and come back slowly. By the pillowing effect, you will be able to crack the calcium. Now, what is the evidence? I'm talking about Empower CAD trial. We know the woman, this was the only all-women trial which was recently conducted, and very good trial, because we know usually women are elderly, they have heavily calcific vessels, small vessels. So 399 patients, 499 lesions. Primary safety point was, a composite of cardiac death, MI, and TVMI, target vessel myocardial infarction over 3 days. So these were the results. Cardiac death 1%, MI rate was initially high, 10.6, because they went by the SKY criteria, where there was enzyme release, but these patients were asymptomatic, and I was only 1.3. So it was a very safe modality to be used. In high risk, and this trial included high risk patients. So this is one of the trials which showed IVL in high risk patients and efficacy also. Another trial, Bali, 200 patients. In this trial, they compared IVL with conventional balloons, coating balloons, and high pressure balloons. And primary endpoint was little different: procedural failure, that is inability to take the stent down, and OCT, residual stenosis. You can see both the places it fared better. IVL fared better. Primary endpoint 35.4 versus 50%, 51%, and residual area stenosis was more with conventional versus with IVL balloon. And target vessel failure was also less with IVL compared to conventional strategies. And you can see the MLAs which we get at the end of the procedure were 0.8 millimeter square more IVL compared to this thing. So I'll just move to one of my cases, antral infarct, basically delayed presentation, very tortuous, routinely pre-dilated. This was at 10 o'clock in the night, and what happened was the ostial diagonal, which was very tightly. So I decided just use cutting balloon and did drug-eluting balloon to the LAD lesion, because there was very good flow, and this was the result. I got the result in the LAD. TIMI grade 3 flow in a MI with, I didn't want to touch that diagonal ostium because it is heavily. I did OCT, which showed the calcific nodule at the ostium, and it was a very big diagonal. I didn't want to lose it. So I planned to stage the procedure. You can see very tight calcific nodule, and then I was unable to do that. So I had to use guide extension. As I mentioned to you, use stent boost to assess the calcium, did IVL and did DEB. So this is a DEB in bifurcation, in both the vessels, and the patient is doing fine for last 3 months. Another case, ostial left main. As Sir said, for ostium, it's a king. Ostial left main, it was a very elderly patient, aortic aneurysm, very complex case. Ostial calcific nodule mid LAD, there is a constant eccentric calcium in the proximal LAD. So prepared lesion, you can see there was an indentation, used IVL 3.5 by 12, and then you can see the area to 6. Then did stenting and PART, and very good result. So this was I got MSAs of almost 16, the left main ostium, which were 3 to begin with. And the last case, CKD patient, female on calcific AD diagonal bifurcation, So this was a hybrid procedure, wired both, did depth to the side branch, did IVL, and there was, you can see the guidance was there, so had to put 2 stents and proximal LAD, and you can see the final result. I did this CT guided, and you can see very good MSS. So last slide is take home message. Not all calcium is the same. You must use right tool for the right lesion. Safety and simplicity with IVL is always there, and there won't be any slow flow distal embolization. Imaging guided strategies have to be used in all the calcific lesions, as Dr. Hazra also emphasized, because that is how we'll come to know what type of calcium is and which tool we need to use. And optimal stent preparation equals to optimal stent expansion. So adequate calcium modification with IVL significantly improves deliverability, expansion, and reducing the risk of stent elevation. So choose right calcium modifications tool. Debulk when you must, fracture when you can. Thank you.
Thank you, Dr. Kalia, for that wonderful presentation on shockwave lithotripsy. And indeed, it is a very safe tool. The only drawback is that sometimes it does not cross. So, but where it crosses, it usually does the job very well. And as you have shown that, especially when we're thinking about using a DCP in calcified lesions, it's much easier to use the shock wave versus the rota or the orbital. So great indications and great cases. We'll take comments and questions from our chairpersons and panelists.
Yes, sir.
A lot of Indian products are coming up in India Live. Vishal is sitting here, will be displayed. So how confident
NC and, plain NC balloons, cutting balloons are not useful. See, I also use lot of cutting balloons, especially when we are doing nowadays DEB cases with mild calcium, just create cracks and do DEB. But when it comes to deep calcium nodules, the OPN will not help you. In fact, it will give rise to more of, perforation and the risk of perforation. OPN is good when you have instant calcification. De novo calcification, ISR. ISR calcification, there still you can use, because that will be great, because you are protected. There is a stent outside. But then victory trial, usually actually the subset of the patient that they enrolled was a low risk patients, which otherwise also, even if you don't use IVL, all the cases could have been done with OPNNC and cutting balloons.
They chose patients based on OCT criteria and supposedly moderate to severe calcification, but yeah, practically everyone prefers IVL over OPN for the fear of perforation, I guess.
Thank you.
So I think you hit the nail on the head when you said with OPN we generally go very high pressures, and with IVL you're doing it at a normal pressure. So there's always the fear that when you're going higher pressures with the OPN, there would be chances, even though for the fact that the OPN is actually a twin layer technology and it doesn't really go beyond the size that it is meant to, and it can withstand high pressures, but still when we go 35, 40, there are risks.
Yeah, they preferably sized it 0.5 mm smaller than the vessel size on the imaging.
I think whatever you do for calcified lesions, whatever devices that Dr. Hazra has shown, without cutting balloon, especially cutting balloon, one cannot move forward. And surprising thing is that even young patients less than 40 years of age, comes with first episode, may have a calcified arteries. Even women also have, young women have. So a lot of our younger population have come with severe calcified lesions. What is your opinion about Dr. Hazra?
Oh, I think it should be directed to the speaker anyway.
Yeah.
So in one lab, you should have everything impossible. You cannot get away from the balloon. Balloon is the basic of everything. Now, if your OPN balloon does not work, so what do? You give up the case to surgeon, you produce nasty dissections. So these are the cases where you need to have additional tool, and 30% of cases you need 2 tools. And you will be macho man, macho superman if you can do laser plus IVL, rota plus IVL, orbital plus IVL, roller coaster trial. So OPN balloon, some lesions are excellently opened. Stent regrets, stent under expansion. Suppose you have put a stent after orbital and it does not open. IVL and OPN balloon or high pressure balloon will work. So every device had its own place for, especially in young, these are more fibrotic, some may be calcific nodule in Indian patients, diabetics, CKD, smokers, drug addicts, they can have a lot of calciums. So imaging, you can do image before PCI, and on the table you should have at least one imaging. And the best imaging, though it's a controversial, 20 Hz Philips. Just 20 Hz Philips is good enough, because there are a lot of mental barrier to use these motorized OCTs, motorized IVs, after IVL, after stent, after balloon dilatation. So 4 or 5 IVs is really painful in private sectors. So those mental barriers can be overcome just by going your Philips 20 Hz, plug and play, 30-second job.
Thank you, Dr. Kalia, and thank you, Dr. Hazra and the expert panel. And yes, combination therapy is required many a times, and it's very important when we are dealing with this kind of cases that the lab should be equipped with all of this. And balloon-based therapies like cutting balloon are typically, in our country, we reuse a lot. So very easy to keep in our labs and goes a long way in treating calcium. Thank you, Dr. Kalia. We'll go to our next speaker. We'd like to invite Dr. Ritu Bhatia to speak about Rota Breaks the Rock.
Good morning, dear friends. So we are talking about calcium today, and as we discussed, calcium artery, coronary artery calcification is becoming very common. 25 to 30% of our patients in cath lab have significant calcification. And with aging population, more of diabetic patients, more of CKD patients we are catering to, this number is going to increase. And of course, with calcification, the cardiovascular outcomes are worse. The stent expansion is not well, it's asymmetric, and we always end up having MACE afterwards. So we have to prepare the bed well. Now, this is the armamentarium we have right now, like started with Rota 4 decades back. We came to IVL, then orbital, and then of course ELCA. I will focus on the comparative trials between each modality, though we don't have many numbers in those trials, but they do emphasize on one or two USPs of each modality. In most cases, when we talk of Rota, a single bar, 1.5 does the job. It's sufficient to smoothen out the vessel lumen and disrupt the intravascular calcium rings, enabling passage of, like IVL and other modalities, and dilatation of balloons and implantation of stents. We all know the indications, contraindications and guideline. Let's jump to the first trial, Prepare Calc trial, where rotational atherectomy was compared with modified balloons. Modified balloons were scoring balloons and cutting balloons. OPN was not a part of that. Conducted in Germany, 200 patients enrolled from 14 to 2017, 1:1. There was a significant reduction in TLR in both the groups, but RA had 3% TLR, but vis-a-vis 12% in the modified balloon. Osteolegends did not do well in either strategy. Late lumen loss was much less in longer lesions. So RA did much better in longer lesions. Balloons did reasonably well in shorter lesions. Dissection was much lesser in RA group, especially happened, as Dr. Hazra said, when RA was used in bailout cases. So when you want to use rotational atherectomy, it should always be like upfront. You do RA first and then do the ballooning, rather going getting stuck with balloon, creating dissections and a bailout RA. And in this trial, there was more than 10% cases with LMC. Coming to Dairo RCT, head-to-head trial, Japan-based, Dr. Okamoto was the PI. 100 patients, 50-50 in each arm. There was a significant greater stent expansion in RA group versus orbital. Significant greater maximal tissue modification in RA group. In hospital, outcomes were good in both the groups and complications were very less. Eclipse trial, we have already touched upon it, did not work in favor of orbital, though the OA was compared with conventional angiography. Many limitations, again it was not very critical group, like average stenosis was 65%, but anyways, and it did not work. As I said, routine use of OA did not improve MSA or reduce target vessel failure at 1 year compared to conventional balloons. Now, this is a CCA, coronary calcification study, where we had a comparison between IVL and Rota. Actually, if you see, the procedural success was 96% in RA vis-a-vis 81% in IVL group. Outcomes were comparable. Now, cases where Rota is better or sole option. We were talking about osteolegends, aorto-osteolegends, though both do well, IVL does a fabulous job, but when we compare OA with RA, RA has an upfront cutting mechanism, so it's easier to get RA in, but for OA, the active actually grinding thing is 6.5 millimeter behind the tip. So it's difficult to, if it is a real osteal tight stenosis, it is difficult to get orbital in and then cut back, and it's much easier for RA. CTO lesions, you cannot use orbital. Balloon uncrossable lesion, Rota is definitely better, and second choice being ELCA, of course. ISR and ELCA again is a second choice. Angulated lesions, Both have problems, orbital more, but rota can also be problematic. Large vessels, more than 4, we can't use orbital, of course. Need for combination therapy, all of us had been using with RA all kinds of cutting balloons, scoring balloons afterwards. And I think there's a talk on combination therapy afterwards, so I'll not spend much time. Of course, rota cut trial talked in favor of that. Rota tripsy, we all know, rota followed by IVL, creating a space for IVL to enter, gives us a very good lumen. OCT revealed that plaque modification in RA with RA is typically a polished, concave and round surface. When clubbed with IVL, you get better cuts and better stent expansion. And we know IVL works very good for deeper calcium. The superficial part is done by RA. You can get IVL in. Razor, where RA is combined with ELCA, can actually be very helpful when rota wire cannot cross. And of course, you can have DCBs also after that. The work done by RA is much more predictable, more concentric. You get better eccentricity index, you get better expansion of the stent if RA is used with IVL, not vis-a-vis, with IVL. Special scenarios, we are talking about bifurcation lesions. Buddy wire has been used by Mitomo et al. In RA cases. Burr size, larger size doesn't help much. We all know that. Rotate registry, dedicated LMCA cases, rotational atherectomy did very well. So coming to my case, this is a 70-year-old female, ejection fraction 40%, PTCA2 LAD was done in the past, but details were not available. She had ISR presented with, as I said, unstable angina, ostial circ very tight and viable. Both the territories of LAD and circ were viable. Now, deep calcium, skinny, long LAD, ISR. The options with me were rota, of course, first option. Orbital, ISR, I did not want to use it. IVL, for such skinny, when you have dense calcium throughout, 2/3 of LAD, you cannot go in with IVL. And if at all you happen to reach there, the size discrepancy, if you have to start from left main to distal LAD, you have to use 2 sizes of IVL. Then 80 pulses might not suffice. 120 was not available at that time. Cutting balloon again could do a good job, but cutting balloon again, tracking it down and might not do the full job. So in summary, 1986 rotational atherectomy was started. It has survived 4 decades. It has survived all developments of newer balloon, OPN, cutting, scoring, OA and IVL, though a little cumbersome, but a predictable, time-tested modality. Thank you.
Thank you, Dr. Ritu, for that wonderful talk and for the punchline that rotational has survived everything. And yes, in all our labs, when we are stuck, it's rota to the rescue. So we'll take some comments and questions from our chairs and panels.
Well, there was a time when rota was really out. That was the time when I learned it, like 1997. But then with the drug-eluting stents and now with the drug-eluting balloon, we have really a long-lasting result if you do good lesion preparation. And I wanted to ask you also, the shortcut trial was done, and actually the basic of this was rota. We saw the group that had rota done. They did well both in IVL and in the cutting balloon. Are you using this approach? And I wanted to ask you also, are you also using rota in a low frequency way to achieve more debulking?
So yes, the combination therapy we were talking about, rota with cutting balloon, rota with IVL. We have used both. They do a fabulous job. Rota does the work on superficial calcium and IVL does the work for the deeper calcium. Cutting balloon, again, actually in most of my cases, even after doing rota, I have been using cutting balloon in most of my cases, because I feel only doing rota really doesn't give you that good stent expansion, probably because we are sticking to only one bar. And we are cutting from distal or mid vessel coming up to left main the size 1.5 doesn't really suffice for left main. So you have to combine it with some more modality. So yes, of course, we have been using that. Low frequency, not really. I mean, I don't have any personal experience on that.
I think if you go back to the history, 1987, two devices were approved by FDA. One was laser, second is rota. Laser has come back, rota is still doing its beauty. And much before the stent was approved. So definitely rota is the workhorse for all types of lesions. The only thing our teachers, our seniors have created so much of fear of using rota that you have to do 30 rota before you can touch the machine, touch the wear. You can get a stuck rota, patient will die. Nowadays, you know, everybody knows how to use rota. So with time, we have evolved. Our juniors now can do rota, laser in India. I'm sure students, they can do rota. So my question to you, rota can also be used for, a TAVR. So there was a case in TCT last year. The TAVR valve was so thick and calcified, they could not do vasilica or any plaque modifications of the TAVR valve, valve in valve. So this bulky, the previous TAVR got calcified. So what they did, they put 1.75 rota on the valve. Okay. So that penetrated the valve. So through that hole, they could pass the wire and do the electrosurgery. So my question to you, you have two speeds, low speed, high speed. You have two wires. One is regular wire, one is extra support wire. Do you think the amount of debulking will be different using regular wire with high speed versus extra support wire with low speed? Is there any data?
I'm not sure about the data, but I think with this newer kind of Rota Pro system, we usually stick to 150, 155 or 160 speed RPMs. I usually am not very comfortable going very high speed. Yes, during the polishing run, I might increase it, but I very sparingly use 1.7. I mean, upgrading the Rota bar, it's 99% of the times it's 1.5.
Okay, so there is a publication in Euro Intervention last month. If you use the regular wire with high speed, the cutting is more. If you use low speed with extra support, the cutting is more than, and also safety part. So there will be some differences in how to use extra support in where you cannot produce the enough debulking. Suppose you have done regular wear and high speed, your balloon is not going, your stent is not going, then you take out extra support wear, go low pressure, or upsize the. So what are the conditions where the rota fails? When the rota fails, what are the situations when the rota fails?
Rota fails.
Rota failure, what are the things you can do in rota failures?
Rota failures is like very angulated lesion where you wouldn't want to do it, or you meant when rota doesn't work?
It's not crossing.
Sir, ma'am, nice question. Very excellent question. I would like to opt that question on Madam's behalf with your due permission, ma'am.
Sure.
So, I am Dr. Monica from KMC Manipal. Now, we are almost completing 200 laser cases for last 2 years. And me and Dr. Tom are heading that laser angioplastics. So, what happens is when the rota doesn't cross, it does happen. And when it doesn't cross, you still have laser. And you can combine rota and laser together.
That's the razor.
Even in the patients wherein you have done the rota, you take the stent across, but the stent is under expanded, you can use laser and expand the stent. So this is an additional use of laser wherein the stent under expansion, very, very bad under expansions, where dog boning is just not giving away, even with OPNs, you can use laser, soften the plaque, soften the tissue, do the NC balloon at 12 atmosphere or a 14 atmosphere.
So Sarita, rota failure tips and tricks.
So
she has mentioned laser.
So when we are saying rota failure, typically if you can't get the rota wire in, you can't use the rota. And that is when the role of laser comes in, because laser can be used over the workhorse wire. So when we are not able to get in, what we do is we take the laser to modify the cap,
Undersize,
and then usually it crosses.
Smaller size of bar, 1.75 to 1.5, 1.5 to 1.2.
Yes. We can all go into smaller burrs. And the other thing when rota also fails is two other conditions. When you have an extremely angulated, sometimes the rota doesn't go across it. In that case, we do a half rota. So we take the rota till
Half
the
rota.
turning.
What else?
And the other situation is when you don't have a favorable wire bias. Then sometimes you have debulked on the opposite side and you haven't. Therein comes the role of switching to an extra support wire, which Dr. Hazra was saying, which will change the wire bias.
What else?
And
Guide extension.
also
I'm
you
not
can-
taking your class. Anyway, yeah. Yes, ma'am.
This is Dr. Anita Balla, Professor CT Surgery from Hyderabad. I think you guys have forgotten there's something called CABG.
I was about to say that.
A room full of intervention cardiologists, Dr. Anita, they don't like CABG.
No, if it is so difficult, I think this should be a better option than,
Very right.
jeopardizing the thing. Because LMCA.
That's also a point.
Surgical
But
turn
yes,
down.
CABG.
Thank you so much, Dr. Ritu, for that
Excellent
wonderful
talk.
presentation and lovely discussions. Oh, yes. And so now we'll go to our next talk. Dr. Praveen Chandra has just arrived, and actually Dr. Chandra was supposed to present in the earlier session. The flight was delayed. So we'll have Dr. Praveen Chandra's talk right now. It's on ultra high risk PCI with total indigenous hardware.
So, Sarita has sent a special flight to bring Praveen here.
No,
We're
no.
so glad to have him.
No, actually, there was some disruption of flights today. So, please, I apologize for being a little late because my session was the previous one. But thank you very much for this accommodation. And today, now I'm going to discuss with you some MCS-assisted PCI or whatever you call it, ultra high risk PCI. So I'll be, kind of discussing few cases, and one of the cases where we used a new device, which I'm going to share with you. So can I have the presentation, please?
Very device.
Yeah.
That's
So,
the presentation.
presentation.
Praveen Chandra.
Got it? Yeah, okay. So in the meantime, let me ask you one question. How many of you use MCS-assisted PCI on a regular basis, like one in a month, or how many people do it here? Mechanical circulatory, there's only 1%, 2%, 3%. And on the ODM, 2, 3, 4 people. So, which means that, we are probably limited in many ways for using MCS-assisted PCI. Of course, everybody gets these high-risk patients, and everybody is managing these, extreme high-risk patients. But of course, one of the major limitations to start with, I must say, is the cost of this device. But certainly, we will discuss. Yeah, this one, yeah. Yeah, okay. Yeah, click this one. Yes. You got it. Okay. So yeah, here you are. Okay. So let me go through this quickly. We should not get too much late. And is it moving? Yeah. So basically what I'm going to discuss in this presentation today is why we should use mechanical circulatory support for these high-risk patients, and what is our program, how do we do it, what are the outcomes which you should expect, and some of the cases which I'm going to share with you, and also what are the complications and how do we prevent them. And of course, finally, we will discuss what are the final take-home messages on this. So with this, I will just tell you that these are the kind of patient profiles which we select for ultra-high risk or MCS-assisted PCI. LV dysfunction, severe multivessel disease, left main disease. Surgical ineligibility is also one of the major contributors, and that is why we do more cases, because we have more surgeons, they reject more cases, and we get more cases. So that is something which happens. And these are high syntax patients, hemodynamically unstable patients. And of course, what MCS does in them is, this is leading to active LV unloading, improving forward flow, and allows complete and meticulous revascularization, and also avoids procedural instability. When you're doing the procedure, you need as little disturbance as possible. So that is something, which happens with the use of MCS. So this is our overall experience, nearly 100 plus cases we have done, and the mean ejection fraction was 28%. And as you can see, almost 1/3 of these patients are either last remaining vessels, left main, unprotected left main, and also some patients we did on ECPella, which means combination of ECMO and Impella. So procedural success has been quite good, and we have been able to shift patients back to the ICU in large number of these cases. The in-lab mortality has been extremely negligible, nothing. And major complications, of course, we see, which I will discuss with you while the discussion is there. So how do we do it? So we, of course, we are, as interventional cardiologists, we have to be there, and the CT surgeons also, we keep standby. Sometimes we need a vascular support, and then the anesthesia team has to be there inside the cath lab, and also discussion has to happen before we actually take up this case with the entire team. And hybrid cath lab is not essential. We mostly now do it in our normal cath lab. The perfusion support is important, which we require. The anesthesia support and the readiness. This is also very important, that these patients, when you have done in the cath lab, they have to be taken care well in the ICU also, because this is half job done in the cath lab, half job is in the ICU. So that is something very important. Managing hemodynamics, managing fluid, etc. So all that is very, very important. So patient selection, I already told you that these are low ejection fraction patients, unprotected left main, surgical refusals, and how do we optimize it? So we have all these, these devices available in the lab, so it has to be there 24 hours. It is not that, you have a patient and you start ordering from somewhere, the device is coming. Then it doesn't work, especially in the cardiogenic shock patients. Then vascular ultrasound mapping is very, very important before you do these procedures, which we don't do in every case. For any intervention, we don't do a vascular access, most of the vascular ultrasound access, but in this, it is almost like 100% we do it. Then access planning is another very important thing. If there is calcification, etc., you better check it out, because many times we have seen that these patients also develop significant spasm of the femoral artery, and then the device gets stuck. It can lead to, dissections and many, many things, and the device can lead to ischemia, especially if you are keeping the device for a longer period of time. And of course, you have to get an informed consent from the patients and the family that this is a very high-risk procedure. So high-risk consent is very, very important, because the outcomes definitely will be initially, will be guarded. So how do we do it? The vascular access is ultrasound-guided micropuncture. We do a pre-closure technique using a ProGlide, and alternately axillary access can be done, but mostly we have been able to do femoral access. And then the devices which we use are the, either the Impella or the ECMO or the MyVAD, which is now going to be available very soon in our cath labs. And then heparinized PERS, ACT targets are very, very important here. We have to keep checking, and backup pacing if required we will do. So this is the safety bundle and checklist, which is very important. Again, as I said, that when you are doing this, and also availability of protamine in the cath lab for reversal and hemostasis plan if there is a bleeding complication, because one of the complication is vascular bleeding complication. So this is where we all started. This is the consensus document which was created a few years back, and here you can see that this is, on the basis of this, you can decide whether your patient needs it, or probably needs it, or definitely needs it. Based on this, you can decide. These are the clinical aspects and technical aspects of the patient. In the clinical, the hemodynamic status, the patient characteristics, and then of course the coronary anatomy based on the angiogram. You can decide whether your patient needs MCS support or not. Because many times people will say, oh, I used to do it and I never had a problem. But definitely, now you have a very, very objective way of defining that your patient needs it. Because many times patients will ask you, why do I need it? Because if he consults some other doctor, he'll say, oh, no, I'll try to do it. So you can say that this is how we decided to do it, and this is why you need it, because it is an expensive treatment. The cost of the device itself is about 5 times the cost of intervention. So this is the difference from the earlier, the other guidelines which are available, that here we have extended the syntax score to 32 rather than 22, and low hemoglobin excluded, and EF less than 25% is 22 points, and age more than 75 is 1 point. So advanced age is also important criteria. So this is our, as I already briefly told you already, that these are the cases which we did. High risk PCI 86, cardiogenic shock was there in 32, single surviving vessel is a large number of patients, and then complex multi-vessel PCI, again a large number of these patients. And many of these patients will be calcified vessels also, so you will need extra devices. So MCS is not the only thing you are doing many other things in these patients. And this is the way our program has grown, and as you can see, the complication rates have been quite satisfactory. So what is the evidence behind all this, what I'm talking today? The evidence is coming from these trials, which were primarily done with the Impella devices 2.5 and also then thereafter the 3.5 device. And these are the PROTECT 2 and PROTECT 3 trial, showing improved outcomes in terms of MACE, death, stroke, and MI and repeat revascularization. Then there was another significant improvement in mortality, which was seen in CABG ineligible patients. So those patients who were CABG ineligible, they did better compared to the, which means the more complex the situation is, the more advantage you are getting by using this device. And also, the completeness of revascularization, as you can see in this data, with reduced AKI, acute kidney injury is also very common in these patients, is also minimized. And also that very important aspect which came out from this was that if you use Impella upfront, it is better. If you use it bailout, because many times patients will say, or you will think that in case my patient becomes unstable, I'll use it. That is the time which is late. So you have to start upfront, and this is the difference you can see. The in-hospital mortality is so different, 4.4% versus 57%. So basically, start planning upfront and use it upfront, then only it is better. Then, as you see here also, pre-PCI usage is better than the post-PCI usage or during the PCI usage. Then, of course, it leads to 47% reduction in post-discharge MACE events also, and significant reduction in hypotensive events during the intervention, which is also very important, because that leads to finally the incidence of complex outcomes in these patients. So more complete revascularization, less acute kidney injury, and of course significant benefit in high-risk PCI when we use support of these MCS devices. So quickly taking to the cases, and this is one of the cases which is a post-bypass. So post-bypass is a very common situation which we deal with because they have complex disease, calcified disease, and this patient who had chronic liver disease, was having low ejection fraction, last remaining graft was this diseased vein graft to the RCA, and the only vessel which was native available was this circumflex, and the lima was not functioning at all. And as you can see, this circumflex is also not a very healthy vessel to handle, because you can expect so many issues when you are treating this OM, which is the only native vessel which is available. So what we do is, we have to do everything possible here, cutting balloon, shock wave, everything to treat this vessel. And as you can see, when you start doing this, these patients will develop hypotension. These patients may develop, arrhythmias. So to, take care of that, we pre-implanted the Impella in this patient and then went ahead with the procedure. We did shock waves, did cutting balloons, and thereafter, when this was done successfully, we thought, since the Impella is already there, let us treat the tightest portion in the vein graft also, which was there distally, and we did that, and the vein graft was also treated, patient did well. Again, 2 months later, patient had some symptoms, etc. We did an angiogram, and as you will see, this is the check angiogram, sorry. This is the, oh, it's gone down. Is it going automatically? What's happening? Okay, let me check. So, I'm sorry. This is, okay. So, yeah, this is the one. Okay. So, here you are. And you can see that this graft was also functioning very well, and this OM was also doing so well. This is 2 months down the line, and the patient was doing, and he's still doing fine. You know, it's few years now that this patient is doing fine. So sometimes, you know, these patients who also have, you know, bypass surgery in the past, as you see here, this is a bypass surgery which failed in 3 months. In 3 months, patients came with acute coronary syndrome, cardiogenic shock. He was put on a balloon pump, and we did an angiogram and discussed with the surgeons, would you like to do the redo surgery? They said there is no place, that's why the surgery failed, because it's so diffuse disease. And here you can see that what, you know, if you do anything, the patient is not going to fare so well. So this is kind of a very complex situation. So we discussed, we removed the balloon on the table, changed it with the impeller through the same axis, and thereafter we did this intervention using, you know, from the left main to the LAD, very calcified vessels, cutting balloon, shock wave, everything. And every time when we were dilating, we were seeing these hemodynamic collapse, but the impeller was, you know, kind of supporting it. And thereafter, we were able to treat this vessel, and the patient did quite well after that. And about 8 months later than that, he developed some restenosis in the left main, which we treated quite easily without a problem. So these are, you know, like situations where we can, now I'll quickly go on to the last case because I don't think we have that much time. So let me go through this one, which is interesting for all of you. And this is the device which we use, the new one. And this is again a very, you know, high-risk patient where we have to, you know, look at this angiogram. And yeah, so the only remaining vessel is LAD, which is so diffusely diseased, calcified. The patient is to start with in cardiogenic shock, lactates are 9. So what do we do? So we initially tried to stabilize this patient in the ICU. He was put on a balloon pump in the ICU itself straight away. And then he was on ventilator with multiple inotropes, which started reducing. His lactate improved to 1.34, started making some urine. So there was a renal issue also. So we said, okay, this is going to be an ultra low contrast PCI. This is going to be a, you know, very high risk PCI. So we decided to do it on an impeller. And here you can see that this is the LAD, which is quite badly diseased, which is the one we have to treat. So we use this device. This is the MyVAD device, which is again a microaxial pump with a flow of 4 liters per minute. And here you can see that this is how it gives the flow. As you increase the speed from P1 to P9, the flow increases to 3.7 to 4 liters per minute. So with that, then we did the imaging because we couldn't do any shot. No shot was given in this patient apart from the initial angiogram. No contrast. We did the IVUS imaging, and this was also the Star Beam IVUS, which is the new one. And then this is actually a combo device, which has both IVUS and OCT in the same device with these handles. And with this, we took this patient to do the IVUS first with the dual imaging catheter. And then we did the calcium debulking, did loratripsy, where we did a rota followed by a IVL, which was this new IVL catheter again. This is the Mason catheter, which is the IVL catheter. And we did the IVL in this entire length of the LAD, followed by, and we still thought that probably we'll have to dilate more. So we did a debulking more with this cutting balloon, Cutana. This is the new cutting balloon, the Cutana. And with that, once it was all done, then we use these mural stents, which are, you know, very extra glide stents, which are now available. The mural DES, where we put two stents. One was a tapering stent, distally, 3.5 to 2.5. This is a dedicated tapered stent, which was used distally. And then proximally, we use the mural stent. And with that, and final dilatations were done. And this is the final result. You can see this, actually this, unfortunately, this is running very fast. Actually, the patient was not having any tachycardia. So this was fine, and then we did the OCT. So this was the only run we took. This is the only run, only contrast which was given was 7 or 8 ml. With this, OCT was also done at the same time, and also we did the angiogram. So with that, we finished this case. So today, we have now newer devices, new iterations of these devices coming up. And in this case, we did everything was actually the metal devices which were available, and some of them are going to come very soon. So this is our outcome summary, that our success rate with the MCS support has been very good. In lab mortality is 0, and complications to watch for are vascular access complications, bleeding complications. This happens. Hemolysis is something which you have to look for in the ICU. And for that, we have to change the position of the catheter, echo-guided, check the hemoglobins, check plasma-free hemoglobins, LDH, and urine. As soon as you see red urine, the impella has to go out. Otherwise, the kidney is going to go. So that all is to be done. So with this, I'm at the end of my presentation, that we need MCS support. Definitely, most of us need it, but definitely we have to become more conversant and more convinced ourselves, and to the patient also. You have to do a lot of convincing. Then only it works, because mostly it is paid by the patients, and the cost today is quite high. So with this, I'll stop here. Thank you very much.
Thank you. Thank you, Dr. Chandra, for that wonderful presentation, and for that very enthralling case at the end, in which it was totally devices which are all made from India. And you use the MyVAD, you use the Katana, you use the Mason, you use the star beam imaging system with the dual imaging. And so basically, my question to you was, because you're an Impella user and now we have the MyVAD. So what was your, did you find any differences in using the MyVAD versus the Impella?
Very good question, that whether there is any difference or not. I mean, if you look at it, if you also saw the pictures, it looks almost the same. The axis size is also similar, and overall it works the same way. The controller is also similar, and it gives about 4 liters of flow. So it looks quite similar, quite the same way it functions. But definitely when we start using it more, especially if you keep it in the ICU for more than 24 hours, we will come to know more about the hemolysis or other effects of this device. Otherwise, upfront in the cath lab for a short time, 1 hour, no big difference.
Sir, in danger shock trial, there was very high incidence of vascular access complications. So what has been your experience regarding the vascular access? So vascular access complications are, as I already said, that is something to be, from the very beginning, you have to be careful. The first thing which you do is a puncture. The puncture, if the puncture is bad, if the vascular preparation is bad, then you are going to land into complications. So if you take care of that, do a ultrasound guided access, take a check shoot when you start inserting. And as I told you, I couldn't show everything. In one patient, very recently, we did, everything was looking fine, and suddenly we thought that there's some difficulty in the left side. When we were going from the left side, we did the puncture. The artery was big size, and immediately the artery went into spasm after that. And then we did on the right side the puncture. We thought that it is not responding to nitroglycerin. Patient is hypotensive. We did that again. That went into spasm. So you have to be a little careful, and so that is something which has to be kind of controlled from the very beginning. And also in the ICU, if you don't take care of these patients, it is going to be a mess. 1, bleeding. 2, ischemia. Ischemia of the legs has to be also monitored.
I think what you have shown, this is all high-risk procedures. So whatever you do, there's nothing to lose, because all this, and most important is the femoral puncture site. If you take care of these, then probably you are 50% of your job is done. Recently, we land up in, femoral down the line after 6 hours, then patients have serious leak from the site. and then you are nowhere.
Yeah.
So probably that is the crux of all these procedures.
Yeah, the whole team has to be streamlined with that. Because sometimes if somebody else is taking care of the patient in the ICU, he will not know why there is a thread coming off from that site, because it is a pro-glide thread. Somebody will try to snatch it out or something, you know. So everybody has to be mindful of all the aspects of this. Yeah.
So Impella is a beautiful, beautiful, beautiful device, and there's no question about it. You can do any high-risk PCI with no stress at all. That's what my experience, our experience has been. But sir, as you said, taking care in ICU is not easy.
Yeah.
So what I have done so far, whatever Impella cases I have done, I've done in disastrous cases like 7% EF, 6% EF, and surgical turn down, and then still viable territory. There we have used the Impella, and we have done the PCI. We kept the patient in the cath lab with all aseptic condition for 1 hour. We slowly tapered down from P9 to P2, and with the surgeon, we did not take the vascular access also. He was 100 kg man. So we called the surgeon for an access, and we closed the femorals with the open with surgeon, closed with surgeons, and closed in the cath lab. So what is your take on shifting the patient with Impella to ICU for 24 hours, or removing it in the cath lab whenever it is possible, within 2 hours, say?
Yeah. So in patients, there are 2 types of patients we treat with MCS support. One, which is a high-risk PCI, which means that the hemodynamics is okay to start with. He may have some hemodynamic disturbance during the procedure. So these are the patients where we take out the Impella on the table itself. But those patients who have cardiogenic shock up front, their PA pressures are high, their, the CPO is less, everything is going wrong, cardiac index is too low. So in these patients, we have to keep Impella for a longer period of time, and it all depends then based on the hemodynamics, because these patients will have a SWAN also 100%. So we monitor that, we see that if once the wedge pressures have come down, the CVP is in your range, like 810 or something, then only we start deploy. So the maximum time we have kept generally 5 to 6 days is a usual time, and many times we have kept patients on ECMO and Impella together. So that is another complicated situation where you have to then balance between the two. One is increasing the afterload, the other is reducing the afterload. So that is something which we have to control. And then the third thing is these patients are also many times on a CRRT or a SLED because they have renal failure. So all that complicated issues you have to manage in the ICU only. You cannot take out the Impella in these patients upfront in the cath labs. Only high-risk PCI you can take out in the cath lab. If the patient was fine during the procedure, he is hemodynamically stable, no arrhythmias happening continuously, it's okay.
Thank
Yeah,
you,
that
Dr.
VT
Chandra.
ablation was one indication, as you said.
So thank you, Dr. Chandra. And please join us on the panel. You're very right that it's an absolute team effort, and each patient is so individualized, and we have to pick and choose the patients in which we can remove it and the ones in which we have to keep them in the ICU. Many a times it's very difficult to wean them off it. So we have a live case waiting, so we'll quickly move to our next talk of this session by Dr. Zakia Khan. Friends, not foes, combination therapy is the way to go.
Good afternoon, friends. I think we are in very good times wherein we have best of devices to deal with rock and best of the devices to image them. And there will be times where you would realize that one device is not enough. Rather than saying that I am a IVL person, I'm a rota person, we should say I'm the patient's person. I want to do the best for my patient. So we know that coronary calcium is very nasty. 10 years back, many of the cases that were shown by sir would have gone to the surgeon. What coronary calcification does is causes stent under expansion, target lesion failure, target lesion revascularization rate increase, and many a times it so happens you are not able to deliver your devices. Forget even your imaging catheter, many times it could be difficult even to deliver a conventional wire. And severe coronary calcification is a special subset because patient subset is also difficult. These patients are sicker, these patients are elderly, many times octogenarian, they have more comorbidities, so they could be, the commonest comorbidity is CKD, diabetes, and multiple comorbidities together. Now, current calcium modification devices are either balloon-based, cutting, scoring, high-pressure balloon, or IVL. Atherectomy devices like orbital, rotational, and ELCA. Each has its different mechanism of action, which my previous friends have talked about in detail, and we know that the combination could be synergistic. For example, rotational atherectomy could cut superficial calcification. Combination of with IVL could deal with deep calcification. So combining them would be better. Starting with the first combination strategy is the rota cut strategy. Rota cut versus rota plus NC at 1 year. The studies have shown that TLRs are better with better MSAs, safe and efficacious. If you look at the TLR, it is 5.7% with conventional balloon versus 22% with the cutting balloon. This was all that was told about multiple trials, PREPARE-CAL, combo study, etc., except the trial by Dr. Sharma, who said that rota cut study did not show any superiority. Coming to rotatripsy, I'll start with a case. This is my 82-year-old female, long-standing diabetes, hypertension, CKD with a creatinine of 2.8, unstable angina, recurrent heart failure, coronary angio done after stabilization showed critical dominant LCX stenosis. Now, if you look at this lesion, it is at a bend in a diabetic patient, in a patient with CKD. To me, it looks like a site for a nodular calcium. So we were all prepared for dealing with this calcium. I could pass my wire, I could pass a NC balloon, but beyond that I could not pass anything. Even my IVUS could not cross. That's when I decided to go with I even attempted IVL through guide extension, could not cross. So took a rota, 1.5 bar. Could prepare the lesion. And then now, I said, now I must see what am I dealing with. And IVUS did show that there was a nodular calcium with a lot of fibrous tissue. And the lesion was not adequately prepared. That's when I decided to go ahead with, more like a nodular calcium will be better prepared with IVL. So took a IVL 3.5 and used almost 120 pulses. Following IVL, dilated with a balloon and then put in my 3.5 stent, post dilated with a 4. You can see a good, it's not playing. You can see a good MSA and stent expansion. This is the final result. So what did this combination do? So you can see that the heavy coronary calcium with irregular border was not allowing anything to pass through. What Rota did was created the space in the figure 2. You can see how Rota makes it a smoother area, and then IVL goes in and gives deep cuts and better expansion, and then finally you are able to expand your stent well and get good as MSA. So we can see this combination therapy has really helped the patient who was so sick. We can also combine shock wave with the orbital. I would recommend use of this combination in osteal lesions, nodular calciums, and when it is combined with deep calcium. This is just a literature case. You can just see that in the first two figures, the IVL, the orbital did some cuts, but eventually the nodular calcium was taken care by orbital shock. We have another modality of combination called razor, which would be used for non-crossable calcified lesions, may be better when faced with rock plus thrombus, degenerated vein grafts, uncrossable CTOs, calcified ISRs. Advantage that it can be delivered on a standard wire, and it creates channel for delivery of other devices. This is another figure from literature where a degenerated vein graft was treated by excimer laser. And you can see that in the figure D, the balloon was not able to expand. So IVL was used, there was still dog boning, then the IVL was used, and then you can see the vein graft has opened so beautifully. So when you look at this busy slide of, how are you going to modify calcium with multiple modalities, what you look at is the purple. Every purple is imaging. Remember that imaging really helps you to decide whether you need another device or not. Many times it so happens in severe calcification that your imaging catheter also does not pass. So that's when you use atherectomy devices, laser-like devices to create a channel so that you modify the lesion in some way and then image and look at the kind of calcium that you are dealing with and whether it is a deeper calcium, whether it will need further more devices like IVL. So in conclusion, combination therapy improves outcomes in heavily calcified coronary lesions, reduces TLR and TLF. However, when you use combination of devices, cost increases exponentially, which in a resource-derived, resource-limited country like ours can be a challenge for many of us. So, with due respect to my surgical colleagues, if such a patient comes and you can't afford multiple devices, I would refer the case to my surgical friend. If I feel that cost is a big issue and expertise is also important, if your setup does not have adequate expertise and equipment, then take the help of surgeon. Thank you.
Thank you, Dr. Zakia, for that excellent presentation and also for a very patient and centric approach that we have to individualize therapy, and we have to, in a country like ours, we have to look at everything. We have to look at the comorbidities, we have to look at the affordability of the patient, we have to look at the expertise which is also available in the lab. So the panel is now open for questions and for comments.
I just wanted to ask Praveen, you have a single surviving graft and a single surviving native who needs MCS. Which one will you tackle? Single surviving, easily doable graft or a complex left main, left dominant system, both needed MCS. After the Victor trial, which one will you tackle and what do you do with the graft? You do kill the graft tackling the native or you tackle the graft first?
So you already, so that nice question. In fact, my first case was exactly similar what you were talking, that this was a degenerated vein graft, and there was another very bad stenosis. It was actually a left main equivalent, where we were doing the single last surviving vessel. So definitely, native vessels behave in a more predictable way than the vein grafts, because you cannot predict whether in a vein graft there will be a slow flow, etc. or not. Because slow flow is something where you do not have any control of what you are doing. Because how much time it will take to recover, whether it will recover or not, nobody can say. So my choice will be to treat the native vessel first, if possible. And you do the native vessel with whatever you want to do. You can do rota, shockwave, as she is showing, and that's what we do many times. But for the vein graft, again, there are 2-3 things which you have to consider as to whether this stenosis is proximal or very distal, because many times if it is at the insertion site, then the chance of slow flow is very less. But if it is in the mid shaft of the
Victor trial, which has been present, Victor trial has been stopped prematurely because of overwhelming benefit of doing venous graft. This is the first trial between doing native versus venous graft. All these years you have taught us, your Ashok Seth has taught us that tackle the native because venous is unpredictable. Now the trial, RCT has shown, all these trials are registered trial. The first trial, Victor trial, I said, do the graft rather than the native.
Yeah, I agree with you that data doesn't defy that much, but many times data may be misleading also. So you have to be very, very choosy about this and make your decision based on the anatomy which you are seeing on the angiogram, where the disease is, how the disease is, and how much of kind of muck or thrombus which is already existing. So take all those decisions based on that.
I think what Dr. Praveen is saying is right. You have to individualize these decisions. They are too complex. You can't have randomized trials. And let's not forget, if the graft is 30 years old, done in 1988, it's a different situation vis-a-vis a recently failed graft, because that vein graft is not going to last forever. And the muck and the slow flow we saw earlier, with statin and dual antiplatelet, today we are not seeing that slow flow we saw 20 years back. So everything has changed, and individual decisions have to be made.
Rupa, that was a myth breaker. All these years, whatever you are saying, Praveen is saying, we believed completely. Now there is randomized data that doing the venous is the better way to do.
I think it would be reasonable to have a proper debate on that trial itself as a journal club than, use it to make individual decisions.
There is a paper which has come last week, which has shown that, I don't remember the author, but what they said is after the bypass is done, the atherosclerosis which is there in the native vessels get more and more and more aggressively calcified because there is no flow. The graft is receiving the flow. The vessels, the native vessels will be definitely more difficult to tackle as compared to the grafts. But yes, venous grafts have their own viability and a period when they can last. But with the laser and the recent advances, we are able to do all this. This is what, it will be complex procedure when you are tackling the native vessels,
so
but yes, it will be
in
easier
this trial,
procedure with venous grafts.
In this trial was laser, in this Victor trial was laser used. Was laser used in this Victor trial?
No.
Simple
Simple stenting was done. So, Dr. Zakia, thank you for that wonderful talk. And I think therapy needs to be individualized, but this trial has come in after a long time, which gave exactly the opposite opinion which we have been doing for so many years. It needs to be discussed more and in detail. It totally changed what we have been thinking. So thank you so much to the panel. We'll ask everybody to come in for a picture together. Thank you so much to all the speakers, requesting everybody to join us for a picture. The speakers, the chairpersons and the panelists.
Please change the backdrop for the picture. Thank you. Thank you to all the session experts. Please collect your mementos. I request Dr. Sheba to do the honors. We now move to this session, the ACS Revolution EAPCI collaboration session, a segment that highlights
Dr. Chandra.
evolving perspective, shared expertise, and global collaboration in advancing the management of acute coronary syndromes. I am pleased to welcome our esteemed chairpersons for this session. I request Sarita ma'am to be on the stage, please, Dr. Aditya Kapoor and Dr. Takahashi. Joining them as part of the expert panel are Dr. Madhumati Panja, Dr. Seema Ajay Naksane, Dr. Prachi Sharma, and Dr. Praveen Jaiswal. Guiding the discussion for this session as moderator, I invite Dr. Richa Sharma. Over to you, Dr. Richa.
Thank you, and I would ask all the chairpersons, Dr. Mamas, Dr. Ramesh Raghubati, Dr. Sarita, Dr. Aditya Kapoor, Dr. Seiko Takahashi, Dr. Michael to come on the dais, and the panelists, Dr. Madhumati, Dr. Seema Ajay, Dr. Prachi Sharma, and Dr. Praveen Chandra sir to be on the dais. So we have our live cases ready, and in the interest of time,
Requesting Dr. Rupa Salwan to please come and join us on the dais. Dr. Prachi Sharma. Okay. Dr. Seema Naksane. She was here right now. So Ujjwal, are we ready to go live? So today we'll take the live cases first, ladies and gentlemen, because the live cases are ready. We are half an hour behind schedule. So we have two live cases today with us. We have Dr. Anja Oksnes, who's going to do a live case on complex coronary imaging and calcium from Norway. And we have another live case by Dr. Anna Franzone. She's going to do a live case of a mitral tear. She's from Italy. So Ujjwal, which lab are we going to first? Can we start with Dr. Anja Oksnes?
Yes, hi, can you hear us? Dr. Sarita, can you hear us from Norway? Yes, hi.
Hi,
So
Dr.
we are
Anja. This is Dr. Sarita Rao.
we are so nice to hear from you. So we are delighted to be here with you and to do this live case from Bergen. We are all female team here today with nurses Birte and Katrine, my two colleague female operators, Kaja Skromme and Malin Flygel, and myself, Anja Øksnes. And patient is very willing to be here this early Saturday morning. He is not a woman, but he's a great gentleman. So we will start by presenting the slides of our case.
Good morning, everyone.
So, Mr. Box, can you switch
We're
to
so
the
delighted to present you this complex case, I would say. As Anja said, we have a male on the table today. He is a 74-year-old, and he have all the coronary risk factors with diabetes, hypertension, hypercholesterolemia, and a chronic kidney failure of a moderate degree. And he presented earlier this year with crescendo angina. He was in CCS class 2 and NYH class 2. His blood tests were normal other than the moderate kidney dysfunction, and the echo showed a normal ejection fraction and a moderate aortic stenosis. So he came for an angio, and as you can see here on the right side, we have a severely calcified RCA with a stenosis in the distal part. We do not see any retrograde filling to the left system. Next slide, please. And in the cranial views here, you see the LAD with the severe calcification is a very long lesion, and also the poor periphery in the distal part. We have a large diagonal with a calcified stenosis in the middle part, and you can also see the moderate lesion of the left main. Next slide, please. In the caudal view, we saw that we had a moderate stenosis in the proximal part of the circ and also a stenosis of the marginals. And the patient was discussed in the heart team, and due to the poor periphery, especially of the LAD, we decided to go for PCI. So he was actually here last month to do the RCA, and as you can see, this was severely calcified. It was a concentric calcium with a very narrow area, despite the large vessel size. We had to use shockwave with 120 impulses, and we had severe dog boning, but we were able to get a very good result. And today he came back to finish up on the left side. Yeah, so I thought that we would show with you the setup pictures of today, if we can have the screen here, Kai and Malin. So we thought today we would start with the LAD diag system and assess everything by IVUS and see whether we could leave the left main alone for today. And then deal with the LAD and diagonal and potentially take him back for the circ left main if needed. So this is the setup shot, and you can see the severely calcified long lesion in the distal mid-LAD and also in the diagonal. We anticipated some challenges in wiring, particularly this diagonal, so we started up front with a microcatheter and Xion wire, and managed to wire the LAD. For the diag, we used XTA. So after swapping up for two workhorse wires, Xion blue in the diagonal and a Xion wire in the LAD, we knew that we had to do some small balloon dilatations to be able to deliver our IVUS catheter. So this is the wiring of the two vessels and the delivery of just a 125 Sakira balloon. So do you want to give us your thoughts on this case before we move on?
Yeah, very interesting case. As we can see that it is a very heavily calcified triple vessel disease with moderate to severe aortic stenosis. So Richa was discussing a point. Richa, can you take that point up of the initial strategy?
Hi, Dr. Anja. So as we just saw the clinical vignettes of the case, that patient was already having a moderate aortic stenosis. Patient is symptomatic NYHA class 2-3 and having some coronary artery disease. So the strategy with which we should imply in this here, why not CABG plus AVR? Because it's already, what was the echo finding? How much was the gradient? Because aortic stenosis is one thing that we cannot miss in here, and the patient is symptomatic.
So the stenosis was only in a mild, moderate degree. The velocity over the valve was 2.8. Okay. So it was not nearly to be severely calcified either.
Yeah, then the scenario changes completely if it was mild aortic stenosis. Since you mentioned some LV dysfunction also, EF of 52%, so it's very important to assess aortic stenosis, the grading of the aortic stenosis. So yeah, we can go ahead with the coronaries now.
So this aortic stenosis probably will not need any treatment in the next few years. Yeah. And hopefully with coronary intervention, patient should do well.
His symptoms
for the LAD diagonal,
and he had angina.
As you're doing LAD diagonal today, so what is your planned strategy today? Like you want to do just balloon plus shock wave, or rotatripsy, or orbital? What exactly is your plan right now?
Yeah.
So it's a long lesion.
So we had, we had a rota. Yes, so we did plan on, or we had a rota in the room ready because we thought that this could be very tight. But as we were able to cross with small balloons, we thought we would do imaging first. And I will show you the IVUS image of the LAD here. So this is, can you see my IVUS?
Yes, we can see it.
Yes. So I can run it for you. This is the IVUS run from the distal LAD coming back.
And the vessel size isn't bad actually. It's a 2.7 vessel distally, but here you see we start getting circular calcium several places as we come up. Some of the distal parts here seem to be modified with some cracks.
Long segment.
And here the vessel is larger, and you see here circumferential calcium. It looks thick, and we thought that shockwave would be a good treatment for this patient since we have a long segment. And obviously, it's also not tight enough that you would reach with a rotablator in this proximal segment. Yeah. So now we're getting close to the diag, and you see just distally to the diag here, it's a massive calcium burden. This is the diag coming in. You can see the ostium on the diag on the IVUS, which looks okay actually. So stenting across it would also be possible. We haven't been able to mention areas and dimension yet because we just did this before we came live, but we will do this in a short while. And this is the calcium in the left main, which is circumferential, but the area looks quite good. Okay. So our thoughts now was that we would do shockwave to this lesion, and I guess the vessel distally is just 2.7, but we don't think we need to do shockwave down here. We think we can modify this with MC balloons, and we actually thought we would treat this distal part of the vessel with a DCB. And as we come up into the more bigger area here, we would do a shockwave balloon, and we thought we would do a 3O shockwave that would touch the edges of this calcium. Any comments from the panel?
So for the distal LAD, which is the calcified segment as well, you are not planning any decalcification technique, just balloon and DCB, is it?
We thought we would do a 2.5 MC and re-IVUS, and if we're happy with the modification, we would do a DCB. If not, we could do a cutting balloon distally. But as you can see here,
we can
there is some reverberations, and you can see some cracks, and this is just and it's only after a 1.25 compliant balloon, but this area here looks quite tight. So of course we have to do something about it, but we thought we would start with a 3.0 shockwave and modify the proximal segment. We would then do a 2.5 NC in the distal part, and we'll re-IVUS and see if we're happy with the result before stenting.
Now we have a 2.75 shockwave also available in India. So
yes, we don't have that actually.
But that's not.
So it's more about having it delivered than.
I have also
of course.
I have also some remarks according to the using of the shockwave now, because I think it's a good practice to make a little bit more space to deliver the shockwave balloon. So you used only 1.0, and I think it will be nice to use 2.5 to have better deliverability of the shockwave. But of course, it could be possible even. It's a very good option.
So the other thing is also that you can use a 2.5 shockwave starting from the distal. Now this is 120 pulses, so you can come proximal. And if you see that the balloon will be in contact to the vessel wall, then the same 2.5 can work for this 3 or 3.25 vessel also, because it will give cracks, and then you can follow it up with a cutting balloon in the proximal segment, and then do a DCB distally and stent proximally or something.
Could be an option. Of course, the risk that then you must
have
use
contact.
Adding or maybe the second IVL balloon, and then the cost is growing up.
So actually we've tried the other technique, what we do is we upsize it by point. If we have two different areas, so we go with, for example, a 3O, and we don't go up to the full inflation pressure, just to keep the contact and give it distally. And then proximally, we go up to the 4 and then give it 6. So basically, it can be done both way. And there's a group of people in UK who are actually doing it, upsizing it when you have a vessel discrepancy with the great results. So the principle is that we have to have contact for it to work. So either ways, it can be done.
This is the shockwave now inflated. This is a 3O, and you can see there's some tightness in the distal part of the balloon, but it opens quite well. I think the reason for not taking a 2.5 was that we felt that that wouldn't touch the calcified area and some of the parts of the proximal vessel. So, and also since the
distal vessel is 275 on IVUS, so it's okay to take it.
Maybe also I would use the IVL for this region, but I'm from Japan, and we usually use the OCT to evaluate calcified lesion, because I think calcium thickness is important to make a decision how to moderate the calcified lesion. So maybe we can open with IVL, but let's see.
So you would want to use OCT in this case, but I think she mentioned right at the beginning, this patient has grade 3 CKD. So possibly that is one of the reasons they didn't want to use the OCT. And of course, we can still do a saline OCT, but sometimes you don't get the images. But possibly, I think the reason for choosing IVUS was that the patient had CKD grade 3.
And also that we're looking at, so obviously when we're with you guys for 20 minutes, we want to do this vessel, but we might continue with some of the other vessels afterwards, and it's going to be a lot of imaging runs, you know, pre, post, calcium modification, then post stenting and optimizing in long lesions. So I think OCT is very good at measuring calcium depth, but here I think having to do many imaging runs, we would prefer to do IVUS. And you do assess the modification of the calcium on IVUS very well. So as you can see, we managed to deliver the 3.0 IVL balloon, and it actually looks like it's opening quite well here. How does the balloon? How does it feel, Kaya? Do you feel that it's doing its job?
Yeah, quite a bit of friction, but it's improving.
I think the case is moving very well. But one point of discussion that many people might have taken the other strategy, which is the rota, because in a diffuse lesion like this, it makes things a little faster, that you do a rota, take a 1.5 burr, do a rotational atherectomy, and then followed by IVL catheter in this situation might also be faster, because now you can see that if you would like to do anything beyond that shockwave segment, the shock segment, this catheter will not go, because now it has lost its profile. And 99%, in case we have to do something, we have to take a new IVL catheter, which will be, far more expensive than rotatripsy.
Or just try to take it in
well,
with the guide extension.
For us, it's for us, I guess the cost isn't much of a difference between the two treatments.
1.6, so 1.5. I mean, if you can get an IVL across, it's better. 1.63 was the tightest point.
Ma'am, we saw a lot of reverberations also on IVUS imaging. So probably the depth of the calcium is not that much at most of the length of the segment, except for a few places where it was 360 degree, where we couldn't see the reverberations. So mostly it is superficial calcium with lesser depth. For this longer lesion, we may end up with the pulses as well. So rota is also an option, a different strategy, wherein we can have the run. And in the proximal, we can take a 3.0 IVL balloon. That would suffice with the job.
Yeah, I think when you do imaging, it's also important that we trust our findings. And when we looked at the imaging, we thought that we didn't need to do rota in the distal vessel due to that the calcium didn't seem thick enough. But we rota Tripsy a lot, and I think it's a very, very good treatment for long lesions and almost uncrossable balloon lesions. And we still haven't, and we still might have to do that in the diag. We'll see how the imaging looks in the diag after a bigger NC balloon.
So, Dr. Anja,
if you look, yes,
this is a wonderful case, and we can really see the amount of calcium over there, and you've been already given 2 sets of pulses there, and the profile seems to be getting better of that lesion. But meanwhile, we'll just switch to Dr. Anna Franzone and then come back to you. So,
sure, we'll be here.
Ujjwal, could we go to the other lab, to Anna Franzone from Italy?
Scusami. Hi, hello everyone. Can you hear us?
Yes, we can hear you, Dr. Anna. How are you?
I'm fine. We are fine, and we are very happy to welcome you in Naples, in Napoli, in our cath lab today for this case of mitral transcatheter edge-to-edge repair. If you want, for the sake of time, we can jump into the presentation of case. And I ask Federica, this is the team today. I ask Federica and Dalila, that are our experts in imaging, to present you the case.
Good morning, everyone. I present you the case. The patient is a 83-year-old female patient with a BSA of 1.77, with dyslipidemia and chronic kidney disease at stage 3, and family history of acute coronary syndrome as cardiovascular risk factors. And in 2011, she underwent a pacemaker implantation for sinus node dysfunction. She suffers from permanent atrial fibrillation, and at the angiography, she has no relevant coronary artery disease. In December 2025, she was hospitalized for dyspnea with a class 3 NIA and peripheral edema. She was referred us for the evaluation of mitral regurgitation. Medication is furosemide 100 milligrams, spironolactone 25 milligrams, and edoxaban 30 with the SGLT2 inhibitors that was interrupted for recurrent urinary tract infections. At the physical examination, we found a blood pressure of 160, oxygen saturation of 94%, follow systolic murmur at the apex, and pulmonary rails. And at the lab results, we confirmed the chronic kidney disease with an eGFR of 39 and heart failure with NT-proBNP of 4,000. And the electrocardiogram, she has atrial fibrillation with ventricular pacing and heart rate of 60 beats per minute.
On transthoracic echocardiography, we can clearly see that there is an issue on posterior leaflet of the mitral valve, which seems prolapsing, causing a severe, large, very eccentric regurgitant jet, which is swelling and reaching the posterior wall of the left atrium. Next. On transesophageal echo, we can better understand the anatomy of the mitral valve with a huge prolapse on the central and the lateral scallop of a posterior leaflet, while the anterior leaflet seems quite normal. Next. On the bicommissural view with the X-plane, we can see from the lateral to the medial part of the valve the prolapse on P1, next, a flail on P2 with the origin of the main jet, next, and while the P3 scallop seems quite normal. Next. We also performed some measurement in order to evaluate the feasibility of the anterior procedure with the calculation, the evaluation of mitral valve area, the length of the leaflets, flail gap, which was 3 millimeters, and flail width of 13 millimeters. So thank you, Federica and Dalila. So we are dealing with an elderly woman with primary MR. This was, of course, discussed in our local art team, and the indication because of the high risk of surgery was for going for TEER. And from an anatomical point of view, as you can see, we have a lot of criteria that suggest this is non-complex and ideal for this kind of approach. And we will show next, please. Our strategy is to start with at least one clip that targets the flail, and then we will see whether another clip lateral to the first one is needed or not. Let me introduce, please, Professor Carmen Spaccarotella, that is my teacher for this procedure. She's with us here at the table. And for the sake of time, again, we already performed the transeptal puncture. Federica will show you just in a moment our height with the, that we gain for the puncture. We are high, and this is desirable for such a kind of anatomy. And we are now in the phase of the clip being in the left atrium, steering down the mitral valve. And we will show you in a minute our orientation, the orientation of the clip, the clocking. And this is usually what we do in 3D echo. We have to ensure to be perfectly perpendicular to the mitral valve coaptation line. And yes, we mark then with the color. We assess also the location of the clip with relation to the major jet that we want to target as our first goal. So we are ready to enter the left ventricle, but we are very happy to hear what do you think about the case and if you agree with our strategy.
So it's a very, very challenging case, I must say, because to start with, for many people sitting here, I'm just giving them the introduction that this is a degenerative mitral regurgitation, and we do today MitraClip for two types of indications. One is functional, other is degenerative. This is a degenerative MR. Functional MRs are more easier to treat, as she also mentioned, but this is a degenerative MR with a leaflet prolapse primarily of the posterior leaflet, and that too on the lateral side, which is P1, P2 segment. So P1 is lateral, P3 is medial. So here you can see that the leaflet prolapse is quite big, and the leaflet size is also very big. So what happens is that we need a leaflet size of posterior leaflet at least 10, otherwise you can't catch it. But here it is, it was like 25 or something, 28. So it's quite big, so it's very bulky. So sometimes it becomes a little difficult, and also the prolapse is quite massive, so it is difficult sometimes to catch it, but definitely it is a good case. There is no calcification on the leaflets, so it will be easy to catch it. And also that the MR is severe, so it needs to be treated, definitely. And what is the age of the patient? I just missed that age.
83. She's 83 years old. Yes.
So a little, unlikely for this age to have a degenerative mitral regurgitation. Mainly it is in the a little bit younger population, which we see here in India at least. But most of these patients who are at this age, generally they come with a functional mitral regurgitation. And the clip you are choosing is, which clip is this you are choosing?
We chose the Abbott XT White. That is the largest clip from the Abbott.
Yeah.
And the reason is, of course, because of the length of the leaflet, and we have a wide valve area. And yes, this is our choice for the first one. We will see how it works then, and we'll eventually opt for a second one.
So just to introduce again, these two views are the main views for any MitraClip procedure, nothing else. The third will be an en-face view, which she showed already. So this is a LVOT view where we will grasp this, and this is the bicommissural view where we will see whether it is medial or lateral. So this is for basic understanding. You can see that this is the the lateral side, that is the medial side, and here you can see that this is the anterior where the aorta is, and that is the posterior, which is the LVOT view for grasping. And then we also see for how the trajectory of this catheter will be, because it has to be in the center. So the trajectory looks quite reasonable. There is some posterior tilt I can see. There is some posterior trajectory I can see on the LVOT view, but I think you can, maybe once you go inside, it will correct itself, or then otherwise you can change it once you see in the en-face view, once you have crossed this valve. But overall, I think, this is a good case selection. Taking a XTW, which is the wide and the long clip, is the choice. And also now look at the fluoroscopic image. The fluoroscopic image is RO. Is it the RO view? Generally, we
No,
take
this is an AP view,
yeah.
yes, but we can go a little bit
So
right.
now you will go to the RO view, and then once
Yes.
to check for the orientation, once we have good orientation here, we can freeze that, and then it will keep us guiding as to whether we are oriented or not, because sometimes when we move the clip down, it disorients itself. So overall,
yes, that's
please
a
go
very
ahead.
good
Yeah.
advice. Yes, and that's exactly what we do. We now have to follow the path of the clip, both in echo and in fluoroscopy, to be sure that when entering the ventricle, it does not move too much. It can happen, but we hope that it keeps its position now.
Yeah, a little interior. Now you're quite in the middle, almost P2.
Yes. Can we check again 3D, please?
So would you check the orientation in the, now there's the 3D and
Yes,
pass? Yes.
We check the clocking. As I said, our target is to be perpendicular to our target grasping zone, and we are,
Looks
it's
like
good,
in
huh?
absolutely in that zone where the leaflet is prolapsing. So look at that. She's
Yes.
absolutely at the right position. It is a little bit anterior. She can make it a little bit posterior by the guide
We go a
caster.
little bit posterior.
Yeah.
Yes?
Yes.
We are ready. I think we are ready now to
So
enter
have
the
you
ventricle.
checked the clips, the grippers? Have you checked the grippers?
Yes, this is something that we can do it again. We unlatch the grippers, yes, and we try to understand which gripper corresponds. The first one, I don't know if you can see, the anterior one. This is good for eventually we need independent grippers.
Right.
When we will be
here there is a
grasping.
possibility of gripping capturing the leaflet separately with the mitral clip. However, in my clip
Yes.
right now we have to grasp both together. So which was the
Yes.
previous iteration of the mitral clip. But here with this we can know which is the gripper we are handling by the two separate controllers.
Of course, we will aim for simultaneous grasping, but we will see then how it works. So, are we ready to enter the ventricle? Yes?
I think, yeah. So you'll close it to what about
We will
60?
close to 60 degrees.
60, yeah.
Yes. To try to not to get entangled in the subvalvular apparatus or into the flail.
Yeah.
Non mi
I
muovete
can
l'eco?
see there are some cordies jumping around, so you have to
Yes,
be careful.
exactly.
Yeah.
Okay, and then we will check by fluoro and echo the path.
I think the orientation has changed a little bit. Maybe you have to check it again.
Check it again, for favor,
Yeah, for
please.
the orientation.
Yes, probably maybe
it
you are
has
right.
changed.
What do you think? It seems
Maybe
more
you
or
have
less
to go a little bit 12 o'clock.
okay.
Yeah,
Now it
slightly
looks better.
A
Yes.
little bit more because here we are nearing the P1, P2 segment, so we have to be a little bit 12, 12:30 or something like that. Yeah.
Yes.
And little bit more anterior. It's very
Anterior.
too much posterior.
still.
Yeah.
Mhm. Can we go back to 2D? Yeah, a little bit posterior.
The trajectory also has changed somehow. The trajectory is very posterior because it is going to
Yes,
hit
now
the,
it's posterior.
yeah, the LV wall. So you have to change the trajectory.
Guardatemi la clip.
Better.
What do you think? Now it's better? Let's try
Yeah,
the
slightly
trajectory.
better. Slightly better now.
Yes.
Yeah.
Okay. No? Vado?
So the thing to remember is that in the LVOT view, you should be able to see the two clips as the V. That's very important. Yeah. Both the arms, clip arms, should be visible properly. And here you can see in the fluoro, this is
Apriamo un
right
po'.
as a single line. So that's what you should see in the fluoro. And once you have
Yes,
chosen,
I think
now,
in the
good.
fluoro
So
we
you have
get the
crossed,
position.
Yeah. Now the
Yes, I
orientation has
crossed.
improved a little bit. And,
Yes.
yeah,
The
yeah.
fluoro is okay. We are now
Yeah,
opening the clip
yeah.
120 degree. I
Maybe
don't know
you have
whether
to
you can
reduce the tidal volume a bit. Because,
Yes.
yeah,
We can
tidal
ask our
volume 200.
anesthesiologist,
Yeah.
anesthetist in charge,
looks good.
Position
You'll
looks
be
good.
able to.
to stop to the breath, reduce the ventilation a little bit.
Yeah.
Yes.
Now we'll check again the orientation by 3D, please.
So the PML is coming quite well. It's a huge PML. So
Yeah.
typically.
Yes, it is. And usually this happens with these prolapsing leaflets that they fall.
Yeah, we are just in that segment. It's okay. Yeah.
Federica is advising a little bit counterclocking. We will do very little movements. We are,
Yeah, little movement, little, yeah,
yes,
just
very
a bit.
gentle movement.
Go to 12-ish, 12, 12:30. Yeah, it's okay. I think it's very good.
Now it's
Yeah,
okay?
it's good. Yeah,
Yes.
yeah.
We'll come back in grasping view.
So we can't do too much movement now because we are in the
No.
LV. So that's why she is very careful in not moving too much. Otherwise, entanglement with the cordy will happen. If that happens, then that's a different ball
Yeah.
game altogether. I think we are
So-
getting the good.
Bye.
Position looks good. Yeah,
And now I coming up.
yeah.
I'm
Come
coming
up a
up
little
with
bit,
the
and maybe you have to come little anterior, now both are coming. Both are coming very well. Yeah.
Both are inside.
Go
I come
for
a
the
little bit
grasp.
up.
Go for the grasp.
She can go for
Okay.
the grasp.
Yeah. Yes.
Yes.
So we can see that.
Carmen, release the grasp.
Yes.
She has grasped
She has
both.
grasped both.
Good, very good.
Yes.
Excellent.
We release a little
Excellent.
bit of tension.
Congratulations.
So now we have to check.
Check
She
yes,
is
now
closing it completely and checking the MR.
first of all, we would like to see whether we were able to get the flail.
It's reduced.
That's
The
beautiful.
MR is totally
It's
reduced.
a very good
It's
grasp, but to confirm, now we have to confirm whether the grasp is
Yes.
complete or not, because sometimes SLD can happen. So we have to check
I
the
would
length.
like also to focus your attention
So you
on
can measure
the
the length of AML
pressure.
and PML. Yeah, length of
Yes.
remainder AML and PML to know how much leaflet is inside the clip.
How much leaflet is inside? Federica will tell us
If
in
it
a
is
minute.
less than 6,
And
the chance of SLD is very high. But it
in
looks
the
like
meanwhile, I would like
too much
you
is
to
inside
look.
already. This
But
is
the posterior leaflet was really
how
long.
much is this?
Posterior
0.9.
was a 28 at least. And now we have
9 millimeters. So it's a good grasp.
9 millimeter out.
It's a
Yes.
good grasp, yeah. Yeah.
We
AML
cannot see
also you
anymore
can measure
the very eccentric
because
jet.
AML was smaller.
You can see also this bouncing, that is this lifting of the grippers of the clip, of the arm of the clip
I think you
during
have
the
to give some
systolic motion.
relief. Push the,
Yes,
this,
we already
tension
did
release
it,
has
but
to be done.
yes, we try to release the tension on the system.
Release
I
the
would like also you to see at the curve of the left atrial pressure. Yes, that is the white one. This is our systemic blood pressure now. It's quite high, and this is what you usually do when checking the results. And also the pressure went in the left atrium, it went down. It was almost 17, the systolic pressure before starting, and now it went down. This is another parameter that we use to assess the result. Of course, now
So
by echo, we can come back to echo.
I
They
think
have to check that the grasping is
the
good,
bridge
but also
is
stable.
Very good bridge, yeah.
Mhm.
So you may check
And-
the pulmonary venous flows now.
Yes, the
And-
reversal in the pulmonary vein.
And
please.
also put color in this, yeah. So now you can see that the lateral regurgitation is gone. There is some small jet, little bit medial to the clip.
So after the first clip, how do you decide on whether this much regurgitation is acceptable or you need another
You see
clip?
that, three things. One, you look at the
So
regurgitation.
we
Two,
we
you
look at the
flows.
regurgitation.
So flows are so good now. You see complete
You can also appreciate some
normalization.
smoke effect in the left atrium now. Huh? Yeah.
Pulmonary venous flow is indicative of that. And also we see that there
There
is
is-
a medial jet. So in this you see
Yes.
lateral and medial. So lateral is okay, very tiny jet, but the medial is still there. We will see. If required, we will have to put one more clip medially which is absolutely
Yes.
okay to do, no problem.
Yes,
And
we
in,
were expecting to use
Yeah,
at
and
least
in
two clips.
Barlow's or bileaflet prolapses, it is better to put the second clip because it is so mobile that after a while it can tear the clip, and so to stabilize this first clip, you put the second clip.
We can check in fluoroscopy.
If the gradient
of course,
is
we
not
are
much. So
Yes,
now you
we
can
will
check the
check the
gradients
gradient
also.
now.
How much is the gradient?
Yeah, it comes.
It's okay. No, it's very good.
Gradient is okay.
Less than 2, maybe less than 2.
Yes.
Yeah,
Let's
nothing.
see what is.
1.26.
Yes.
It's okay. No problem.
So
Very
once
good.
we are happy with this grasping and with this preliminary result, we release the clip, and then we will assess whether another one, we can use another one.
Yeah, I think it's time to release the clip. Yeah.
Ok, rilasciamo? Ok, let's go by releasing the clip. L'anteriore ci stanno.
Maybe you can go a little bit RAO also and
Parliamentary
freeze this view because it will be very beneficial when you are putting the second clip. It will be much faster. Yeah.
Yes. So we are performing these tests that are under fluoroscopy and under echo to ensure that the clip is not opening. These are security, safety maneuvers.
But this
And
is
then
a
the
beautiful grasp, I must say. But you can see that the clip is moving so much, and once she releases it, it'll start moving a little bit more. But
yes,
second
that's
clip
of course. That's
most
the reason
likely
why
will be required. Yeah.
Serena is already preparing another clip.
Yeah. So
for us.
now,
And
are you preparing a XTW or a XTR or a
should we
NT?
go? Should we go for another XTW? I think yes. With
Yeah,
this will
you
something
can take a
that will-
XTW, but usually we take a XTR because that's a thinner
XTR.
clip, longer and thinner.
Yes, we have
choose
confidence
either,
here
because
because
the gradient is
valve
not that
area
much.
is very
It's okay.
high. Yes, yes, yes. We are quite confident that also the wide one is good enough.
Definitely we need a
And
second clip. There is a medial jet which is coming in.
Yes. And the release takes some time to release the clip. These are all the maneuvers that are needed.
You can check again. No, it's not opening, it's okay. We can close. Yeah, this
Okay.
is to be taken out, yeah. Expose the groove. So these are the steps. Exposing the
Yes,
groove.
we are exposing the groove. Then we have some turn.
Mm.
We have to turn, no?
8 turns.
We do 9 in Italy. I
Yeah,
don't
we
know
also
why.
do 9, but 8 is recommended. Yeah.
La spoletta.
Yeah.
Refer su.
Yeah.
So fluoro on, please.
Fluoro. Yeah. Okay,
Clip
now,
is released.
yes.
It's very
The
mobile,
clip is
at least on Anjo.
Excellent. No SLD, moving good. Now
Yes.
you can
C'è
take the
del
M off a
cavo
little
fare-
bit and take this out.
Togliamo dentro.
M off.
I'm off. Yes.
Yes.
Se non se ne viene.
Excellent demonstration of this clip in a very difficult case. Nagurupa.
So
That was an excellent one.
let's see the result. But we are, of course, there's no time probably for you to stay with us for the second clip. But we will do it now,
Check,
and
check
maybe
the color on this because sometimes
Color?
when you remove this, it's a MR is there, and it's better to put the second clip to stabilize the first.
Yes, yes.
And take this MR which is there.
So, Dr. Anja, thank you so much for that excellent demonstration and walking us through that entire clip process, and you did it beautifully. Now, in the interest of time, we will have to go to the
Yes, of
next
course.
live case, and thank you so much for an excellent presentation.
And bye-bye,
Thank you.
everyone. Bye-bye, bye-bye.
Bye.
Thank you, bye.
Ujjwal, can you shift us to back to Dr. Anja? Dr. Anja, we are with you. Dr. Anja, can you hear us?
I can hear you. I can hear you. Can you hear me?
Yes, we can hear you.
Yes. Hi. Welcome back. So while you've been in Italy, we have done a 275 NC to the distal LAD. We then had something that you sometimes have when you go high on NC balloon. We had entrapment on the wire, so we had to swap the wire with a dual lumen catheter. And then we've done a 3-5 cutting balloon to the proximal vessel because the shockwave was not completely expanded in a part of the mid vessel there. You want to show that, Kaya? Show where we have the. You see here that there's some indentation on the shockwave balloon, but most of it worked very well. We delivered all of the 120 pulses. Yeah, and then we did the 3-5. So I will show you the IVUS. Da må du ta fotmek. Yeah. So I'll just run the IVUS for you. We try to start in a kind of a healthier part of the vessel, distally, and as you come upwards here in this segment that we have intended to DCB, if we can get a good result, we don't see any major dissections or untreated calcium. There is cracks in the calcium all the way here. Very tight though in some of them, but you see all these nice cracks in the calcium, multiple of them. And now we're coming back towards the more proximal segment of the vessel, and also there's some eccentric plates here that aren't that modified, but that's still a challenge for us today. And you see here all these nice cracks in the calcium. Coming back towards the diag here, and we see all the way that we've managed to modify the vessel. This is the thick part of the calcium just proximal to the diagonal branch. And here is the diagonal branch. And yeah, this is our intended landing zone. So do you agree with that the calcium has been modified by the shockwave and the 3-5 cutting balloon?
So did you use cutting for the distal lesion as well, and did you use that 3-5 balloon for that?
No, we used that in the distal part here. We had a 275 MC balloon, and then for the more proximal lesion, we had a 3-5 cutting balloon.
Yeah, from the images which we saw, it appears that in some distal portions the calcium is slightly untreated. And if you are proposing a DEB in the distal segment, I will recommend that you should do a cutting balloon dilatation using a 2.5 to start with distally, and go to high pressures. It becomes 2.75 at 16-18 atmospheres. So,
so this portion that I'm showing you right here, is that the portion that we're thinking of, right? This segment here. Yeah.
So
there is obviously one crack at 12 o'clock and one distally, but we can, do we have did the 275 dilate completely, or?
Yeah, I think you can take a 2.5, 15 cutting balloon. And as you go up, increase the pressures, go to 18 or something, because this is what we typically do in a tapered vessel. Start with the cutting balloon, 2.5, like for example in this, and it can go up to 2.8 in the proximal segment if you go to 20 atmospheres, and it doesn't burst, or it only expands.
Yeah, the proximal vessel we're already been with a 3-5 cutting, so that's okay. Har du MC-en ute I diagonalen?
Ja, nå har jeg kommet ut med den. Den har jeg kommet ut med.
Yeah. So right now we have a 2-5 NC in the diag. We're just going to use that. As you can see here, that's a 2-5 NC. So we're just gonna modify the lesion here a little bit more, and we'll re-IVUS after we've dealt with the distal part of the LAD. So.
So as we can see that the ostia of the diagonal is clean, do you plan a DCB in the diagonal as well after preparing the lesion? Distal LAD as well as diagonal, and go with a provisional strategy rather than a bifurcation?
Yes.
Because it's
we do not plan to do a, I think as the ostium looks very, very fortunate on the IVUS, we should not go for a bifurcation strategy. And if we could do a DCB and have a good result with that in the diag, I also think that would be favorable. As for now, we don't have an IVUS showing that we have achieved a good enough modification of the diag. So obviously that's the first thing we have to assess. But yeah, we do use a lot of DCBs here, and I think this is a vessel that we would prefer to do it in. I don't know if you have any thoughts on that. See here the expands well here. I think we should do the 2.5 cutting balloon in the diag as well. Why don't we deliver the 2.5 cutting to the distal part of that LAD lesion, and then we'll do a 2.5 cutting in the diag and we re-IVUS. So we thought we would DCB display in the LAD. We would then place a 2.5 by 12, 16 stent distally, and then we'll do a 3.5 stent across the diag. There's not really a good landing zone in the ostium of the LAD, just distally to the diag. I think we have to stent provisionally across the diag.
So, Dr. Anja, we agree with that approach of stenting provisionally, and doing the DCB distally, we were thinking that maybe do a cutting and then do a DCB. Now, our session is running a little late, so Dr. Anja, we'll be coming back to you in 10 minutes to see the final results. And for now, we would like to invite Dr. Stephen Harb to come and give the spotlight lecture on culprit versus complete revascularization, the ongoing debate. We'll be going back to Dr. Anja after this.
Thank you for this unique experience. Am I already, is it my turn? Okay. This is really a unique experience for me. So many powerful women from all over India. I'm hearing stories like I was the first cardiologist in my college, and now I'm here representing my center. And you are still allowing men to participate. Thank you. My topic is simple: culprit only versus complete revascularization. It's an ACS session. I want to show you a picture from 1961, the year when I was born. Even back then, they were able to look at thrombocytes in the electron microscope. And you see normal thrombocytes with the granules in it. And you see 15 seconds later how the granules are already delivered, and they bind together and form a very strong thrombus. Nowadays, we can look at the thrombocyte with a light microscope when they are still working, and we can play tricks on them, tease them a little bit with optical tweezers, and see how they deform. It's quite nice what they can do with these methods. And the traumatologists have found that female thrombocytes are different from male thrombocytes. They build. But let's go back to cardiology, not to traumatology. This is the prospect trial by Greg Stone. You all know this. And you know that it's not only the thrombocyte that plays a role in the ACS, it's also the thin cap fibroatheroma. And they showed in the prospect trial that it's really a difference if there is a lot of thin cap fibroatheromas waiting for rupture. And not only that, they also found that the plaque burden is very important. and also the mean luminal area. So the smaller, the more shear forces, and these also tend to they have a damage. But still, it is culprit lesions and non-culprit lesions about the same responsible for the events. So when shall we completely revascularize? We have different entities of our disease. It's a chronic coronary syndrome, but we are talking about the ACS today, non-STEMI, STEMI overlapping with OMI with a non-STEMI group. 50% of ACS do have multivessel disease. You know about the inflammatory properties of these entities, that the chronic coronary syndrome is not so much inflammatory as the ACS. In shock, 80% have multivessel disease. So let's start with shock. What is going on in shock? You know the culprit shock trial. This trial showed us, Holger Thiele and his team did show us, that it does not make sense to take care of all the vessels. You have to look for the culprit and treat it, because in shock you have to do quite decisions that are very tough to make sometimes. You have to see how to get the patient to the cath lab. You have to decide if you should even do an intervention, because you have to make sure there is a culprit, otherwise it would make no sense to do an intervention. And once the patient is in the cath lab, you have to take care of many things to keep him alive. So you only go for the culprit. But this doesn't mean, the ASC guidelines also state this, but this does not mean that later on you are not taking care of the other vessels. If the patient is lucky and survives, you will still try to do complete revascularization, but not immediately. This is also part of our guidelines in Europe, that you have to think about the individual patient a lot. It's not so strictly possible to say, do this and do that. You always have to consider what will it entangle, what will be the consequence if you go for a long procedure. You have to think about contrast volume, you have to think of your team. If it's in the night time, you will not be able to offer everything. You have to think about imaging. Imaging is now 1A indication. You may use mechanical support. This may also change the game, that once the mechanical support is in, maybe you tend to extend the procedure a little bit in favor of the patient if there is a doubtable second. We have now talked about shock, but let's talk about non-STEMI. In non-STEMI, this is not so clear what to do. We have just a few trials. We should also think of measuring some things in the non-STEMI. Some trials are ongoing, so we will soon learn more about complete revascularization in non-STEMI. I show the BioVasc trial just as an example that has STEMI and non-STEMI and also unstable angina in it. Just look at the curves, at the beginning of the curves, and I am astonished that there is no signal of harm of an early intervention that is taking longer if it's just a single intervention doing more than usual. So there is positive signal for intervention early. Non-STEMI without shock, you should do complete revascularization, but maybe it's better not to do it immediately. In STEMI, we have the strongest situation for complete revascularization. We have a lot of studies. All say do complete revascularization. It has to do with the acuteness, with the possibility that the vulnerable plaque in the other parts of the vessel will act. But when do we do it? Shall we do it immediately? We have a time frame up to 45 days. And we have a lot of studies showing this and already studying this still. So we have to do complete revascularization in STEMI for sure, but we need not measure a lot in STEMI, because you know that in STEMI the lesions are functionally variable, they will not be stable, so it's not easy to measure anything reasonable. Let's conclude. This shows it all together. It shows you in shock don't do immediate more than the culprit, but think about staged revascularization to be complete. In the non-STEMI, there is more evidence that you should do the complete revascularization, and most evidence is in STEMI patients. Here you can do either immediate or staged up to 45 days. Thank you.
Thank you, sir. That was a wonderful talk. And we would have the question session just after the complete session. Ujjwal, can we just switch to the screen so that we can see what is happening into the cath lab?
Dr. Harp, can you join us
Ikke du
on the
måle med den
panel?
der? Jo.
Dr. Stephen Harp, can you please join us, please? Dr. Sujata, can you also join us, please? And Ujjwal, can we just switch to the live streaming and see? Dr. Anja, we are with you.
30 og 12 ser nesten litt koldt ut. Yeah. Hi. Yeah, so what we've done is we have just done cutting to the diag and we've DCB'd the distal part of the LAD, and the balloon expanded very, very well. Ja, dere trenger ikke bruke den der. Den ut. Ja. So now we're ready to put in the first stent in the LAD. So we're going to do a 2.5 by 12 single-digit stent. And then we're going to add on with a 3.5 in the proximal vessel. So it's going to be another few minutes before we can show you the final result. Also, we did a 2.5 cutting balloon in the diagonal that opened very, very well. Yeah, so first we're going to do the 2.5 DCB in the diag. So we're going to do that right now.
Dr. Anja will be
I don't know
back
if
to
you
you
have-
after another session over here. So we'll back to you in 10 minutes to see the final result. We'll move on.
Perfect.
We'll move on now. Dr. Stephen, that was a wonderful talk, and we'll be discussing it further. We'll have Dr. Marta here for her talk on a vulnerable plaque, the new forgotten PCI paradigm. Dr. Marta is from Poland, and she's chair of the Gender Diversities Committee.
Thank you very much for the invitation. I'm really very happy to being here for the second time at this excellent conference, and I'm really all the time very exciting about seeing the cases which are very complicated and very complex. And I would like to touch today a topic, vulnerable plaque and the new forgotten PCI paradigm. So we talk about vulnerable plaque since many years. So the first description about the plaque rupture, what is the reason of vulnerable plaque, was in 1931, so quite old concept about that. And then we have also very nice description about the possibilities of having a vulnerability in the atherosclerotic plaque, like a plaque rupture, plaque erosion, or hemorrhages in the plaque inside, and then building the hemorrhagic or eruptive calcified nodules. And it's this, it's a quite old concept, but you can see here what is the main reason of what happens in the plaque. It's of course the monocyte and microphages and all the factors which destabilize the plaque which is already built. And they are also, of course, why we are talking about the vulnerability of the plaque and why we are looking for the things of the vulnerability in the plaque. Because of course we have some important parts of that atherosclerotic plaque, and one of them is fibrotic cap. And what happens in this fibrotic cap if we have too much inflammation, if we have proteolysis or angiogenesis, then this is the thickening of the plaque, and then it will be we think that it will be the problem of the troubles. Of course, what is the main reason why we are talking about is the acute coronary syndrome, which can occur due to thrombosis, and this thrombotic event can happen in all of this concept. Especially we deal with a rupture of the plaque in acute coronary syndromes, and it can lead, of course, for death. But we have also a non-rupture and erotic vulnerable plaques, which can also lead for the acute coronary syndromes with also very high rate of mortality. But what is very interesting that more than 50% of patients suffer on ischemic event with a high plaque burden, but without a severe stenosis in the place of the plaque. So what is the concept? We are looking for some things which can maybe describe as the patient who are on the risk of the vulnerability. So one of that is, for example, here a very big cohort study of asymptomatic patient, almost 10,000 patient or age over 40 with checked with coronary computed tomography. And you can see here the non-obstructive but extensive plaque burden was one of the risk of the mortality. So we know that we can anyhow look for the vulnerability of the plaque, and we have a lot of images. It can be invasive, non-invasive, like computed tomography angiography, especially this new concept of the computed tomography, which can assess a very specified composition of the plaque. We have also MRI, which can be also helpful here, and of course we have intracoronary imaging like OCT and IVUS and NIRS, so combined spectroscopy with IVUS. And this slide you saw already, it was shown by Dr. Harp. It's the plaque it's the study of Professor Greg Stone, published 2010, which show us that if the plaque has a very thin cap, very thin cap, so it's and the plaque burden is over 70%, and if it exists together, the risk of the event is very high. So then we have this concept, how can we maybe prevent the rupture or erosion, or how can we prevent the acute coronary syndrome, which happens due to the plaque which is vulnerable. So it's the prospect absorb study. It was quite small study, but it was assessed by the NIRS if the plaque was, how was the plaque burden, and if the plaque burden was 65% or bigger, the patient were divided into arms, so they were randomized to BVS, absorb, implantation or optimal medical therapy. And you can see here that the study showed that BVS implantation was safe, substantially enlarged the follow-up MLA, and showed favorable long-term clinical outcomes, but it was not a so big study that we can really implement this, this information to everyday practice. Then we have the Prospect 2 study. It was also a quite similar story, so we would like to treat the patient with absorb BVS and show and look for the longer follow-up. But what is very interesting of this study that you can see here, this blue line show us that on the lesion level, the biggest problem the patient have if the plaque burden was very high and if the thin cap atheroma exists. So then it is the concept that the triple L, it's a very dangerous situation if we are talking about atherosclerotic plaque. So if the plaque has a large, if the plaque is large, so the plaque burden is more than 70%, if the plaque is very lipid rich, and if the plaque minimizes the lumen of the artery, so if the lumen artery size is less than 4 millimeters square, then if all these things exist together, the risk of myocardial infarction, death, or MACEs regarding to the target vessel and target lesion, and also, of course, angina symptoms is higher. So it's a very nice concept, which is here shown in the combined OCT FFR trial. It was a trial conducted in a diabetic patient, and you can see here then 25% of patients with diabetes mellitus have TICFA, so thin cap fibroatheroma, showed in OCT examination in FFR negative lesions, so they were not stented because the physiology was negative, and in those group there was the 5-fold increased risk of adverse
adverse cardiac events if they presented this TICFA. And this if the follow-up was prolonged, the result was similar. So even in 5-year observation, it was shown that the special thing of the special characterization of the plaque was very dangerous, even if the lesion was not severe. And it's also here a sub-analysis of the combined OCT FFR trial, and the TICFA was the most important thing most important characterized of the plaque, which was correlated with mortality. So then we have a PREVENT trial, and it was really the analysis of patient with negative FFR measurement and vulnerability of the plaque assessed by intracoronary imaging. So you can see here all these parameters which were checked, and the patient was randomized to optimal medical therapy or BVS or DES plus optimal medical therapy. And you can see here it was quite a big trial, more than 1,600 patients, and here is the result. It showed that the result was favorable for preventive strategy of stent or BVS implantation, but it was driven only by a target vessel failure. So it was only driven by the MACEs which are according to the lesion, not the hard MACEs like death or myocardial infarction. There are a lot of trials which are already ongoing, which try to check the concept to local prevention and local treatment of vulnerable plaque. I think one of the most important now for which of the result we are waiting for is combined intervene trial. So what do we know about vulnerable plaque? There are a lot of things which show us that we know such things, characterize things which can show the vulnerability. We can check and identify it with intracoronary imaging and also non-invasive imaging, but how can we treat it? Now it's the new concept that it's maybe not only looking for the vulnerability of the plaque, but we must be much more concentrated on the vulnerability at all. So it means we should also check all the risk factors in our patient, especially think about the risk factors which can influence of the inflammation. And only having this holistic approach is probably to treat the patient properly. So our goals and actions to reduce atherosclerotic plaque instability now and in this moment where we are is maybe not preventive PCI, but making lower the risk of MACEs at all in the patient. So for sure the first choice is optimal medical therapy, assessing the plaque, and of course then thinking about revascularization. So my take-home message is this: of course the vulnerable plaque characterized now at this moment a large lipid core, thin fibrous cap, large plaque burden, and small minimal lumen area these are the key predictors of future cardiovascular events, but the exact definition of vulnerable plaque is not clear at this moment. And we can maybe go more in the concept or instability of the plaque, and on this instability can influence everything what is connected with the patient, not only the plaque themselves. Advanced imaging technique like OCT, IVUS, NIRS, or CCTA can allow identification of the high-risk plaques. And of course, we have some studies which show us the concept of preventive PCI, but for sure at this moment, these results didn't give us the basis of make it in everyday practice. So optimal medical therapy remains the foundation of our treatment strategy. The key message, I think, is that the personal approach, integrated imaging, risk stratification, and target therapy, also pharmacotherapy, may redefine the future of PCI. Thank you very much.
Thank you, Dr. Marta, for that wonderful talk, and it's beautiful that all of these studies will probably give it an answer, and also the passivate cap, which we are looking for to see the results, and also the question of whether we should use DCBs in this situation. But we'll take the questions at the end of this session because we are running behind time. But thank you, that was a beautiful presentation. We'll call Dr. Shiba Chabra to please come and give a presentation on ACS in women, not just men with small arteries. And after that, we'll go over to see what Dr. Anja has finally done in her life case.
A very good afternoon to all of you. Well, I know it's the lunchtime and we are very hungry, but I think it's always good to talk about women, and especially when it comes to heart disease. May I have my slides, please? Yeah, thank you. So acute coronary syndrome in women, and it's not just men with small arteries. So the global disease burden of 2019 did tell us that cardiovascular deaths are much more in women, especially when it comes to all the ailments. We understand that women have got different risk factors. We have talked of this umpteen enough, that there are female-specific cardiovascular risk factors like pregnancy-related risk factors. We talk about female predominant like autoimmune disease, breast cancer, rheumatoid arthritis. We talk about female-specific conditions like peripartum cardiomyopathy, and especially female predominant cardiovascular diseases like NOCAD, Takotsubo, microvascular dysfunction, SCAD, and so on. We understand also that the upcoming data now suggests that it's not just those risk factors, but it's also some social determinants of health, cultural issues, language, health literacy, and especially stress-related risk factors in women. Women are also different. Their presentation as chest pain is less likely. It's typical for women to be atypically presenting. It's also very clear that the incidence of heart failure, cardiogenic shock, restenosis, hospital complications after PCI or surgical techniques is much higher in women. We are all aware of these gender-based differences. And when it comes to acute coronary event, we understand that plaque erosions are highly prevalent in women. Plaque rupture is less. They have lesser calcifications, less focal obstructions, more diffuse pattern of atherosclerosis with outward remodeling plaques. The microvascular dysfunction is more common. They have higher coronary blood flows at rest, but still a lower coronary flow reserve. Having said that, we have some data which is coming, in patients with acute as well as chronic coronary syndromes. And what was found is that lower plaque volumes are there in women. However, there are no sex differences when we talk of high-risk lesions, especially when we talk of thin cap fibroathromas and plaque burden more than 70%. The men and women actually behave in a similar way. And let's see, this topic is all about, small arteries. So given the same artery and the same lesion and the same extent of lesion, the FFR in a given woman would be higher as compared to that of a man. And why is that so? This is because the amount of functional myocardium which would be subtended by that smaller artery of a woman would be small. So the FFR, we can see that the area which is supplied by the coronary artery of a man would be higher. So the FFR would be lower in a man as compared to the woman given the degree of the myocardium which is subtended. So in women, in cases of intermediate stenosis, despite receiving fewer interventions, women had favorable outcomes, and the use of FFR led to lower PCI rates in women, however, equivalent results and the MACE rates. Well, we also know, coming on further to rehabilitation, that utilization of cardiovascular resources is less in women. First medical contact to device time in women is longer. Referral for revascularization is less. They are less referred for cardiac rehabilitation and receive less evidence-based treatment. There is also a difference between whether a woman is presenting at what age, whether she's coming to us in a reproductive age or a post-reproductive age. So a younger woman would come frequently with typical symptoms as compared to an elderly woman who would come to us with headache, nausea, dizziness, and so on. A younger woman would seek care but would be attended less frequently and misinterpreted. On the other hand, an elderly woman would seek care late. A younger woman would have higher risk of risk factors, which could be preeclampsia, PCOS, fibromuscular dysplasias. An elderly woman would have more typical risk factors like diabetes, hypertension, and so on. If we look at the PCI specifics, the younger woman would have higher rates of catheter-induced dissection spasm, vis-a-vis more bleeds in an elderly woman, which would be found. Depression is an outcome modifier in younger women as compared to frailty in a post-reproductive age. Having said that, if we look at clinical and angiographic patterns of ACS, we realize that women usually have got non-obstructive disease, which is prominent. In women, the incidence of SCAD and Takotsubo's is higher. 40% of men would present with STEMI as compared to 75% of women who would present with NSTEMI or unstable angina-like picture. In women, obstructive disease is 25 to 30%, and conditions with Minoka like SCAD and Takotsubo's, which are around 1 to 4%, usually in the whole spectrum would be to the tune of 80 to 90% in women. SCAD in STEMI in women would usually have single vessel disease as compared to multi-vessel when we talk of NSTEMI, and women do have sudden cardiac deaths when they have Minoka. We can simply not ignore Minoka. The meta-analysis which has been conducted have found that all-cause mortality, even with NSTEMI, was higher in women. And if we look at some very recent data, this was a data of around a decade which was conducted in women with ACS, it had all the same findings which we talked so much, but another upcoming finding is that the outcomes in low middle income countries have been less studied, and we need to look at so many other risk factors. This was just a few days back from the European Society only, acute coronary events, and this was a gender diversity and inclusion acute coronary syndrome registry. And in this registry, they actually found that chest pain was a significant manifestation even in women to the tune of 86%, and STEMI and STEMI were 38, 36%, and Minoka was the same number of patients actually. And if we look at a very recent study again, which studied about sex differences in ACS vary with age, what did it conclude? That younger women had higher risk of death or cardiovascular readmission than younger men. And this was largely due to differences in comorbidities, the type of ACS, and deprivation levels. Yet another study, which was studying the sex differences in ACS, and what did it find? It found that studies on sex differences in ACS mainly again come from the high-income countries. We need to have our data because sex differences in ACS management are widely reported and unfavorable to women, especially in the early phases of hospital care and diagnosis. So many things can be done, whether it's what happens in low middle income countries, the inclusive trials, the psychosocial determinants, the precision cardiology, but I simply love this slide. But today, I'll be talking of the right side. The women have got 1% incidence of stent thrombosis at 3 years, 4% severe bleeding risk, 8% in-hospital mortality when STEMI occurs, 20% of women with CAD feel sad or depressed, 22% of young women have STEMI with plaque rupture, 30% of women with CAD have concomitant diabetes, 40% of women with ACS have SCAD, 40% reduction of severe bleeding occurs if you do a radial puncture, 50% higher prevalence of depression than men, 50% higher risk of in-hospital mortality in STEMI, 70% of women would have non-obstructive and 90% of them would have Takotsubo's. So women, as compared to men, have childbearing potential and smaller arteries, and they are frequently underrepresented in trials. However, they have equivalent results whether it comes to structural or coronary interventions. So as I conclude my talk, female disadvantage in CVD has remained, whether it's personal, professional, or risk factors. And I simply love this slide. I quote it so many times because cardiology for women, and that's what we all are here, to talk about cardiovascular disease with a different perspective. And cardiology for women is not a religion for cardiofeminists, but it is very much an evolving scientific field with evidence-based data that needs to be implemented in clinical practice. And to end, I would like to say that God created men and women equal, and He created them different. Different doesn't mean that one is superior or inferior to other. It simply means different. The differences between men and women are necessary for the God-given purposes. Thank you very much.
Shiva ma'am, can we have you on the dais, please? So that was a very wonderful and enriching talk on how men and women differ functionally, anatomically, and how interventions can help women. So can we just go to the cath lab in Norway? Ujjwal, please send us to that cath lab and let's see what the final result has in it for us. Meanwhile, we can have questions.
Hi, can you hear me, Sarita?
Yeah, hi, Anja, we are with you.
Hi, thank you. So if you look at the angio, this is the final result of the DCB in the diag and DCB in the distal vessel, and we've stented with a 2.5 by 16 stent distally and a 3.5 by 30 proximally here. And we've done POT and we've post-dilated with a 3.5 NC. What happened was here, if you look at the IVUS, this is the IVUS. I'll have to go out and show you, actually, since they're just doing some dilatation here. So I'll take you through the IVUS. So you see how the vessel has grown both on angio and on IVUS, but right here, just distally to the stent, there's still a tight area, so we decided we should also put a stent here. So this is the distal stent edge, which looks fine, and just 8 millimeter distally, there's this tight lesion. So the rest of it looks very good, good area all the way up through the stent and across the diag and to the landing stone with good expansion. So we're very happy with the result. You see here the area is 8 in the mid LID. So what we've done now is that we've put in a short stent to cover that tight lesion since the rest looks so good with post-dilated, and now we're just going to show you the final result as we speak.
Yeah, so you had to cover the lesion distally with a stent only.
This is the third stent.
Yes, we
right?
did. It was just, yeah, it was the third stent. So just 6 millimeter to our stent landing, there was still this calcified lesion that wasn't really treated good enough, I thought, by the DCB.
Usually we
So this is
encounter
the final result.
Usually we encounter this after having calcium preparation by a cutting balloon. We have dissections and we are not able to put in the DCBs, and so ultimately stent is our rescue. But diagonal looks very nice. We haven't touched the ostia with a metal. DCB did its job.
No.
And the lesion is quite distal. We need not worry about that.
So this looks like a
Not at this
very
point,
good,
we're not going to
result.
do.
So much of hard work is showing here, and the vessel is looking nice. And
Yeah.
so finally,
Yeah.
that means
Yeah.
you did 3 stents in the LED, yeah?
Yeah, we did.
And one
We did.
DVT
So
with a
about
stent
40,
and one
about
DVT in
50 millimeter actually of stents. Yeah.
Overall, very good, and also
So-
we see that the diagonal ostium is also reasonably well preserved, so nothing needs to be done for that. Yeah. So very good. Yeah.
Do you funnel the stent between a 2.5 and a 3.5? Would you take a 3 to just smoothen it out? The overlap.
A 3 to what?
Your post-dilatation.
Post-dilatation of the 2.5
We've-
and a
we've post-
3.5. With a 3
We
in
have
between?
we have post-dilated. We took actually a 3.5 NC, not completely to the ostium, but on low pressures, and then we went up with higher pressure, and then we IVUSed, and it looked well opposed and not overly opposed. This final stent here that you see is the last 2.5, and the area of the vessel here was 2.75. Yeah, and we have not post-dilated the final stent that we just put in. We're going to do a final IVUS run and see that we're happy with the result also by IVUS. But by the angio, they all look very well expanded.
Right.
So
What
we don't want
about
to
the
overdo
diagonal?
it.
What size
Yeah.
DV was used in the diagonal?
2.5.
So
Is there
we used a 2.5 and we went
Is there recoil?
a 2.5.
So is there recoil?
Oh.
Was it better when you had the DV there across?
We can show you the DCB here. We will show you the DCB of the diag here. This is the DCB 2.5 at 12 atmosphere. I'm sorry, 10 atmospheres in the diag. The diag is almost a 3.0 vessel, but we didn't want to overdo it to get any dissections. So we're very happy with that DCB expansion in the diag, and it's a good angiographic result. So would you do the circ? Would you leave
No,
the
not
circ, or would you
today.
do the circ?
Enough.
No, absolutely not today. Yeah, so we've only used about 80 mils of contrast, not even that. 75 mils of contrast. But that's enough for him today. We do intend to, he came in with an STEMI, so we think we should do full revascularization, but we'll talk to him in a few weeks and hear how
I
he
see
is
that,
regarding symptoms.
I see that you're using the SS device for contrast injection. So do you do that for every case, or do you do with ultra low contrast PCI?
So, you can still do ultra low contrast even though you do the assist. You can control it the way you want it, how many mils and how high pressure you want it. So and obviously when you do cases like this, you can do most of the case almost without contrast. One setup and one final picture, and you do the rest by imaging. So as you maybe have seen here today, we didn't use any contrast until we wanted to see the result of the DCB that we did in the diag and the distal LAD. So, but obviously we have manifold sets that we use for our CTOs and things like that. But
may we know which DCB
yeah.
did you use in the diagonal? Which DCB was used in the diagonal?
So we actually use a DCB that's called Potache. It's a DCB that you can expand 2 to 3 times, and it's very deliverable. Yeah.
Because we could see the DCB moving along the length and with multiple inflations, so it's protege, right?
So in fact, if you have a longer lesion, you can use the same DCB for
Balloon.
back and
Yeah.
forth, but we don't know the data, but that's a bench data showing that the second time you inflate, about 20-30% drug will come out. The third time you inflate, another 10-15%. Yeah.
Yeah. So we usually use it only twice when we use it, and I think for long lesions it's good. And sometimes I think also when you don't, just to do the overlap zone between the stent and the DCB.
Yeah.
So
That was a wonderful demonstration of how to do diffuse coronary artery disease with heavy calcium and a bifurcation disease with a DCB in side branch. Thank you so much. And we'll move to the session here.
Thank you.
And see you again.
Yeah. Thanks for having us. Bye from Bergen.
Bye.
Bye.
So we have a question to Martha. So do you have, considering that now we are having local drug delivery with drug delivery, do you see a future where, or is there any trial in Europe that is delivering some nanotherapeutics to the vulnerable plaques?
I must say I don't know the results from such kind of trials, but I know that there are some ideas that maybe especially for plaque erosion and acute coronary syndrome, the DCB will be a good option for the treatment, because it's usually not a significant stenosis in the artery, but it's the vulnerability of the around the on the plaque on site. I don't give you the answer at this moment. I think that DCB could be a good option, but I think we don't have enough trials at this moment to say that it should be everyday practice. You know that we have different trials for DCB in stable patient, not in vulnerable plaques. I mean solution de novo, which is not published yet, and carriage-free with a prolonged observation, which showed that the result for DCB was inferior in
Dr.
comparison
Ha,
with DS.
I'm in touch with Tanvir Cheap from Oxford University. He's a basic scientist. They are now structuring proteins that would go to smooth muscle cells. So there's a lot going on there. This is but not in a clinical relevant stadium right now, but things change quickly, and if I look at the industry in India, for instance, you react so quickly, maybe tomorrow. And there is an old trial that is, I would just want to name it. It was done by Ron Waxman. It was just an oral application of rapamycin. I'm saying this because look at this case Anya just did. This is diffuse disease. You will have geographical miss even with the drug-eluting balloon. So I think it's time to study again what can be done maybe orally, maybe intravenously. I don't know which will be the way with the new drugs. But I think this is coming in the patients we have to care for now. And interestingly, this study that was done 2004 had the consequence that, for instance, in Egypt, I have a friend who is still doing this because he doesn't have the access to the drug-eluting balloon.
I would like to add something about additional therapy, especially for acute patients. Now the study is ongoing, I mean the Artemis study, but it's without intracoronary imaging, so we don't know how was the characterization of the plaque. But it's the study with ziltivekimab, so it's interleukin-6 antibody, which is injected in the acute phase of acute coronary syndrome, and it's specially designed for making the burden of atherosclerotic plaques lower and the vulnerability of the disease lower. So we are waiting for the results of the recruitation is finished and we are waiting for the results. But it was together STEMI and STEMI and without characterization of the plaque.
Dr. Marta?
So,
Dr. Marta, I have a question for you. Since patients are put on medically optimal therapy, and I see a lot of diabetic patients who refuse to go back to the cardiologist, what are the guidelines to return to the cardiologist to do another angiogram or reassess the medically optimal therapy?
It's very difficult question remark because we don't have guidelines which can anyhow to take the patient to us. It's of course all the time the talk with the patient. We know that maybe not invasively assessment, but for a diabetic patient, the cardiologic assessment should be obligatory every year. And especially looking for heart failure, it's even written in the guidelines that it should be, for example, in the European guidelines, that for diabetic patient, the measurement of NT-proBNP should be yearly done, even if the patient is asymptomatic. Of course, looking for atherosclerotic diseases is much more complicated, but I see here a huge possibility to use of computed tomography, angiography to assess the morphology, anatomy of the coronary artery, so also the severity of the lesion, but also the composition of the plaque. And we have studies which show, it is not according to the diabetic patient, but we have studies which show that with the using of lipid-lowering therapy, the composition of the plaque is changing. So maybe this idea to make the plaque more calcified is the way how should we treat the patient.
Yeah,
Thank you so much.
Thank you, Dr. Marta. So we have the great debates waiting for us. The next session is about CT in PCI, as you just rightly said, and this is a burning question. So I would just thank you, all the speakers and chairpersons. Just wait here for a photograph.
Thank you. Thank you to all the experts here, requesting everyone to please collect their mementos elsewhere. I request Dr. Agrawal to kindly do the honors. I would also like to request all the experts who have missed to collect their mementos to kindly come here near the stage and collect the mementos. We now move to Great Debates Division Angle, a thought-provoking session that brings together diverse perspectives to explore emerging ideas and clinical viewpoints, shaping the future of cardiovascular practices. I am pleased to welcome our esteemed chairpersons for this session, Dr. Rupa Salvan, Dr. Hetan Shah, Dr. J. Celicili Mary Majela, Dr. Kodru Gopal Krishnan. Joining them as member of the expert panel are Dr. Rudrani Sharma, Dr. Sindhu, Dr. Parvata Naini Nagasari Harita, and Dr. Vinod Somani. Moderating this engaging discussion will be Dr. Zakia Khan. Over to you, Zakia Bab.
Hello. I think it's going to be a great debate. People can bring their plates inside and have it. It would be a nice discussion.
Let's invite the first speaker of the debate. Is he going to be on live? I'm a firm believer in that in the future decade, later, cath labs will not be used for diagnostics. Cath labs will be used for only treatment options. The all diagnostic angiogram will stop at CTA level. That's my firm belief. Let us see what Madam is going to tell us.
Good afternoon, ladies and gentlemen. Right, so I've been put up here for the debate. CT-guided PCI is the future. So it all started when Dr. Sarita Rao calls me up and says, I'd like you to debate pro for CT-guided PCI. And I said, who's the opponent? And she said, Dr. Mama's Mamas. And I said, oh my God, that's my biggest fear. And then I thought, well, it's win cars. And we the women, we're always winners, right? So what's there about that? So I said, okay, it's all good. Now the first step is to know your enemy. So I went into the web, the big web, and I said, what's Dr. Mama's stand on complex PCI? And then I discovered that for complex PCI discussions, you need a good breakfast dosa. And that Dr. Sarita Rao made sure he got. He got his big fat Indian dosa this morning. Done deal, round one, won. Next thought, what's Dr. Mama's stand on CTA? And then I go back into the web and he says, the vision for CAD is CT and AI. Diagnostics, workflow efficiency, quality improvement, it's all there. So then that's round 2, 1. And then incidentally, for cardiologists, you've got to realize DOSA is a thing, so it's okay. Why is CT-guided PCI the future? For interventionalists, PCI has been routine, effortless, seamless. I can fix anything. I can wing it anytime. But really, everyone's not Superman. There's a lot of other which are training. They are in all different steps of being the Superman. And they don't know what it takes to be the Superman, firstly. So the success of CT in pre-TAVR and structural assessments has questioned the ad hoc reactive rather than the predictive strategy. It's ignited this new wave of ideas for PCI, and CT promises to address many concerns. Concern 1, can CT better triage patients pre-PCI? So what does CT actually promise? The volume rendered image is the overview of the heart anatomy. Then we have the 3D maximum intensity projections, which give us the 3D coronary anatomy, the disease complexity, stenosis, calcium, and the single image triage actually tells you it's a non-calcified focal lesion, diffuse calcification, bifurcation, CTO, stents. You just need this one single image, and that will guide who, where, when, what PCI. If you have a stenosis with no calcium, anyone can do it anytime, anywhere, ad hoc. But if you have a heavily calcified vessel as to the right, then you want a PCI center of excellence. You want a high volume chip operator like the man sitting here. You want the pre-planned situation. You want to know which is your advanced calcium modification strategies that you're going to use. The next concern is, can CT guide this procedure? Well, the axial images by themselves will tell you the osteal takeoff, the dominance, the guide selection, and the diagnostic evaluation. So the normal takeoff RCA 11 o'clock, LCA 4 o'clock, and if you have deviations, you know you have a case complexity, and prior knowledge is totally useful. Curved MPRs, they'll already tell you the stenosis, the location, the length, the estimated stent length, the plaque extension, the landing zone, all of that is already fed to you. The cross-section gives you the lesion morphology, the plaque burden, the composition, the proximal distal luminal diameter. So all that is already pre-done when CT is performed. And the photon counting CT, well, that's a new game because we've got very high resolution with histological correlation for the plaque. Concern 3, which is calcium, which is what I've heard through the morning where guides have gone in, haven't gone in, everything's been talked about it. And calcium is truly critical for your PCI. And the MPR tells you the precise calcium location, length, circumference, thickness, arc angle, and density. Concentric, asymmetric, and all this is really useful. And the new frontier is how hard is this calcium? Like for the aortic valve, we're now talking about AU, HU. Calcium density measured in Hounsfield units makes such a difference to know exactly which modification tool are you going to use. The extraction of this 3D calcium analyzes its morphology, length, circumference, and density, and guides the calcium modification. And then you have the guide wire bias, which exists. So the wire actually, if it's not touching the calcified structure, then whether it's going to be rotablation of the burr and the calcific disease, all these need to be questions. So you definitely need to know what is going to be your wire bias. And the prototypes now can simulate the wire position in cross-section and guide the ablative tool. Next concern, can CT plan the PCI? Well, beyond morphology, we know it's physiology that actually derives the PCI. And the CT-FFR simulates the blood flow and calculates the pressure drop across the complete vessel. So CT-FFR gives you the pattern of coronary artery disease. Is it diffuse or focal? A virtual PCI can guide the PCI strategy. It'll tell you the vessel course, the tortuosity, the angles, the delta, the virtual FFR pullback, the disease pattern, focal, diffuse, and the virtual PCI. Here you can see how you can clearly have the vessel course, tortuosity, case complexity, guide selection, planning, all done even before you go into the cath lab. The virtual CT-FFR, here you have two cases. Both of them have a CT-FFR distally at 0.63 and 0.64, but the pattern of drop is completely different. The first one is a focal disease with a major delta with benefits of PCI, but the second is a diffuse disease, and medical therapy may be the more useful way out. Concern 5, can CT guide the revascularization strategy? Well, the virtual PCI really assists in very different scenarios. If you have serial lesions, the technology recalculates the impact of flow immediately. If you have proximal, mid, or distal LAD disease, even if you put a long metal jacket, you realize that all that you'll achieve is a FFR of 0.78. So maybe the CABG is the preferred method. RCA strategy, long or short stent, again, you want to know exactly which would be the beneficial one. Next concern, can CT improve outcomes and prevent complications? Well, CTOs, various CT-based CTO scores exist, and these are actually superior to the angio-based scores. They'll tell you, is it a complete or a subtotal occlusion, calcification, stump morphology, tapered, blunt, length, multiple occlusions, bending, remodeling, linear enhancements, side branches, collaterals. It's all told to you before you even start. So the AI QCT is now going to be actually interesting, and you can put it with angiocorrelation. Bifurcation lesions, morphology and physiology are both equally important here. The CT derives the myocardial mass at risk for every segment of your coronary artery. And so the vessel-specific myocardial mass at risk is extremely important. You need to know whether that side branch needs protection, and this is really important in the bifurcation lesions. And then, of course, you have the advantage of functional evaluation by virtual PCI. Post-CABG, Prior information really makes it very easy for the target vessel. And so you want to assess the graft, their origin, their course, their termination, their distal runoff. You want to see the old venous graft, is there stenosis or stenting? And bypass CTCA trial is now looking at the results which are superior with CTCA and ICA put together. Concern 7, competition. Imagers are spoiled for choice. And CT, IVUS, and OCT evaluate the calcific plaque quantification, their arc, their circumferentiality, their thickness, their length, all of it. And there's an excellent correlation between CT and IVUS for plaque composition and with OCT for calcium length. So CT definitely complements or in fact trumps intravascular imaging because it's non-invasive, pre-procedural, 3D plaque assessment and in all the 3 vessels. Concern 8, medicine is all about evidence, and we now have the P4 trial, which is aiming to establish the non-inferiority of CCTA to the current standard of IVUS. We already have the Octavis, which has compared OCT and IVUS and has actually made them comparable. So CT has taken on the cath lab challenge. The best PCI begins before the catheter enters the artery with the CT. And guess who tweeted as we speak? Thank you so much.
Excellent beginning. Can we now invite Professor Mamas for his talk?
Fabulous talk as expected. It's great to be here. Can you hear me? Hello, can you hear me? Oh, fantastic. Well, first and foremost, I'd like to thank the organisers for inviting me. It's a real pity that I haven't been able to come. I think it must be a first that 3 flights, 3 bookings were cancelled, and the latest one on the last day prior to my arriving there. But I've been very impressed by the standards. The live cases have been superb, and I've really enjoyed watching the presentations. So over the next 8 minutes or so, my focus is going to be about image-guided PCI. This is how I do it. And we've heard from Dr. Mona Bhatia, one of the icons of Indian imaging cardiology, and I agree with a lot of what she said. But I think the nux, or the main point of this debate is what cardiac CT cannot do. And I think really this slide summarises the debate to me. I think cardiac CT will tell you whether you should do the PCI. It will tell you how to plan to do the PCI. What it won't tell you in real time, which is the strength of intracoronary imaging, is whether your strategy is working. Are you doing the procedure correctly? Do you need to change strategy? So, you know, the rotablation or the lithotripsy that you've used, has it actually worked? Has the calcium fractured? It won't tell you how well you have done the PCI. And I think that's important because, you know, we often talk about image-guided PCI, but actually image-guided PCI is only useful if you achieve the parameters that you set out to achieve of an optimal PCI. If you don't achieve them, then using image-guided PCI is a rather pointless exercise, and I'll show that because the outcomes are no different from angiography alone. And finally, intracoronary imaging will tell you the patient risk from future target lesion failure. So I think intracoronary imaging will tell you or provide all the information that cardiac CT provides, but also will provide you real-time intraprocedural guidance. So what do? I mean, that was the remit. So first and foremost, I use intracoronary imaging to ask myself, do I need to treat the lesion? So for example, you know, one needs to assess the characteristics of the lesion. So in acute coronary syndrome, is this an erosion? Is this a plaque rupture? What's the MLA? If the MLA is good, you can leave it alone. What's the etiology? Is it SCAD? It's important that you assess the vessel size, plaque burden, particularly for risk stratification. I use it to assess the lesion, so the anatomy, calcium, thrombus, I use the information to help me define the strategy. Is the side branch, does it have significant plaque burden? What is the calcific burden? How deep is the calcium? How long is the calcium? What is the nature of the calcium? And all this information I use to guide my PCI. I think, importantly, it will tell you whether you actually need to do the lesion, and this is some data from the LITRO study, for example, for left main, arguably one of the most important decisions that you have to take, whether to revascularize angiographically significant left main disease. And this showed that in patients with an MLA of greater than 6 millimeters squared, deferring PCI gives you similar outcomes to those with significant IVUS that you undertake PCI. So it shows that actually you can use intracoronary imaging to defer PCI lesions. Also, do we need to stent? This is data from the erosion 2 trial, showing that in those with an erosion with a reasonably sized MLA, leaving the lesion alone, you have acceptable MACE rates. So again, intracoronary imaging is not only telling you how to do the PCI, but when you don't have to do the PCI. And again, as far as I'm aware, cardiac CT is unable to define erosion versus plaque rupture. During the case, I think intracoronary imaging tells you important information such as whether your lesion preparation is adequate, whether you've had adequate fracture or preparation of the calcium, particularly if you've used, say, rotablation or lithotripsy. Has it had the impact that you're hoping to have? In CTO cases, imaging will tell you whether you're in the true lumen for CTO. In bifurcation cases, it will tell you whether you've crossed the correct strut for a bifurcation. It will tell you whether your wire is in the lumen or behind the stent following rewiring. And actually, when you undertake PCI, you often undertake several runs for each case during the case. Clearly, it would be unfeasible to stop the case, send the patient back to the CT scanner, do a CT, bring them back, carry on the case, stop, send them back to the CT scanner again. That's science fiction. It wouldn't work. So I think intracoronary imaging gives you a live step-by-step update of each procedural technique that you're doing and each procedural point that you're at. And we talk about calcium, and we know that calcium's important. The reason calcium's important is, and this is a meta-analysis from 18 trials, showing that intracoronary imaging-defined calcium is associated with increased risks of target lesion failure, death, MI, and so forth. And intracoronary imaging will give you important information around calcium, both its distribution, its thickness, but also, importantly, the type as well, whether it's superficial, whether it's deep, whether it's nodular, if it is nodular, whether it's a non-eruptive or an eruptive nodule. And again, cardiac CT can't make this difference between eruptive and non-eruptive nodular calcium. And the reason why this is important is that they behave very differently following PCI. So eruptive nodules are much more easy to expand with regular balloons, but they have a very high rate of target lesion failure, whereas non-eruptive nodules, you need to use things like rotablation or maybe even lithotripsy in these sorts of cases, but their outcomes are slightly better in the longer term. Intracoronary imaging will again give you important information around optimal treatment of your calcium, and there are both IVUS-based scores and OCT-based scores that can give you information about whether you need to use calcium modification strategies, and if you do, whether what the optimal means of treating your calcium is. And finally, image-guided PCI is useful in assessing the stent result. Is my expansion optimal? Have I covered all the lesion? Do I have stent problems such as dissection? And really, the most important determinant of target lesion failure following PCI is how optimal your stent result is. Cardiac CT cannot give you this information, or it can at the end of the case, but then if you find that it's not optimal, there's nothing you can do about it unless you hope to do a second procedure. And so, we use MLD Max to tell you how well you have undertaken your PCI and whether your PCI result is optimal. And this is a paper that we published a while ago showing that optimal PCI is important in that if you don't attain image-guided endpoints, your risk of MACE, myocardial infarction, repeat revascularization and all-cause mortality is increased. So it's not only using intracoronary imaging, it's using it to achieve optimal results. And this is really my final slide, in that if you use imaging but you don't achieve an optimal result, your outcomes are no better than angiography alone, i.e. not using imaging. And the same would apply to CT. If you're using CT to plan your case and you result in a suboptimal PCI, your outcomes would be no different from not using CT at all. And so that's really the crux of the argument here. I think CT is a fabulous modality, as Dr. Bhatia has shown, in helping you predict whether you need to do the PCI. It's a fabulous modality in helping you plan the PCI, but it lacks the ability to give you real-time guidance for your procedure, and most importantly, whether you have done an optimal result. So I think in conclusion, intracoronary imaging gives you real-time procedural guidance. It tells you whether your PCI is optimal and it improves outcomes. I know that this is a debate. I think in the real world, how do I predict things that are going to happen? I don't believe that there is going to be any role for angiography in the future. I think it's all going to be CT guided. But once you get to the cath lab, that's where intracoronary imaging comes into its own. So with that, I thank you and go back to the panel and congratulate Dr. Bhatia on an excellent presentation.
We now invite Dr. Mona to give her rebuttal.
Can I have the rebuttal? Thanks, Dr. Mamas. That was excellent. And we're all friends here. And we do realize there's going to be layering of all kinds of investigations. And the more we have imaging, the more we get better and better at it. So, no, it's the other one, the rebuttal. It's the other presentation.
Dr. Mama's expressions. Do you really have a rebuttal? Look at him.
Okay.
I can't see the screen. That's the problem. So I can see the wonderful panel and the wonderful speaker, but I can't actually see the screen.
Fantastic. That's how I like my enemy needs to be blind to what I'm doing. Right. Okay, so referrals that come. Stent fracture, occluded, pseudoaneurysms, RCA jacket with this huge leak, and it's almost looking like a mass in the right atrium. You've got post-CABG pseudoaneurysms, ruptured LV going into the RV, post-AVR, and you can see this osteal stenosis. You would never know that why this patient post-AVR came back with angina. So what's really changed? What's changed is we have this amazing hardware, we have the right software, we have efficient systems, we have the right data, we have the right technology, we have the right collaborations, the right innovations, and we have lots of pivotal trials. And there is no doubt, like Dr. Mama said, that, the thing is, everybody today comes with a CT because in chest pain guidelines, you've launched CCT as a class 1 indicator. So if everybody has a CT, might as well use it and use it constructively. And the CT base is going to give you your morphology, length, diameter, and physiology for the virtual PCI. So we definitely need to bridge this gap between the CT and the cath lab. We need to synchronize them, co-register them, and help them do the live guidance. You can have your optimal angles, live interactions, stent lens positionings, and understanding foreshortening. So why drive blind? You've got Google Maps, and you want to go blind into the PCI. Why? It's a no-brainer. Get a CT. From anatomy to strategy, CT enables precision PCI planning. So definitely, just go get that CT scan. And when you look at that comparative, you've got to realize its key advantage is it's non-invasive. You get the full heart, the full coronary tree overview. You have a pre-procedural planning. You have the virtual FFR prediction. It's minimal contrast, minimal radiation. You've got the post-PCI FFR already planned for you. And it's really low in cost. I mean, in India, you could go all the way from, a couple of hundreds to 20,000 bucks. Resolution may not be to the level of IVUS and OCT, but yeah, we can always mix and merge and layer the tests. So the future of the cath lab starts with CT before the patient enters the cath lab. And that's where it's going to be. CT decides the PCI, CT plans the PCI. The OCT and the IVUS can optimize your PCI, but the future definitely will be CT-guided PCI. Thank you.
Dr. Mamas, are you there?
I'm here. Can you hear me?
Your rebuttal.
Well, my rebuttal is I sort of agree with a lot of what Dr. Bhatia has said. I think that there's no argument that I think the days of angiography should be consigned. I mean, I was one of the forecast FFR trial investigators. So I think CT is important for planning, but when you look at the result of the PCI, the biggest determinant of outcome following a PCI is whether you have achieved image-guided parameters, i.e. an MLA over 5.5 expansion over 80%, whether you've landed your stent in an area of plaque burden of greater than 70%. If you don't achieve those parameters, your outcome is no better than angiography alone. And so irrespective of whether you've used CT or you haven't used CT, if you do not achieve those parameters, you're going to have high target lesion failure rates and outcomes that are no better than having not used CT. The only way to check whether you have used those parameters during the procedure is with intracoronary imaging. So where do I see the future? I mean, I personally see that everyone will be having a cardiac CT. I think the cardiac CT will provide information around the lesion characteristics. It will provide information in relation to risk stratification. And we know that Scott Hart, for example, improved clinical outcomes in a CT-guided approach. I think thereafter, once the decision to undertake PCI is taken, then that's where intracoronary imaging will take over. And that's where intracoronary imaging will provide real-time guidance for your PCI and an optimal PCI. I don't think that CT will have any role after the point at which the decision to undertake the PCI is taken. That's my rebuttal.
We had an excellent debate. When we talk of CT and guidelines, so far guidelines have talked about CT coronary angio in chronic stable coronary syndromes. When you want to decide whether you want to continue medical management, you want to revascularize the patient. And also a lot of our CTO operators, especially when they deal with calcified CTOs, they prefer to have a CT beforehand. But when it comes to precision PCI, I think precision PCI is about selecting the right patient, doing the right procedure, and putting your stents optimally to give the right outcome, which actually is live. And only imaging can help you with that. So PCI, best of PCI or the precision PCI is always imaging. But when it comes to decision making, whether you want to do medical management, when you want to do revascularize, I think CT angio can help in a chronic stable angina. That's what is my take.
Yes, so in my center.
That's my take. Any questions, any queries from my colleagues?
So we don't do angiography in my centre anymore, we use coronary CT. We do CT-FFR and coronary CT for all the chronic coronary syndrome cases. So I completely agree with Dr. Bhatia in terms of the planning and in terms of the selection of cases that get to cath lab. I think there is no place for diagnostic cardiac cath for CCS cases at least. And, you know, personally in my centre, we do cardiac CT for all of these cases.
I think I agree that TCS, there is a guideline that you want to rule out the high-risk cases. If it is a left main prox LAD, then your management differed from the medical management. My question is, like, if there is a high calcium score or a high BMI, you can visualize the soft plug on the CT. And CT also carries a lot of radiations also. So if we combine both, are we adding more radiation hazard to the patient? And can we, like in a calcium score, like elderly person, they comes with atypical symptoms, and there is some amount of non-invasive evidence of RWMA or something, and I want to rule out, I don't want to do invasive, but where a radiation expert says that, madam, it is a elderly person, calcium score is high, you are not going to see the soft plug. So how we can address such thing?
So I think first of all, as far as the radiation is concerned, the radiation of a CT is like less than 1 millisievert at this point. So it's less than taking a flight to New York. So you're pretty okay. So I don't think we should talk about radiation anymore. We haven't managed to learn to take out radiation from the body, but we don't give any radiation.
It should be what, this thing?
Sorry?
What software, like certain, in
No,
India,
all of our new
certain,
CT scanners are
yeah,
barely giving any radiation. It's very low.
Okay.
So it's like all these 256 slice scanners are very fast. And if you've done prospective gating, you're literally at 1 to 2 millisievert and not more. So there's no, the radiation is behind us.
Is out.
As far as the calcium is concerned, yes. The thing is that it's really important for people to not just sort of cancel out a CT just because there's calcium. Because that is exactly why you do it. In a CTO, that's exactly what you want to see. And if you do it at the proper KV levels, you can tell where there is a nodularity, what is the arc, what is the thickness, and what is the calcium number. Because that calcium number will tell you whether the IVL will work, the rota will work, what will work. Because if you have really thick, dense nodular calcium, if you did an IVUS or an OCT, you'll just get one blob that there's calcium. You will never know that number of the calcium. Why do you turn around in the TAVR and say, what is the number of that, how calcified is the aortic valve, right? We are asked, is it in the thousands or is it in the 10,000 or 8,000 or 4,000? It makes a difference to how you think. And that's what we are forgetting in the CT scan. You need to know how hard is that calcium to know which device will work. And maybe it needs a trial where you want to see how hard does the calcium get and which burr really works on what. I think we really need to put that into a trial.
But our radiologists, they don't report if there is a calcium score is high.
The difference in your radiologist and my
that
radiologist.
is a soft plug. They can't differentiate if there is a hard evidence of significant high calcium score.
I think the level of...
That is a majority of the radiologists.
I think the level of plaque characterization is very high now with the good CT scanners. And you can not only tell whether it's a vulnerable plaque, calcified, PVAT, whatever, everything. Okay, Sarita Rao's here.
Ma'am, that was a great talk, Dr. Mona and Professor Dr. Mamas. Actually, definitely pre-PCI, especially in CTOs and post-CABG, CT planning prior to PCI is definitely useful, and intra-procedural, definitely intracoronary imaging is very essential for modification and other things. But one small comment, for a recent patient, 33-year-old, who presented with acute chest pain, actually we did an angio and there was a huge coronary cameral fistula coming from the left LAD, and we were not sure how to go about with this case. He was 33 years. So at that time, definitely CT was very, very essential. We were able to play, it was a confluence of LAD, RCA and phrenic artery, and CT was very helpful for the procedure. I think certain times definitely CT has a great role.
Interest of time, we should wind the session up.
I think we'll wind the session up. Yeah, thank you so much.
We all complement our work, and there's no competition and there are no enemies.
Hello. Requesting everybody to please come to the center for a picture. All the speakers also to join them. Requesting everybody to please come from the right side to receive the memento.
Our next session on the agenda is the evolution of scaffold from bare metal to 4th gen DES, a session that traces the remarkable progress in coronary stent technology and its impact on contemporary interventional cardiology practice. I am pleased to welcome our esteemed chairpersons for this session, Dr. V. Surya Prakasa Rao, Dr. Ashok Seth, Dr. Stephen Herb, Dr. Hema Malti Rath, Dr. Yakiko Morito, Dr. Saiko Takahashi. Joining them as part of the expert panel are Dr. Ruchi Gupta, Dr. Somyata Somendra, Dr. Sujani V, Dr. Prachi Sharma, and Dr. Deepthi Gali. Moderating this session will be Dr. Priya Palemkar. May I request all the experts to be on the dais, please? Over to Dr. Priya.
There is a slight change in the schedule. The live cases are ready. So we will take the live cases first and then the presentations.
Hello? Could we have the mics on, please? Mics.
Good afternoon, everyone. So we have the first live case. Ma'am, can you hear us?
Yes, we can hear you.
Could you please introduce your case, madam?
Right. So let's go to our case, please. Yes. So this is a gentleman in his mid-60s. He was diagnosed with a non-ST segment elevation myocardial infarction on the 5th of this month, and he underwent PCI to RC at that time. He's hypertensive, has COPD, chronic kidney disease, and an ejection fraction of 45%. Next slide, please. So this is his left side. So he has a left main of 50 to 60% stenosis. The LAD has long segment lesion, 90 to 95%, extending up to the mid segment. LCX, as you can appreciate, is highly tortuous, and we found that it was quite calcified with subtotal occlusion. So this is what his left side looked. The right side, we treated a dominant vessel, pretty diffuse disease, and we treated the, can we go to the next slide, please? We treated the PLV with a 2.5 by 48 millimeter drug-eluting stent. Now today, what did we do? Actually, I think we're running a bit late, and our patient was getting quite restless. So we had to proceed with the case because it was quite, as you can appreciate, quite a severe disease. And once we had wired the vessels, and then there was this 30-minute lapse, so we had to proceed. So what did we do? We first wired the LAD, and as you can see, this was also quite a bit of a challenge. There was this bit of calcium there which was obstructing our wiring, and we managed to wire eventually with a run-through floppy wire. After wiring the LAD, we went on to wire the LCX. And the LCX was really challenging because of the tortuosity of the vessel as well as a subtotal total occlusion in a mid LCX. Eventually, we needed a filter XT to wire this vessel. We changed the filter XT for our workhorse BMW wire once we had wired the vessel with the help of a fine cross microcatheter. After wiring both the vessels, we proceeded to do IVUS. And the IVUS was quite eye-opening. So let's go to the IVUS, please. So if we go to the IVUS, can we switch to the IVUS? So this is the run from the LED, as you can see. It's quite a large vessel. And then we have this huge amount of fibrocalcific plug. Can we go a bit more faster? And the most tightest portion, as you can see, was only 1.4 millimeters MLA. And there was quite a bit of calcium. There was napkin ring calcium as well. And then it was really fibrocalcific. This is the distal left main, quite a tight lesion. Can we go further? And then we see the LCX coming at 7 o'clock position. And the distal left main was also diseased. And when we did a run from the LCX was similarly diseased, fibrocalcific lesion, mostly fibrotic in the LCX. And the ostia of the LCX was also significantly diseased. Its ostia, as you can see, the MLA is, what was the MLA, please? 2.9. And then we went into the distal left main, which was also very tight with an MLA of 4.23. So clearly by definition criteria and IVUS criteria, a Medina 111 lesion and angiographically as well. So we were thinking of trying to keep it simple, obviously. So first of all, with the severity of the lesions, we decided to prepare the lesions, and as we had seen in the LED, there was a lot of calcium there. We decided to use a scoring balloon. So we took a 2.75, this is a 3x10 scoring balloon, and we used this 3x10 scoring balloon through the entire length of the lesion. After using the scoring balloon, we went on to tackle the LCX, and for the LCX we used a 2.5 by 20 NC balloon. After lesion preparation on both sides, we saw that there was a bit of dissection, more so in the LED and also in the LCX, and so we decided that as these were moderately large size vessels, there's dissection, and the lesion is quite long in the LCX, we opted to go for a double stent strategy here, and we thought that we would go for a DK crush. So for the DK crush, we had already prepared the lesion in the LCX. Yes, please.
Fazala?
Yes.
Dr. Ashok Seth here.
Lovely hearing your voice. Yes.
How are you?
Dr. Sheth. I'm good, thank you. How are you?
Very good. We just wanted to have a bit of discussion. I think you got a tremendous case there. Just wanted to understand, what was the ejection fraction? 40% you said?
The ejection fraction is 45%.
And where was this infarction? Because all the three vessels were pretty bad. So was it an inferior infarction? Is that why you tackled the RCA first? What was the, which was the area of infarction?
It was a non-STEMI. So actually, all the vessels were, but when we first tackled the RCA, it was a bit hazy on that day. And there was, the ECG changes also more in the inferior region. So we opted to treat the RCA at that point. Now this patient, he has chronic kidney disease. He's COPD. He's got quite severe lung disease. And we did have a discussion with the surgeons, and they were not very keen, and the family as well is not keen on surgery, so we opted to go for a PCI, and we obviously staged the PCI. So we did the RCA first. He did well for these last few days, and today we are tackling the left side.
Right. So anyone in the panel has any comments on this case? Now this is for PCI, so the discussion is not PCI versus surgery. We're already doing a PCI. It's now got to be more to do with the strategy around the PCI on the left main bifurcation as well as the LED and circumflex.
The heart team approach is very important, as Dr. Ashok said. And it's a syntax score very high. Yes, because of surgical refusal. The issue of CKD is there. So when you plan angioplasty, out of all the 3 blood vessels, which one you handle the first one? That's the first thing. Next is you have to do a ultra low contrast angioplasty in this case anyway. Good, they did not do any OCT, but they can have done some Dextone or saline OCT. They can do it to profile in a better way the calcium. I think this case needs a staged procedures which she is doing perfect.
Yeah, I think the anyone has any comments? Because Fazil has already done part of the case, and therefore we can discuss, because she's just going to show us exactly what she's done. But the strategy seems to be, I mean, both vessels are high grade. And there is calcium, you can see it right there. But the quantification of calcium was approximately 270 degrees from what I could see at that point. It was not 360 degree circumferential. That was an intelligent move to keep it simple. This extensive disease process, unless it's calcified to a longer extent with nodules as well as extensive 360 degree calcification, one would try and keep it simple with a balloon and see how it does with a balloon before calcium modification tools are used. Obviously, I'm surprised that IVUS went through that high-grade lesion, because I think Fazila would have pre-dilated it prior to passing that IVUS. IVUS is not easy to go through heavily calcified, long diffuse disease segments with tortuous anatomy. And that was certainly not possible in the circumflex. So Fazila, I think what you've done is pre-dilated with cutting balloon or scoring balloon, which was quite adequate. But 2 important points. At that calcified segment, which we see right here in the LED, did you get a complete expansion of your non-compliant balloon or your scoring balloon in 2 orthogonal projections? Because that's what you really want to see as the most important surrogate endpoint for adequate dilatation. Otherwise, calcium modification is needed.
Absolutely, I totally agree with you, and I think that's a very important learning point that we have to keep in mind when we are dealing with calcified lesions, to take orthogonal views, make absolutely sure that we've done a proper job, and then proceed, right? Because this gentleman does have quite a bit of calcium, and you really want to do a proper job of tackling that and preparing your lesion before deciding to do anything further. So yes, we did do that. So we really made sure that the lesions were well prepared. And as you say, we were very surprised that our IVUS did go, but that was also a reminder that maybe we would not require any atherectomy device. Rather, we would be able to get away with a scoring balloon in this case, which we were able to do so. So after proper lesion preparation, as I've already mentioned, we decided to go for a DK crush. And so we first tackled the LCX as is done. And we took a 2.75 by 48 millimeter Zion stent. We deployed it. And then we did the post-dilatation as well. Usually we don't do that, but here, you know, there was this concern, as you have also said, that it's a calcified lesion, and we want to be absolutely sure that we've done everything properly. And once we did pre-dilatation, after that, we did our crush. So we did the crush with a 4 by 10 millimeter NC balloon, and we crushed. After crushing, we rewired the LCX, and our wire went fairly easily. And after wiring the LCX, obviously we did our first case. After the first case, we removed the wire from the LCX and we stented the LED. Again, we used a 3.5 by 48 Zion stent. Now here also, we did post-dilatation, we did our first pot, and we did our rewiring. After rewiring our second case,
so Fazila, we'll stop you here and say rewiring. Can you just explain to us what struts do you go through in terms of your rewiring?
Yes, so with DK crush, usually it's a customer, initially the authors, they wanted the proximal strut. But nowadays I find that, going to the middle strut, and which they also advocate nowadays, so either the proximal or the middle. In this case, we went through the middle strut.
Good. So you're redistributing, during the second wiring, you're redistributing the rewiring, you're redistributing the carina practically on either side rather than having a major carina on a huge carina if you really went proximally. So I totally agree with you around going through the non-distal strut. Proximal, but more likely mid.
Sir, would you like to go for a rotor orbital, such a long diffuse calcific disease with 45%, not that bad?
Personally, I think want to keep it simple. Both lesions are very long lesions. If we rotablate, we have to have a very good reason to rotablate. They had imaging. Most of the calcium was deposited in no more than 10 millimeters of the disease segment because it was fibrocalcific throughout. You have debris, you have other issues, you can have hypertension, and both lesions were tight, including left main. Having thought through that, the next step was what she did. 2 orthogonal projections, optimal size balloon, probably a 3 millimeter at 18 atmospheres in 2 orthogonal projections. And if that's inflating well, absolutely fine. If that doesn't inflate well in a 3.5 millimeter vessel, you wouldn't do a rotor. You would just, at the point where it is constrained, is all that you will deal with an IVL. So smaller vessels, yes, rotor. Larger vessels, the backup plan is an IVL.
Sir, would you like to put a metal jacket like that, or you want to do some stenting of the proximal critical lesions and do a DCB in this?
See, if I have in long lesions, and by the way, the best way to keep everything simple is to have a combination of DCB and stents. There's no question. Multiple stents have been done away with now with the advent of DCB in multiple. But what's very important is to have a good outlet to such long stents, or even shorter stents have a good outflow. So if you really had a very distal disease or mid to distal disease and had a good diagonal or a good septal prior to that, I would just send proximally and do DCB distally. But if it was a continuum of a disease process, then I wouldn't leave dissections beyond any left main bifurcation stenting. I would perhaps could do it in another vessel, but left main bifurcation stenting, I wouldn't want to leave distal dissections beyond optimal stent implantation. Okay?
Sir, at least
it's an outflow issue. An outflow issue is very important.
At least an IVL balloon was could have been used here for the longer lesion where there was calcification.
Yeah, it's the extent of calcification and non-yielding calcification in this case. And she decided correctly. She said she had optimal dilatation at that calcified point in 2 orthogonal projections. And believe you me, nothing is better than an optimal size balloon in 2 orthogonal projections to tell you implantation and final MSAs. Not even imaging.
So, Dr. Fazila, you want to tell us what you went?
Yes, so we did final post
Can
dilatation.
you adjust the volume at your end? It is a little muffled.
So please go ahead.
Yes, so we did post dilatation. We did report, and then we did our final angiography and IVUS. So this is our final angiography, and can we another view, please?
So did you do high pressure dilatations all along these long stents?
Indeed. We went up to 24. That's very important. That's a very important and valid point. You really have to go up with your pressures. Make absolutely sure that your post dilatation is spot on to make sure that the struts are well opposed. Especially this is left main. It's a calcified vessel. It's tortuous, especially the LCX. So the best possible way to get great long-term results is to do a very good job of the post-dilatation.
And can any of the panelists comment on that under-dilated segment in the LED that you all saw? Fazila, could you please show us the cranial view?
The mid-segment.
Epicranial, please.
Which was your main calcified point, I guess.
Yes.
So we had a look with the IVUS, and that titles portion was initially 1.7, and now we've achieved MSA of 7.73 over there. So, I mean, angiographically, it does look a bit tight, doesn't it? But that was our tightest portion pre-procedure, having a MLA of 1.5 or something, 1.3. And now we've achieved 7.73. So we decided, you know, I mean, we were happy with the reasonably good result, and we didn't strive for, because we'd gone with 24 atmospheric pressure there.
While we did not see your IVUS very clearly, that
You
truly
didn't see that.
represents a
Can you show
nodule
the IVUS again?
or a
Please.
very
Show the-
eccentric
Looks
drop
like
of calcium.
calcified nodule at that point, which is probably crushed under the stent struts. Maybe IVL at that point.
That's the place. You just saw that.
After stenting, if at all, we have to address this. What would you suggest?
So that looks bad to the eyes, correct? Doesn't look nice. Everything else looks well dilated. So who's going to go there with a larger balloon? Anyone for a larger balloon? Larger non-compliant balloon? None? Anyone for an OPN? Why not get rid of that stenosis? Any comments on
I
that?
think OPN is a good choice in such a case where we had pre-dilated the lesion well, and we can go with the 1:1 sizing and at higher pressures.
So just a comment that if you went in she did a 3.5 at 24 atmospheres, if you needed to go with an OPN, it wouldn't be 1:1. It'll actually be a 3 millimeter at 40 atmospheres. That's the first step that you really need to understand. Because when you take an OPN at 3.5 and go up to 40 atmospheres, 35, it grows by 12%, it'll become 3.9. And that's a sure rupture of the vessel. Second point is don't go with an OPN. Look at MSAs. MSAs are your endpoints. That eccentric nodule is only not going to go anywhere, but your other side of the vessel wall is really going to rupture at high pressures. If you, in a 3 millimeter vessel, achieve a 5.5 MSA, you've achieved greater than 80% because a 3 millimeter vessel is equal to 7.2 millimeters square, and you've achieved 80% already. That's why the 5.5 figure came in for a 3 millimeter vessel. But if it was proximal, osteoproximal LAD, where you want to achieve greater than 7 or 8, because a real vessel, a 3.5, is 9.6 as a square millimeter, or a stent should expand to 9.6, and 80% of that is anywhere above 7 millimeter square.
I think
So
the other
8 millimeter square is what you want from an ostium of the osteoproximal left main, and on the mid segment you just want greater than 5.5.
The other live case is also ready, so
So we
would
should
like
go to that.
switch to that.
So Fazila, that's a great result, and you had a what sort of area MSA did you have in the left main?
In the left main, please, can we go to the left main, MSA of the left main, please? 13.89. Can you show it? 13.89.
That is excellent.
Yeah. Thank you, Dr. Fazila,
Thank
for a
you.
wonderful case. Heavily
Thank you.
fibrocalcific vessels and a very nicely done DK crush with good MSAs at the end of the procedure.
Thank you.
Thank you so much.
Thank you so much. Thank you.
Well done, Fazila. Always great. Your team's great.
Thank you. Thank you. Very grateful.
We'll move to the next cath lab now. Dr. Mary. She's going to be demonstrating a TAVI case. Can you hear us, doctor?
Yes, so we
Can
can
you
hear you.
introduce your case, please?
Yes, so it's my pleasure to be here with my team that I am with Greta Cattaneo, the second operator, Jessica e Valentina, the technician, Elisabetta, Irene e Patrizia, the nurses. Now, Greta will be introduced the case.
Next. Thank you. Today we present a case of a 70-year-old man with severe aortic stenosis, symptomatic for worsening dyspnea in the last month. The patient is quite fit, and he has very few comorbidities like hypertension and dyslipidemia. He takes some drugs, but he has perfect renal function, no kidney dysfunction, and perfect exams. Next. And during this month, we performed an transthoracic echocardiography that show a preserved left and right ventricular system function with ejection fraction above 60%, and confirm the severe aortic stenosis with medium gradient 42 and with approximately EVA 0.9 centimeters squared. And then next. And then we perform a pre-procedural planning with CT scan, and in particular Crohn's and cardiac CT. And next, you can see the measurements, and in particular the annulus dimension. Perimeter is 80 millimeters, and the area is above 510. And next, you can see also the level of T and the calcium quantification. And next, the heights of coronary left and right is permissive, and no problem of obstruction during the procedure. And also you can see that there is no calcification in LVOT, and this is important for the safe of the procedure. Next. And this is a relative horizontal aortic because the angulation is 51 degrees. And then you can see the three cusp view and the cusp overlap that is useful for the procedure. Next. This is also the vessel access that is fundamental for the diameter, and also there is no calcification and non-tortuosity. So this is a good point for this procedure. Next.
So the CT scan recap, we have a tricuspid aortic valve, moderate lift calcification, so probably we perform balloon valvuloplastic before the implant of the valve. Low risk of coronary obstruction because we use a small short frame, and a good femoral access, 10 to 11 diameter. Moderate tortuosity of aortic root, and relatively horizontal aorta. Next one. So we are planning to use a MyValve Octave Pro Plus 26 with a 4.3 oversizing. Next. And this is our strategy. We perform the procedure in local anesthesia and in fluoroscopy guidance. We use the left artery femoral axis as a diagnostic axis and protection of the therapeutic axis. And we use as a therapeutic axis right transfemoral axis, and we use ultrasound guided to do a puncture. And we put two Proglyce devices. And the pacing will be done with GL 3.5 for French and 0.035 wire in right ventricle. We use MyValve Octave Pro Plus 26, and to remove the sheath, we use a crossover balloon occlusion technique. So if you wanted to show where we are now, we are already started with the procedure.
We take the access, and in particular ultrasound guided access, and you can see the second one and the vein. We take the vein for the first, and also you can see the fluoroscopy, and then we take the second access left artery, and then we doing an angiography to check the bifurcation, and also we check the bifurcation with echocardiography, and then we go above the bifurcation and we take the main access. Then we insert the introducer and we cross the valve.
So you can see the pressure, the measurement of the pressure in the screen. I think you can see. I don't know. And is 47 the medium gradient. so confirm the aortic stenosis. So we proceed to put the Safari small wire inside the left ventricle and to do the valvuloplasty with 20 crystal balloon. Okay, this is the way.
Okay.
If you have
remove the pigtail and then also the 6 French.
Okay, okay. So we remove 6 French. Now we perform dilation of the introducer. The introducer is expandable sheath. So before we introduce with the 14 dilator, then we use 18 dilator before to go inside with the balloon and the valve. Sento un po' male adesso, signora.
So, is there a pre-existing bundle branch block on the this patient? Because I could see that on the ECG earlier.
Yes, it is a pre-existing.
Yeah.
Yes. So, sorry. Okay, spingi bene la qui. Okay. It's a little bit hard to open the sheath, but controllate la pressione. Okay, now we go with balloon, please.
Yeah, so you're putting a 26 millimeter valve and your pedal balloon is what size?
It's a 20.
Is a 20?
20. It's only to permit to the valve to go inside without problem, without friction. I prefer to do this normally.
After the case, we'd like to discuss with you your oversizing in this case.
Yeah.
Less calcium, tricuspid valve, something which I would have really gone with at least a 10% oversizing if it's a tricuspid.
Yeah.
But are you concerned about the outflow tract calcification? Is that what's preventing you from being appropriately oversized? Tricuspid moderate calcification for me means at least 8-10% oversizing rather than 4%, which is what I see for bicuspid valves.
Yes.
So, no. So we need to. So we test the pacing because it's good. Ok, prova. Sì, prova a farlo.
Pacing on.
Sorry. No, yes, ok.
Yeah.
Stop.
Però non va bene.
Allora, che pacing, andiamo nell'altra.
180.
Okay. 180 the pacing, so go up, vai.
No, c'è la pressione di...
Vai un pochino più. Stop pacing. Sorry,
Stop
we have
pacing.
a problem with the pacing. Vai dall'altra parte.
We need to reposition the pacing because improve the capture.
Prova a fare un test. Sì? No, come se non... Prova ad andare a 100 a una frequenza inferiore perché lo spacing ce l'ha e anche rapido. Sì, grazie. So if we don't count in this way, normally it's okay. Prova a fare adesso, aspetta un attimo. Aspetta un secondo. Wait, sorry. 2 minutes. I'm sorry for that. Prova.
No.
Sì, adesso sì. Ok. Si stacca. Perché non sono stabile con il...
You know, in a patient with pre-existing bundle branch block, maybe you should consider having a proper temporary pacing wire and...
Yeah. In realtà funziona sempre. Stop oppure il pacing. Mettiti in obliqua di là.
Siamo in obliquo a destra.
Non so perché non funziona, ma funziona sempre. È attaccato tutto, sì. Prova adesso la pacing.
You can comment on sizing of the valve if you're telling it's undersized.
Se no, passatemi il pacing classico.
Sì, perché questo non va. Così non va, perché è il suo ritmo.
Prova adesso. Ma stai attaccando? Lo so. Prova adesso.
Aspetta che
stop.
No.
Aspetta. Aspetta, adesso prova.
Ok.
Stop. Stop pacing.
Torniamo
Ok.
di là.
Vai di là, non toccatelo di un millimetro. Ok.
over
So now
the
it's
wire?
working. So,
Now we are
vai.
ready.
O dopo nel caso lo
Temporary
facciamo.
pacing
Vai.
is not very stable.
Rapid pacing.
It's not even temporary pacing, it's
Ok.
OC5
Ok,
wire
pacing.
pacing.
It may not
Vai.
be good.
Okay.
Yeah, exactly.
If it's not stable, it'll pop out.
Absolutely.
Pacing.
But
No, it's not.
stability-
We change with the
existing, so
pacemaker.
they're
Could
going
you-
to change it. They're going to change it to a
Yeah,
proper
yeah,
temporary
we
pacing.
change.
I know that's going to happen.
Seems, but okay. Dammi un interruttore anche
Just
ora.
as a
Un
matter of
5.
understanding for everyone else here, while they're changing the wire, you
Okay.
either pace on the LV
Cinque
wire
duro,
or you
so
either pace
1
with
5.
temporary pacing in the RV. Halfway
Also
stages
because
are
when you
always-
use valves,
always
better.
challenging and can
No, no,
shortcuts
no,
can lead to
no.
disasters. But this is a patient with pre-existing bundle branch block with a high propensity
Vai,
to
vai.
have a complete heart block. So
Okay.
anyway, a temporary, appropriate balloon tip temporary pacing wire is always what we would do.
Ok, vai.
Because it's the
Dammi
safest
il...
tool that we have in armamentorium.
Metti il palloncino, per favore.
Balloon tip pacing wires do not cause perforation
Antero posteriore.
and are a good safety device.
Ok.
Aspetta, che sono ancora.
Sgonfia, sgonfia. Vediamo.
Ok.
Il test. Ok,
Check.
prova. Sì, si è attaccata. Non va ugualmente.
Beh, meglio però.
Ok, stop. Now it's better. Stop,
Sì.
stop, stop. Tieni. So, vai su piano.
Mhm.
No, non parte subito bene, eh. Vai. Rapid pacing on. Now is good, vai. Ok. Stop. Stop pacing. You can check the rhythm. Ok, vai. Stop. Sì. Entra la guida, spingila. Ok. Now we put the valve. Now it's better with the pacemaker, probably was too unstable. Avete tirato indietro il pacemaker, ragazzi, cioè vi voglio bene. Non troppo. Prova a fare un test del pacing. Ok, stop. Il pacemaker ancora. Ce l'avete su con me. Ce l'avete su con me. Va bene. Ok, vai. So we put the valve. Okay. Sometimes in this part, the patient have some pain to the axis. Fix the wire, please. Okay. So we introduce the introducer. Then we go up with the valve. Okay. Yes, we can check the valve in the introducer to be sure that is not inside is over the balloon. I think is good. Ok, guarda sopra adesso. Sopra? Guida. Right, ok. Ok. Normally we test to cross the arch without flexing. If I have some problem, I come back and use the flex. So no problem to go inside with the new valve. This valve, okay. So we put the pacemaker, the pacemaker, sorry. The pigtail inside the right cusp. I need probably the wire for that.
I guess you all know that the Pro Plus has minimal shortening of
Yes,
10 to
only
12%.
Yes.
And it's both sides.
Yes, it's true.
And therefore it implants very precisely and accurately. So you position it at where you want to implant it, and the depth remains absolutely stable. And therefore, because it doesn't foreshorten, one has to predict absolutely at the depth what you want to implant.
Vai in caspo per labbro, lo capiamo se siamo adesso.
Okay. Repositioning the pig in the...
I check because probably the pigtail is in the right, so I go in cusp overlap to be sure that is a no, or to be go in the, to... Okay. Test? Piccolo test, eh?
Okay.
I'm okay. Okay.
This
It's
is
an
okay.
order, so we can come back in tricasp. I prefer to put the valve in tricasp with balloon. I don't know. Okay. Vabbè, so. The pigtail now is go on now. Okay.
Okay.
So we needed to put the marker, the bigger marker, the third to start to the up at the level of our annulus, an idea of a non-coronary cusp. Pico check. Okay, so probably we are quite good. I do a angio, right?
So that's,
okay.
That'll get an 80-20
Facciamo rapid
implant.
please. Aspetta,
Because it's
te lo
not
dico io.
supposed to foreshorten.
Yeah. Okay. So normally the distal edge, the ventricular side, the shortening is 10% with this valve. So I think it's a good position. Now we start with the pacemaker, slow inflation, a small angio, then we continue with the inflation. Ok, allora, rapid pacing on, ok, inizia a gonfiare, piccolo check, ok, vai fino in fondo. Ok, nice. 1, 2, 3, 4, 5, stop, go down, and stop the pacing, we check the
Did
rhythm.
you see that it did not move? The depth remained absolutely at the point where they had put it.
Yeah.
That's the quality of this this new innovative
valve, yes.
Pro Plus.
Ok, tieni un attimo.
No.
Octocore Pro Plus.
Riesci a ossializzare la nostra...
La valvola vuoi dire?
Sì.
Adesso te lo metto.
Quella in cui eravamo era la caspa overlap, spero.
Tricaspa.
Cioè, scusa, la tricaspa. La metti in asse poi. Ok, go down. Prendiamo un pallone, un 1240 stereottante. Ok, so we check the valve. In this case, it's easy to remove the pigtail also without the wire because the sinus are very big. So, and then we check the pressure with the pigtail, also in left ventricle. Sì.
No.
L'ho già tirato. Sì. Mi sembra abbastanza espansa.
It's a good expansion for the valve. Now we check the gradient and then with a final angio, eventual paravalvular leak.
If we have some paravalvular leak, we can also use the same balloon with 1 or 2 ml more.
I think
But,
that's a very nice demonstration.
I prefer to check the pressure before. Okay, test. Physio? Anche il
Dr.
secondo?
Mary, do you want to give any concluding remarks?
No, sorry, can you repeat?
Any concluding remarks from your side before we wind up the session?
With the gradient.
So, for me, it's important to check always the pressure
Do you
at
want
the
to
end
show
of the
the
procedure.
echo findings or the pressure gradient?
Yeah. Aspetta che lì siamo dentro qualche cosa. Dammi la guida, per favore. Riuscite a fare gli zeri della pressione? 0? So the pressure seems very well because the diastolic is very low, telediastolic, okay?
Yep.
And also the diastolic of aorta is low. I don't know if through this pressure, so I check, perché è strano che abbia questo gradiente. We have some gradient. We check, we try to put better the pigtail because it was not in position, correct position. Now it's better. And then we check again.
Vuoi lavare con la lunga?
I mean, there seems to be a gradient which is more than a single digit.
Yeah,
gradient.
seems. Test? I don't know. Test? Fisiologico.
So we'll
Physiological.
while you
So sometimes it's also our line that is not so perfect. So we check with the echoes if we have some problem. You see now it's better because probably the one line was not very flashed. So we don't have a gradient in
Great.
this way. Okay.
Thank you.
So we check with the angio.
You can do it
Okay.
now, and we'll just wait for 1 minute.
Siamo? Okay. Vai, angio. I think is good. Also, I think also is a 70-30%, so I think is a good result. So now we go to closure the access.
I think in the interest of time, we'll move towards the next session. Thank you, Dr. Mary. Thank you so much.
Thank you. Bye-bye. Bye-bye.
So our next session is on the evolution of scaffolds from bare metal to fourth generation DES. The first speaker is Dr. Sarita Rao, New Age DES, live in box case.
So very warm good afternoon to everybody. And we actually did this case on the day that the Zion SkyPoint was launched. And can you play it? Because I'm not getting an audio on this. Old gentleman. Now, he was initially admitted at an outside... If you have an issue with the audio, then I think I'll speak. No problem. So, okay, so this was... So this was a 77-year-old male initially admitted outside the hospital with acute LVF and hyponatremia. He was subsequently referred here and admitted to our facility with respiratory failure requiring BiPAP ventilatory support. And when he came to us, he had shortness of breath, altered sensorium, reduced urine output, a little slurred speech. He had hyponatremia. He's a known case of diabetes, hypertension, and ischemic heart disease. He's known to have had a CVA a couple of years ago. He's also a known case of bronchial asthma. He has a history of a cabbage in 2014 where 3 grafts had been implanted. He had a lima to the diagonal, a left radial artery to the ramus, and also an LRA to the PLV of the RCA. His vitals were okay at that time. He was on some inotropic support. His NT-proBNP was 10,000 plus. His troponin was positive. His creatinine was about 1.4. HbA1c was about 8.6. So this was his ECG on admission. As you can see, he was in atrial flutter with controlled ventricular rate. Next, please. We did an echo at our center and it revealed severe LV systolic dysfunction. His ejection fraction was 25%. He had had an old inferior wall MI at the time of his cabbage. He had a wall motion in the RCA and the LAD territory currently. Next, please. So we went ahead and we did an angiogram. Can you show the angiogram, please? So this is the angiogram of the patient. We've just done the angiogram. As you can see, there's diffuse disease in the circumflex. Next, please. But this is the LAD of the patient. You can see there's a 90% long segment of disease in the LAD. The D2 is occluded. The D1 is about 90%. Next, please. This is the RCA, which has a distal 90% block. And you can see this is the LRA, and you can see it's patent and supplying both the RI and the PLV branch. So the RCA and the RI graft are patent. Next, please. Now this is the lima of the patient. It's on a diagonal and there is no flow to the LAD. Next, please. Mild disease in the renals. Next, please. Can we come back to the presentation? So this is the situation at this point. Now the question to the panel is, what is your approach at this point? So at this point, what we are going to...
Why was the LAD not grafted in the first place? It was disease-free at that time?
So we did not have details of the initial angiogram when the patient came to us, but we only had some prescription reports in which this was written. We don't know why it wasn't grafted and why the surgeon at the index procedure, it was not done in my hospital, why he decided to put the graft on the diagonal. But at the present situation, the diagonal is occluded proximally, so we have no flow in the LAD.
I think the graft just got put at the wrong point, which we've seen in the past as well. And he thought it was the LAD and he grafted the diagonal. We've seen enough of that.
I think that's exactly what happened, and Dr. Seth has put it so well.
Because non-LAD ABG is a little rare to find. So anyways, what was the plan?
So I think at this point, this is what we also thought, and this patient had a critical disease in the LAD. So let's go ahead and see. We do realize that we'll have to address that LAD. Is first we're going to go ahead and wire into the LAD. Yes, can we come to a PA cranial, please, and can I have it here?
With an ejection fraction of 25%, how are the hemodynamics?
So this patient was on some mild inotropic support when he came to us.
Any thoughts on intra-aortic balloon pump up front?
So typically we usually keep an access ready. We don't put it until the patient requires it. At the time that we took him onto the lab, he was on minimal inotropes, his pressures were good. So we didn't put it up front.
So the numerous criteria.
Could you go back to our recordal?
And we can discuss.
So the plan at this point is open this LAD, which appears to be a calcified lesion, and it doesn't have any flow from the graft to the diagonal. Now at this point, we want to see the amount of calcium over there, decide how we're going to approach this case. So we're going to go in with imaging, and we're going to be taking an OCT. We always try to use the OCT in such cases because we're able to appreciate the extent, the thickness of the calcium way better on an OCT. We'll try to pre-dilate if the OCT does not track at this point. Well, let us see. So at this point, it is such a tight calcified lesion that we are not able to track the OCT in. So what we'll do is we'll go ahead and do a little bit of a pre-dilatation. So at this point, I'm taking a 2O balloon in and trying to pre-dilate the lesion. You can see that the lesion is not giving way. Deflate, please. Inflate, please. So at this point, we have pre-dilated the vessel, and now we are trying to track in the OCT because we want to image and see that point which is not opening up. Can we go PA cranial, please? So I think we've been able to cross it this time with a little difficulty, but we've crossed. So we've just taken the OCT run. Can you go to caudal? And let's see what we see on that. Center it, please, so I can take the OCT out. So at this point, we've taken the OCT run for the proximal segment. And as you can see, we have a nodule at around the 5 o'clock position. We have superficial and deep calcium. We have a nodule even at the ostium of the LAD. So at this point, we've decided to take the orbital atherectomy in. However, in the distal LAD, we won't be doing any orbiting because we have ballooned over there and it's predominantly fibrous tissue. We'll finish that with a cutting. The vessel size is smaller there, but in the proximal and the mid LAD segment, we are going to go in and orbit.
Sarita, I just wanted to comment for everyone that in a patient with 25% ejection fraction and a creatinine of 1.4, I would be concerned with OCT. I would be actually relying totally on IVUS for my gut.
Yeah, unless you are going to do a saline OCT. But for the left system, it wouldn't give you good pictures. So maybe.
I also prefer IVUS in this patient. Second thing is even the orbital atherectomy like this. I've seen many cases go into slow flow with EF of 25%. Rota is, we see have many cases, they go into slow flow and they may crash sometimes with high LVDP. Even orbital also we have seen with tight lesions like this. That risk is always there. I think a mechanical support, we should put it first, whatever major intervention done in this patient with IVS, as Dr. Seth said.
So I think at the end of this talk, we will discuss that mechanical circulatory support importance, because I do think with Surya Prakash that a 25% ejection fraction, calcified lesion, if this is a viable territory, and if this is the most moving territory, believe you me, with atherectomy being done, we saw the PA pressures were normal. We don't know what the PA sats were. The patient was on inotrope. I think we have to be more judicious around considering mechanical circulatory support in this patient. But let's see how everything goes.
So I really appreciate all of the points, but we had done an ultrasound of this patient. This patient had no pre-existing history of renal disease, and we probably thought because he had been transferred in from an outside center, and he had been given a lot of diuretics over there. We probably thought that this mildly elevated creatinine was probably because of that. Second, he was on minimal inotropic support. Yes, there is a point that maybe we could have used an IVUS. However, in this situation, I wanted to appreciate the deep calcium also, so I wanted to take an OCT. MCS, yes, definitely. Whenever you have an EF of 25%, but in our situations, there's always a constraint. So we take an access and we keep an IABP there for support. And it hardly takes us any time to get it in, yes. And one more point, rota, orbital. In a calcific lesion like this, slow flow is always an issue. But with our, what we have seen is that orbital, typically we have less slow flow as compared to rota, which is why we decided that we'd go in with orbital as in opposing the rota.
Just another question.
What we're doing.
Fallback mechanical circulatory support has always been known to be one of the worst consequences of not preempting problems. That is why none of the trials came out to be positive. It was always a fallback mechanical circulatory support. It's not a bailout. I think it should be preemptive, that's all. But I understand the whole thing. It's just some messaging for people to start thinking that a 50,000 or a lakh may not add on, but fallback mechanical circulatory support is always more disaster. That's all.
So I agree with that. And typically we say that if the patient is going into shock, the earlier that you take the MCS is way better. But this was a patient on minimal inotropes, and his hemodynamics were preserved. He was on a minimal support. So I would still want to, hold it. The microcatheter in. We're going to exchange coming wire for wire. We've got the orbital in, and we're going to orbit into the proximal segment. So we're going to go very slow, 1 millimeter per second, and orbit both antegrade and retrograde. Can somebody keep an eye on the hemodynamics at this time? There's a big sound and we stop. Keep the microcatheter ready. We know we've orbital a couple of times. We're taking the orbital out right now. So at this point, we've decided to do first a post-dilatation of the distal stent before placing the proximal one, because sometimes it's difficult to get through. We have an area of under-expansion distally. We want to tackle that before we place the proximal one. Can you center it, please? Okay. So you can see that on the stent enhancement. Please go up. That we were not able to address this with the orbital because we had dissections at this point. So we've taken an OP and NC. Please go up. Yes? Yes, 25. We're on 35, 36, 37. Please prepare for boost. Yes, please. Deflate it. We had that huge nodule over there, which we couldn't get an orbital there.
Was it?
So let's see what the OP and NC has done at this point.
What
The
was the size?
distal
This was
portion with
inside
the
a
OP and
stent.
NC.
Took a 1:1.
Yes, go up. 25. Go up to 30. Yes, much better. Deflate it, please. That's it. Deflate, please. Go back to an RO caudal. So we're now taking in the Zion Sky Point. This is a 3 into 23. So now we're going to go left main to LAD with this and overlap over the prior stent we've taken into the mid and the distal LAD. We've done the, and this is an excellent stent for side branch protection. So we're going across these circumflex and we want it to remain patent. I think I'm good with it. We deploy. Okay, please deploy. Go up. Some ephedrine, please. Inflate. Watch the hemodynamics. We've placed the left main to LAD, overlapping stent. The side branches are okay. We are now going in with a 3O balloon to do the post dilatation, and then we'll do the final part. So let's first. Okay, please go to a PA cranial. Inflate, please. Go up to nominal pressure only. Okay. Deflate, please. You can see how well it's opened up. Inflate, please. Deflate. Inflate. Deflate, please. Go back to a caudal. We've done the post dilatation. And now we're going to take in the pod balloon. Give me a 4-6. We're going to take a test to see if everything's okay, so we can remove the jailed circumflex wire before we do the final pod. Yes, the ostium appears to be quite okay. We'll take out the jailed wire. Yeah, comes out easily enough. Can you take a boost? Do a stent enhancement. Center it, please. There's the pod. Deflate, please. We're doing a proximal to distal pod. Go up. Down. Okay, deflate. Now, make it small. Center it, please. Yes. I think we're good. Right? Inflate, please. So at this point we've done the pot. We've done the post dilatation of the stent. We are now going in with the OCT to see what we've done. We've taken both the OCT runs. So at this point, we've taken the OCT run. We have an excellent expansion along the entire length. Our left main area is about 11.2. So all in all, you can see the OCT run and beautifully expanded stent. So all in all, this was a patient of an elderly male with diabetes, hypertension, post-CABG patient, and with a calcified lesion which was dealt with a cutting balloon distally, and we dealt with it with orbital atherectomy proximally using OCT imaging, and a final good result using the Zion Sky Point stent, which is excellently suited to such lesions. Thank you so much.
One question, ma'am. Did you do orbital up to the mid LAD or in the proximal part only?
Did I do? So
Orbital.
we had dissections in the distal most part where we were not being able to cross, and we had to pre-dilate to get the OCT in. Now, because we had dissections, orbital can't be used in the presence of dissection because it will find the dissection and it will perf it. So we only orbited in the proximal and the mid segment. We did not go down.
Because that was the area where you require to use OP and NC later.
Yeah, so the one area where it did not open up, we went ahead and did an OP and NC, and it did open up with the OP and NC.
Again, I keep saying, everybody seems to say 1:1. There's nothing like 1:1 OP and NC. It's always half size smaller to 40 atmospheres pressure. Only if that fails, you go to the next step. Otherwise, you perforate vessels. It grows by 12%. A 3.5 becomes a 3.9 at 40 atmosphere. And if it's 1:1, it's the pressure and the size. And size is what matters in high pressure perforation. So I think we just be careful. The message is very clear. 3 millimeter will go to a 3.35, 3.39. Exactly 12% at 40 atmospheres.
I think that's an important point, but many a times in the presence of a stent which has been implanted, many a times we go 1:1 when the stent has already been implanted. But yes, there is always a risk that you can end up having a perforation.
I think Dr. Florim Kukli and his team, they use a lot of OPNCs, and their dictum is go smaller size and higher
Absolutely,
pressures,
higher pressures.
to avoid
Oh,
perforation.
I've perforated
perforations,
vessels,
yes.
and that's why I tell you.
Yes.
Perforating vessels is not fun. Avoid it.
Excuse me, ma'am. When the imaging catheter did not cross in the first place, would rota have been a better choice in this case rather than redilating the lesion first? Because if it would have caused significant dissection after that, then any other calcium modification therapy.
So
would
your
have gone
question
wrong.
is very valid, that why not just go ahead and use rota, because when we have an uncrossable lesion, a balloon uncrossable or an imaging catheter uncrossable lesion, typically we do use rota. But my question was, in this case, did I know, was I dealing only with superficial calcium? Did I know if I had a nodule over there? Did I know if I had deep calcium or not? So in the presence of, if you're using only rota, you're very much dependent on the fact that it will do a superficial ablation, and probably if you have a nodule there somewhere, you may not be able to ablate it. You're very much also dependent on a wire bias. So I did want to image and find out exactly what was over there. So which is why I didn't take the rota in, because sometimes you do a rota and it may not be enough.
Okay, so I think all in all, it was a good demonstration. Would you like to highlight any salient features of the new stent, SkyPoint?
I think the SkyPoint is an amazing innovation today. All the things which were lacking in the previous stent have been covered. So now we have extra long lens to the tune of 48 millimeter, which we did not have with the Zion Sierra. The second thing, it is marker to marker, so very good for osteal placement. The third thing is the expansibility of the stent is immense. So you can actually go up and use it for your left main because it expands right up to a 5.5. So I think the expansion, the long lens, the side branch protection, and the fact that you can create a tapered vessel. Because when you're using a long stent, you know that your proximal will probably be a 4 or a 5, and your distal may end up to be a 2.5 or a 3. So it gives you the advantage of creating a tapered stent in a long length. I think all of these are very beneficial to us intervention cardiologists who are looking for more and more devices to deliver better patient care to our patients. Thank you so much.
Thank you, Dr. Sarita. We'll move on to the next talk.
Very, very good case, Sarita. That's tremendous.
Dr. Subhash Chandra. Does DES design matter?
Yes, it does. Thank you. Dr. Seth, sir. Thanks, panelists. Yeah. So, Dr. Sarita has already alluded to the new stent salient features. I'll quickly go through this presentation in 8 minutes time. Inferior wall non-STEMI, classic case, 54-year-old. And to your surprise, you come to know that he's slated for a prostatectomy because of cancer prostate. And what plays on your mind is as to what stent to use so as to abbreviate the duration of DAPT, and patient can be sent for surgery. This is the classic lesion, type A RCA lesion, mid-RCA lesion. Earlier days, we used to debate whether to put a drug-coated stent here or just a bare metal stent so as to shorten the duration of DAPT. But well, today times have changed. We have learned that even today, these second generation DES are actually much better than any other thing. When it comes to stent thrombosis, two factors basically: device-related, patient-related. Stasis, hypercoagulation, endothelial injury is what determines thrombosis in the bed. And the strut thickness, malposition, exposed struts, or non-endothelialized struts are what determines the device-related stent thrombosis problems. So the first generation test, which was Cypher, which was the thick strut stent with a very durable polymer, had its own problem of late catch-up, and there were instances of very late stent thrombosis. We know that. And we know that strut thickness is directly linked to thrombogenicity. So the whole effort went behind reducing the strut thickness and refining the polymer, because webbing and bonding of polymer is what leads to non-endothelialization and future thrombosis, even late thrombosis. So if we look at this in the animal experiments, clear that polymer has to do a lot with the generalized or universal endothelial formation. The whole stress thereafter came on reducing the strut thickness, and as we see in this diagram, most of the drug-eluting stents, the strut thickness hovers anything between 60 to 81 micron. Zymes has 81, Resolute 91, Synergy has 74. And of course, the red blocks show that there are few stents which have biodegradable polymer as opposed to the stable polymer. So, and these stents have earned FDA approval. A lot of work has been done on polymer also, whereas to ensure that the inflammation, late inflammation and non-coverage leading to late stent thrombosis is minimized as much as possible. The current generation stents, as we see in this diagram, have largely able to overcome that problem, but the polymer which is especially used in the Zymes stent is what stands out, and that is a fluoropassivated polymer. As in this trial also, if you see an examination trial, the bare metal stent versus eluting stents, the overall results were fine with eluting stents in the long run than the bare metal stents. So I'll just touch upon what is special about this polymer which is used by the Zymes family of stents. It's a fluoropolymer which fluoropassivation leads to least thrombosis on this polymer as opposed to the other polymers. And this fact was proven in the recent times of COVID, where a cytokine stent or cytokine storm or procoagulant state, and if these stents were used there, the Zymes stent with fluoropassivated polymer, the incidence of stent thrombosis was least in those cases who received Zymes stent. So that is peculiar as opposed to Synergy, and the comparison was done in a trial, small trial, that the polymer has a lot to do when it comes to thrombosis in these stents. In acute coronary syndromes also, in ACS, the debate is about biodegradable polymer versus durable polymer. There is a notion that these biodegradable polymers perhaps cause less thrombosis than the durable polymer which last longer, but that is actually untrue, as has been proven in this trial, that both almost behave similarly in the long run, and there have been small data where the patient-oriented and device-oriented composite endpoints were collected. It turns out that Zymes, which has a stable polymer, perhaps does best out of the 5 stents which are compared in this trial. Safety is impeccable. It has been seen in complex left main PCIs when the whole effort was to abbreviate the duration of DAPT, which was done in the case of Synergy with 4 months DAPT versus Zymes in 1 year's DAPT, and the results were almost similar. So the strut coverage of more than 20 micrometer was almost 98% in case of Zymes as compared to the Synergy. So safety is ensured irrespective of the DAPT duration, especially when it comes to high bleeding risk population. There have been a few trials in the domain of high bleeding population with Zymes, and I'll just quickly touch upon those trials. These are the trials which are conducted with Zymes in different subset of patients, and the safety is impeccable. So the STOP-DEP2 trial, Zymes 90 trial, Zymes 28 trial, where the duration of DAPT in this population of high bleeding risk was anything between 1 month to 3 months to less. And it is seen that in high bleeding risk population, withdrawing aspirin at 1 month or even at 3 months would not lead to much increase in stent thrombosis as compared to the DAPT being given and inviting more bleeding in this population. So, and that is proven with Zymes only. Coming quickly, so in this patient, classically the Zymes was placed and the patient was doing well and sent to surgery. This is Sky point. I'll just touch upon a few salient points. The device has been refined to the extent that it has excellent pushability. The shaft is very stiff, so it goes everywhere. The transition points where the monorail part finishes has been made smooth, So the transition is very smooth. It goes in nicely into the vessel. The sizes have been increased to 48, and in that 48 category also, because of this interjoint at the monorail point, the interjoint is not like a step and Zions stent. It has been tapered down, and the point where the wire is inserted in the monorail is also tapered. So the whole device actually looks very slick, and it goes almost everywhere in the coronary tree. On the design of the stent also, the bands have been acute, and that perhaps leads to more deliverability. And the length of the bands, the structs have also been increased, and that is responsible for making it an ideal product for left main LED PCI, where you need to blow the left main part by 1 millimeter or even more than 1.5 millimeter. The main point is the stent should not get distorted in spite of growing by 1.5 or 2 millimeter. So that is the quality of the new product, Sky Point from Zions, and it has excellent pushability, both 3.5 and 5 size and 2 to 3.25 size. They can grow by more than one. There have been huge data over the last 20 years plus, and perhaps the most widely used product globally. So to conclude, significant progress in stent design, thinner stents has been made, and this translates into improved clinical outcomes. Significant progress in polymer technology has also been done, and perhaps there's not much difference between biodegradable polymer versus durable polymer as in the case of Zions. And that's it. Thank you. Thank you, sir.
Thank you, Dr. Chandra. Any comments? I think the deliverability is what has been highlighted.
Yeah, so that's a notion that the biodegradable polymer perhaps will invite less thrombosis, but that's not proven in any trial. So,
Side brand.
with that's right. Thank you.
So the next talk, I'd like to invite Dr. Vishal Rastogi, right patient, right desk selection.
Yeah, thank you. So my job is made very easy by both Dr. Sarita Rao and Dr. Subhash Chandra, who very rightly highlighted the complexity of the situation and how the new device is trading. So we have come a long way from these era where we used to do very simple lesions. Now we are mostly dealing with type C lesions. So what should be an ideal DES? It should have a good anti-restenotic benefit, should have good radial strength, and it should have good side branch access. There should be good long-term vascular response, and then the biomaterial should not be inflammatory and should we should be able to do a depth for a short duration. So design stent has 4 pillars. It has good multi-link stent design. It has everolimus drug, which has proven safety, and the polymer is fluoropolymer, as highlighted by Dr. Subhash Chandra also. So these are 2 stents with durable polymer, and the rest are biodegradable. And the polymer that is there with these lines is actually a fluoropolymer, and it has very good coating integrity. It is already used in multiple sutures and surgical sutures, and it has thromboresistance. That's because of its affinity towards albumin. So it actually attacks albumin rather than the other fibrinogen and other proteins. That it leads to minimizing the inflammation, and it leads to faster healing. This process is fluoropassivation. So I'll just go to the lesion subset and how the stent is there. So coming to left main, Zions Sky Point is indicated for treating left main lesions. In fact, it's the only stent which is approved for vessel large than 5 millimeter, and it is because of the various factors which have been highlighted earlier. It's the ideal stent for this kind of scenario. And we know left main, there's a hoard of data with the Zions platform where the long-term stent thrombosis as well as the TLRs were very, very low. So just to show you a case, this is a diabetic patient, normal ejection fraction, left main LED and lesion, ostial LED is diseased. So of course, after cutting the LED ostium lesion, once we put the Zions Sky Point and then dilate, minimal pinching of the circumflex, but the crossing of the side branch is so excellent that we just finished with the single stent strategy with a crossover, and the circosteum is widely patent there. You can see that the stent conforms so beautifully and it's been dilated to 4.5 millimeter in the left main area. Another important subset is calcified lesion. And why calcified lesion is important? Because that is independent predictor of poor clinical outcomes. We know that those patients who have high calcium load, they have a lot of peri-procedural complication. That means we are not able to deliver a stent, or we lose the stent from that balloon, or there's impaired duct delivery, polymer disruption, and then stent enter-expansion. That leads to post-revascularization outcomes of stent thrombosis, high restenosis, and long-term adverse events. So Xine's SkyPoint has significantly better stent retention because it requires a huge force to dislodge this stent. As you can see against the other platform, the dislodgement force required is maximum for Xine's SkyPoint, thereby making it ideal for long, tortuous, and calcified lesions. Also, the platform is excellent longitudinal stent. The lower is better because the displacement of 50-gram load will lead to minimal displacement, minimal shortening of the stent as against other platform, and there's a specific design features which enable it to in this strength. So in a patient who has a long calcified ostial LAD lesion, once we dilate the vessel with balloons, we did OCT here and we found that the calcium is 270 degrees only, so we ended up dilating it with the non-compliant balloons. And though the vessel is totally disrupted, but once we stent it, the vessel takes up very nicely after the stenting, and the deliverability of the long stent is very good. And as highlighted earlier, the ostial state placement is perfect with Xine's because of the marker being situated just at the stent. Another important subset that we see in our practice is bifurcation lesions. And this Xine's SkyPoint is, it not only allows accurate stent placement because of the precise stent marker, but also it has very large side branch access cells because of this design that it has. So the circular cell opening is maximum. In a 5 millimeter stent diameter, there will be 3.9 millimeter side branch area available so that the complete strut is moved out of the vessel. So this is a case which 81-year-old male who had right coronary artery totally occluded and 35% ejection fraction. The patient has critical left main distal bifurcation lesion with heavily calcified lesion. So we had to do IVL and other debulking techniques here. So we put the patient on Impala device, and then we treated the patient with the two Xine's SkyPoints using the mini crush technique. We chose to keep the large circumflex, which is co-dominant vessel, as the main vessel, and crushing the LAD stent and then crossing into the LAD was very easy. As you can see here, the wire crosses easily into the branch, and then once we post-dilate and then do the PART, there's excellent expansion in the left vein. The left vein was almost 5 millimeter here, while the circumflex and the LAD were 3.5 millimeter vessels each. So to summarize, now we know that Xine's stent platform has shown excellent early outcomes in whatever type of lesions we deal with, whether it is bifurcation lesions where there's good early outcomes and very good zero risk of definite stent thrombosis at 30 days in the trial. Also in long lesions where again the MACE is very low. In diabetic patients also it has been proven of being good result. Calcified lesions, chronic total occlusions, and also the subset that earlier highlighted that there was in patients with ACS, and also in patients with high bleeding risk, the stent performs very, very good. Thank you.
Thank you. Without any comments, I think we'll close the session. We are awaiting the keynote lecture of Dr. Ashok Seth. Don't want to keep anyone waiting. Thank you.
Thank you. Can we have a quick photograph, or can we have the speakers on the
All
stage
the
for
speakers
the
also, please.
group photo?
Come forward, please.
Thank you so much. Requesting all the experts and the speakers to kindly collect their mementos. I request Dr. Jyotsna to kindly do the honors. Can we have a big round of applause, please?
So good evening again, ladies and gentlemen. We now come to a very important point today. And Winkas today is honored to have our keynote lecture to be given by none other than Dr. Ashok Seth. It is indeed a great honor to introduce Dr. Ashok Seth, one of India's most distinguished pioneers in intervention cardiology and a globally respected leader in cardiovascular medicine. He serves as the chairman of Fortis Escorts Heart Institute and chairman of the Fortis Healthcare Medical Council. He's also an adjunct professor of cardiology at Jawaharlal Nehru Medical College, Aligarh Muslim University, and with the National Board of Examination in Medical Sciences. With more than 4 decades of pioneering work, Dr. Seth has played a transformative role in advancing complex coronary and structural heart interventions in India and across the Asia-Pacific region. He has performed innumerable 25,000 angioplasty and more than 60,000 angiographies. He has one of the highest numbers globally, earning recognition in the Limca Book of Records. Dr. Seth has also been a visionary academic leader. He is the director of the Intervention Cardiology Foundation of India and the flagship India Life Course Director of the Heart Valve Foundation of India and India Valves. He is also course director of major international educational programs, including the AICT Asia PCR and the CHIP CTO India. He has served as immediate past president of the Asia Pacific Society of Intervention Cardiology and also past president of the Cardiology Society of India. In recognition of Dr. Seth's extraordinary contribution to medicine, he has been honored with India's prestigious civilian awards, the Padma Shri and the Padma Bhushan, as well as the Dr. B.C. Roy National Award for Eminent Medical Person. He is, as I know him to be, a remarkable clinician. He's an innovator, he's a teacher and a mentor. Dr. Seth has inspired generations of cardiologists and continues to shape the future of cardiovascular care, not only in India, but globally. It is my privilege today to welcome Professor Dr. Ashok Seth to deliver the keynote address at the Women Cardiac Care Conference. Welcome, sir.
Sarita, thank you very much for that kind introduction. Kuch zyada hi keh gayi. But, you know, what am I going to talk about? It's just a privilege and a pleasure to be here amongst you all. आज मैं थोड़ा नर्वस हूँ. वो तो आपको पता ही चल गया होगा क्यों. वैसे मैं होता नहीं हूँ. Not on a one-to-one, but अगर there's so many ladies looking towards me, at me, then बोलना थोड़ा मुश्किल हो जाता है. Just seeing ठीक से कपड़े पहना हो कि नहीं, have I dressed up properly? Am I going to speak properly or not? Am I giving the right impression? Am I doing well? But perhaps let's start, because you're going to enjoy this journey. This is India's 38-year journey. And I call it a journey in complex high-risk intervention. You'll just understand why it's been a journey of 38 years when the CHIP terminology came in far more recently over the last 10 years. And what does pushing the boundaries mean from India to global leadership? But I think let's just understand that pushing the boundaries is not the same as being the first. It's a responsibility. It is really to start a journey for a country transforming care. It has to be evidence-based. It has to be procedural optimization. We have to be safe and effective. But I also want you to understand that a continuous learning and upgradation of knowledge skills is when you push boundaries, and this knowledge then has to be shared with each other and passed on to the next generation. There's training and teaching, which is paramount as we push boundaries, and development of therapy for the country and putting the country on international map has to be an aim when we push boundaries. So it is not personal, and when I look back, if we got to look ahead in our country, then we certainly have to look back. And just a story as it goes, what are we going to talk about today? How we transformed interventional cardiology in India over the last 38 years. What did we do? Why and how did we do it? And what can we transfer on to the next gen of interventional cardiology? And most importantly, what do I transfer on to the women in interventional cardiology? Well, 1977, we don't have to dwell upon this story, but it was a landmark because it started the era of interventional cardiology with Anders Grunzig, a radiologist in Zurich, when he did the first case. But what's even more important is the tedious, the passion, the mission he was on. Do you know that every balloon of his was sized to the vessel he was going to treat and made on his kitchen table at that time, extruded out with his associate Maria Schlumpf and his wife involved, and you can see the wine bottle there as they would work. It was a balloon at a time till Schneider bought it in 1977. All the animal experiments were done the same way. The first human actually also was done with the same balloon. And I met, this is Maria Schlumpf, and Anders Grunzig migrated or immigrated to United States of America, and that's her just 10 years ago at the 40 years of anniversary of angioplasty. Those were the days when we had crude guiding catheters, and when I started PCIs in 1884, balloon angioplasty was perhaps the main thing. We had to, there were no specialty guiding catheters. We learned how to deep throat 9 French guiding catheters to make it look like an amplatz, or deep throat it down the coronary arteries to push crude devices into lesions and dilate them. So these were tricks that we learned and we taught further. And then we had balloon like this. This is the first balloons that we started using. They were over-the-wire balloon systems or fixed-wire balloon systems, and we even had an angled balloon catheter for angulated lesions so that we wouldn't dissect vessels. That's what we lived in. I returned after 10 years in October '88 to start off the intervention program, angiographs and angioplasties as a head of cardiac cath lab in 1988. I was a handsome, I am a handsome, but I was handsome looking person, 35-year-old I was, 36 maybe. And what did we do? Well, there were only few of us in this country. And that's why I put this up. Dr. Gandhi and Dr. Kalula had propagated intervention by encouraging others and were clearly the father figures. Actually, the ones who were doing it were only 6 of us at that time. It was Paladani, Dr. Mehta, Upendra Kaul. We must remember Matthew, who's passed away, a real pillar and a real expert in interventional cardiology, Dr. Soma Raju Gambhir, and myself. Can you believe just the 6 of us doing balloon angioplasties in 1988? I joined this gang as the youngest of the lot, and we subsequently trained, and of course there have been many subsequently, many of whom you get all inspired from. 8 F guides, 9 F guides, only heparin and aspirin as an antiplatelet, and dextran, but no clopidogrel, no antiplatelets. Crude balloons, fixed wire systems, no monorail systems. In fact, in front of our eyes, over-the-wire systems came in and we said, thank God we got something better. Cut films, put them on the screen, look at them, go back to the patient. That's how we actually had roadmaps. Videos came in as a roadmap. We would stop, record, and then stop. And that blurred image was a roadmap. 10% acute vessel closure, 5% acute MIs, 3% deaths. This technique today would be considered unethical to be performed on anybody, correct? It wouldn't even clear anything. It would be considered experimental. And yet, we had to have an OT standing by with empty OT. We had a surgeon breathing down our neck because emergency bypass surgery would happen in 3% of those patients or 5% of the patients. And he would be saying, why the hell have you brought out a technique which is as crude when you've got an established bypass surgery as the mainstay of treatment of coronary artery disease? You guys are experimenting in the realms of nowhere. And restenosis, even if the patient lived, restenosis was 45% in the first 6 months. So he would come back. Can you believe that you talk about complex angioplasties now? We talked about every angioplasty being complex at that time. And from then, move exactly 40 years later, February 2026, a 63-year-old gentleman walks in. He's a diabetic, he's a smoker. He's had an inferior MI, he's got an ejection fraction of 40%, his class 3 angina. And look at his disease process. He has a right coronary artery, which is long segment disease. He has an anomalous left main. I hope I can, that doesn't show you. There is no pointer, or if there is. An anomalous left main arising from the right coronary sinus with an ostial LAD stenosis. And then he's got multiple lesions in the circumflex going down to the OM. He's at least got 7 lesions out there. How many would say surgery? How many would say bypass surgery? Don't be shy. We're in the realms, and we've got enough tools, haven't we? We've got enough tools, and if the patient prefers, I say we would actually stent the right coronary artery, perhaps do a drug-coated balloon to the ostium of that LAD, then go down the circumflex, maybe a drug-coated balloon to that OM, and then a stent into the proximal circumflex and do a drug-coated balloon all along. Would that be reasonable? Correct? And we would have treated this high-risk case. His ejection fraction is 40%. Well, that's what we do. In 1989, 8 of us got together to create a club. And the first meeting was held in Mumbai in December 89, October 89, where we shared, discussed cases, and enjoyed learning. By the way, that PTCA club is what became the Angioplasty Registry of India, and that is what is now the National Interventional Council. So that's the history of National Interventional Council. We 7 people created that. We started teaching angioplasty, the 5 of us, which was myself, Dr. Mehta, Somaraju, Matthew, Gambhir, and Kaul, started teaching angioplasty to the nation. Formal 5-day teaching courses, 4 times a year. The first course was held in Mumbai, and who did we have as students? Some of the path breakers that you see today. Our first group had Mullah Sari, Tejas Patel, who we actually taught angiograms and how to do angioplasties, balloon angioplasties. Pratap Ras, Shivadatta, Jagmohan Verma, Bali, all trained from us year after year after year. And that course became the most popular. Coming back to that tough case 2 weeks ago. That wasn't 2 weeks ago. That was a case of 1992, in the days of balloon angioplasty. And it came to me and refused. And I said to myself, I can do it. This is mission, this is passion, this is for balloon angioplasty. And I had followed Jeffrey Hartzler, I'd spent some time with him. He was a whiz at balloon angioplasty. 7 lesions, 8 lesions, 3 vessels, he would do it. We had no backup stents, we had no drugs, remember? We had a guts. And so I went ahead in a single sitting, treated all this with balloon angioplasty, even this. And that's what you will see. When I sent this for publication, and by the way, this represented the only such case in the literature with appropriate technical details as discussed, never done in the world before. It was 95 when it got published, and why? In 92 it was refused, saying we don't want heroes and cowboys affecting the integrity of what we think is a promising treatment for the future. And it was refused by 4 journals. 2 years later, as all this was done, I can see the balloon hanging onto the left main as I did the ostium, and all that circumflex treated in a single sitting. When he came for chest pain, he had a high-grade stenosis at the crux, but every other lesion remained patent. That's when I sent it for publication again. And the journal accepted, saying, wow, you have demonstrated that balloon angioplasty has a future, it works. Can you believe that I still have preserved those letters which said, you're a cowboy, you actually disappointing balloon angioplasty, you will actually let it down to where they started saying that it worked. Very early in the days, 92, we had limitations with balloon angioplasty. I went on to directional coronary atherectomy, a device which cut out plaques from within the coronary arteries. We didn't have stents. We wanted to do a better job in 3.5, 4 millimeter, maybe cut out the plaques completely. 10 French guiding cutters, which had a window and would rotate at 2,000 revolutions per minute, cutting out plaque, and you could just rotate it circumferentially and cut out the plaques from within the coronary arteries. And how did I start this technique? It wasn't even available in whole of Asia Pacific. When I went to the United States and watched it in 2 centers, and there were very few being done at that time, I picked them out of the dustbin. And I put the motor, I put the cutter, I brought it out, I cleaned it, sterilized it, and the next ulcerated huge plaque in a proximal LED, which wouldn't respond to balloon angioplasty, I just cut it off. And that, for me, started the era, which was for whole of Asia Pacific. Now, if you see, this is the sort of lesion which we talk about, crossover, nailing ostia, etc., 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 with a stent. What if we could just cut it out completely, and that's what this cutter is doing. Guide said, 9 French guide here on the left side, with the 10 French for the right. Here it is. Balloon blown up one side, cutter moving from one edge to the other, plaques being cut out within the coronary arteries. That's what you leave behind, absolutely smooth vessels. You just cut it out. There is no stent. There's nothing there. And that's what you get out from within the coronary arteries. So you understand where we were going. We were saying, what are the alternatives? And this is how we cut out plaques from within the coronary arteries. And this is even more complexities as it goes along in the pre-balloon era days. LAD, we haven't got great, long lesion, rotablated. We got no stents. And balloon it. What about this bifurcation? Provisional strategies, 2-stent strategies? Who bothers? We only had balloon angioplasty, but I had a cutter. And I would therefore cut the plaque out from the circumflex. Here's the rotational atherectomy to LAD. We're talking about 94. And here is the cutter cutting in the main circumflex, cutting out plaque from the circumflex, and then cutter into the OM branch, cutting out plaque circumferentially from the OM. And then you can see the cutter moving, plaque collapses in that window, and you have this type of a result. No plaque, plaque's gone. You talk about leave nothing behind. We were doing leave nothing behind because we had nothing in our hands. So there was nothing to leave behind. We could only take it out. And here it is as a result, and 1 year later, angiogram shows a pristine circumflex with nothing inside it. I mean, I took this technique to such an extent that I could do anything with a directional atherectomy. Ulcerated, eccentric plaque, fuzzy plaques, etc., ostial proximal LADs, lesions. I even cut out flaps from within coronary arteries because there was Jean Marco sitting in my lab when my colleague dissected an artery. I told him 1 minute. I went and cut out the plaque, and suddenly the vessel was flowing. And there were no stents in those eras. We were doing long lesions even at that time, totally occluded with rotational atherectomy in 1993. Long segments of disease, totally occluded disease being done. 10 centimeters long rotational atherectomy treated with balloon angioplasty. Another 6 centimeters in the circumflex treated with balloon angioplasty with pristine results at follow-up. And actually, that is when I started. Me and Matthew did the first rotational atherectomy certification program outside the United States. You couldn't do rotational atherectomy if you weren't certified. We did it for the first time outside the United States, where David Worth, myself, and Matthew taught a generation. And many of those who see here is Claire, Pravir Agarwal, etc., who was my resident at that time, and others. And of course, you have a number of others who actually learned rotational atherectomy for us, and that's what all this says. By the time the new device era came in, the stents came in, of the 750 angioplasties I was doing, 400 of them were either rotational atherectomy or directional atherectomy. So if you go back and think that 95, 94, we were doing 200 rotational atherectomies in a year, you'd be very surprised. That was 32 years ago. Well, here we have your Marco, Gary Rubin became a great friend. He used to bring us his stents, which were only meant at that time for bailouts. And he became a great friend. And as you know, Jan Tucker Rubin's stent was the first one approved. And that's, of course, when he wrote up his book, we exchanged this lovely photograph of ours where he says, to a show, from one leader to the other in interventional cardiology. That's how we bonded together in those times. When I started doing angioscopies and analyzing angioscopies in 97 in vein grafts, seeing whether self-expandable or balloon expandables worked. I won't show you this. This is a tremendous video which actually starts showing you. But in the interest of time, maybe you should just move on, because we started doing angiojet thrombectomies prior to its launch in the United States. And by the time it got launched in the United States as a thrombectomy device, a most powerful thrombectomy device, we had published articles on revascularizing saphenous vein grafts, totally occluded saphenous vein grafts, sucking out thrombus within them and seeing whether they stayed patent at all or not. These were pre-balloon angioplasty. By that time, the metal stents had just come in. 95 metallic stents came in, changed the world for us. But we had still the challenges of diffuse disease. And we didn't have enough tools for diffuse disease. So I was the fourth center in the world, the first one outside the United States, to start punching holes in the endocardium using laser and punch nearly 20, 30 holes to perfuse endocardium, to perfuse myocardium through endocardium for intractable angina. We called it PMR. We had a great experience with PMR, but the technique died down because on randomized trials, it didn't prove to be as good and effective. And it was transcatheter, it was percutaneous, it was drilling holes into the endocardium, into the LV cavity, like that. A number of things. The first, of course, I think for one of the highlights was this live transmission of ours, the first time India started teaching the world. First ever live transmission from India anywhere outside. And that was to the TCT main arena. That was truly amazing for the Americans to start learning from us. It transformed the arena because the arena actually became even far more aggressive. And by the way, Orbit-1, orbital was just demonstrated by Sarita. Orbit-1, the first in-human study, was done with us in India. It's still there as Orbit-1 with our names, Keyur Parekh and myself. And the coronary sinus reducer, which Shockwave just bought for intractable angina, was the first in-human study done by us again at the same time, 2007, and that's again published. But this is the landmark which you see now. You saw the use of impeller, the first in Asia. Outside, in America hadn't used it, or America was on 4 cases at that time as a part of PROTECT-1 trial, was this case. We started the first. How many years ago is that? 19 years ago when I started teaching impellers. Not just using it, started teaching impellers. This was the landmark for India. We airlifted this patient in cardiogenic shock from Jaipur, and he'd been advised bypass surgery much earlier, but that's beyond the point. He was on a ventilator, his ejection fraction was 30%, he had very diffuse disease. And there it is, impeller in 2007, implanted, RCA revascularized, left main revascularized, everything done, and the guy lived. And the guy lived, and 5 days later, he was a doctor, he went home, he lived for another 15 years. I think this was the first ever implants, not just in Asia. But in that year, we'd done enough implants for the TCT to invite us to show the use of impeller and high-risk protected PCI to the main arena and the coronary theater. And that was us. Thanks to Dr. Rupa, who's a tremendous national leader. We can see this is 12 o'clock at night. We are demonstrating cases here which was 10 o'clock or 9:30 at the Washington time. In the main arena, for the first time, United States saw the live demonstration of impeller. There were 4 cases done of impeller at that time. And look at us smiling. We had a patient with 20% ejection fraction. Dr. Rupa will remember that he arrested exactly 5 minutes before we were going on to the transmission. We revived him and revascularized his last remaining vein graft. And then we did a second case from the other side. That was considered as the highlight of 2007 TCT, a beautiful demonstration of the most treacherous cases. I must say I had a huge support from my team, and I'll just demonstrate that to you. At the Masters Conclave of CHIP CTO, which is what I do every year, we do every year, on 20th January, we created this expert consent statement on the use of impeller in high-risk PCIs, and that's why I always have created the scoring system, which is what we use to decide microaxial flow pump mechanical circulatory support. This is already published, and we have validated it also. I was the first one to use absorbs in the whole of Asia in 2010, but also enrolled Absorb Extend India was a very important study of the Absorb Extend whole 1,000 patient study. We enrolled our 200 patients given to India very rapidly. And the journey Absorb was tremendous, but my landmark achievement for Absorb clearly was not just messaging the right way to implant absorbs, and these were all my publications, but the partnership that I created across the world in seminal literature around the use of absorb was a journey which was landmark. But not just landmark, because I devised the technique of using absorbs in bifurcation with two scaffold strategy, doing a tap through the main branch scaffold, which had been unheard of that time, that could you use a scaffold just like you can use a metallic stent. This described the first ever technical steps to achieve optimal results while treating bifurcation, described the snuggle technique, which became a trade name for not just for doing a snuggle balloon dilatation rather than kissing balloon dilatation, and this is what was recommended in a two scaffold strategy. This was the first ever description and technical, and then I was invited to transmit and demonstrated tap technique using scaffolds, BVS, to the main arena and the coronary theater of the TCT from India itself. And those were the first ever demonstrations that they saw. And I also did it to Serbia, to Goran Stankovic's meeting, because he was just amazed at what we could do with absorbs. If you talk about leave nothing behind in the present era, you must see this, what leave nothing behind actually does mean. This is not a wishful thinking, this is a reality. It's reality because he is a 38-year-old diabetic in 2015. He's got a totally occluded LAD, he's got a totally occluded circumflex, and he's got a branch vessel disease in a huge circumflex, which is a huge diagonal, which also stenosed. Well, what does it take? You can see that it takes CTO revascularization techniques to open up that LAD, and in that LAD diagonal bifurcation, in that long LAD lesion, I put two long BVS scaffolds. Then to the main branch scaffold, which is the LAD, I put a side branch scaffold as a tap technique into the diagonal. And that is what you see here. And then after implanting that, I do the snuggle balloon technique, which I had described, which had become the way to do a bifurcation technique. And then finally, I open up the circumflex and put two long scaffolds in. 5 long scaffolds with a bifurcation technique and a tap. And what do you see? A great result. But what happens over a period of time? This is what it looks like with a carina right there, which is, as you can see, a plastic carina at the bifurcation. Exactly 3 years later, what you see is a resorption of that plastic carina and the footprints of the scaffold in the vessel, but all the vessels are patent. At 5 years, and what do you see at 5 years? This is amazing. All the vessels have positively remodeled. There is nothing there. The bifurcation looks pristine. Every vessel looks pristine. And what do you see on the OCT? You see nothing on the OCT. You see nice intima. You have changed this person's life to what he was born with. There is nothing there. And we have that whole totally occluded vessel looking pristine. He still remains well. I've asked him to come for a 10-year follow-up because it's already 10 years. And then Antonio Colombo and myself joined up our data, because we had the best data, in the most complex absorbs of 700 cases and 1,200 absorbs, to show that if we did it rightly, our 3-year scaffold thrombosis rates were still running at 0.7%. And that was an important data. But more importantly, the FDA panel invited me to present our data for approval of absorbs in the United States. This has never been done before. And there I was presenting. Their pivotal trial got presented in the morning. There were only 3 invited from across the world, both from 2 from Europe and myself. That day, after our presentations, the FDA approved absorbs in the United States that very evening. That was the FDA panel, never through before. And of course, we've written around that, and of course, the book launched with Patrick Sorois. And of course, we moved on to our own bioresorbable scaffolds, and you know that, MIRIS. The MIRIS-1, first in human study, and the 3-year follow-up was presented both at the TCT and the PCR with simultaneous publication at the same time. Again, a landmark for India that we created. Of course, we moved on to creating introducing the IVL and then the Shock India real world, largest registry in the world, which is accepted for publication now. And of course, again, Dr. Rupa, again, my partner in many of the good things that I've done professionally, has been the first successful core valve ever in the world as a part of first in human study in a patient with AR. Again, a handsome looking myself going back many years. And here we are. And of course, this is what that patient was. Pure AI. You've never seen something like this before. 2004. And when we did this, I couldn't believe my eyes. This is what this device did. Just opened it, and here it is. Absolutely not a red cell passes by that first case. Had this popped out at that time, this was the first in human. Alan Kribbe had already done the balloon expandable 2 years earlier. This was the first core valve implant in the world. And had this failed, believe me, it's set back self-expandable valves behind by a couple of years. It succeeded, and we moved ahead in that era of introducing the valve. This was on the London Valve of Fame. We introduced TAVI into the country in 2012 on compassionate grounds. It was finally approved in 2016, and very rapidly in 2012 we moved on not just from the high-risk experience, but to conscious sedation, and then obviously to low-risk patients, till we did the first in-human study with our MyValve. I was privileged to be the principal investigator and present it with a subsequent publication in Eurointervention on the MyValve 1 data. Won't talk about too much about saying, but apart from saying that education is an integral part, and let me come to the end of this, because putting a whole lifetime in 20 minutes is not very easy. But then education has to come along with pushing boundaries. And of course, as you know very well, that we then created meetings for teaching India Live now into its 17th year. It's just around the corner, something which we created in 2010, the 15th India Live, by the way. We created in 2010. Of course, CHIP CTO, the moment I said the CHIP has to be a part of the curriculum, and I wrote up an editorial on that, which you will see, is the fact that we created the CHIP CTO India. And of course, next year, I think I'm going to combine, at least for the next meeting next year, CHIP CTO India will combine with India Live in Delhi. Of course, the India Valves, which we created and has become a force to reckon with across the Asia Pacific, is going to be in September in Chennai, so mark your dates. The IPCI, the Imaging and Physiology Council of India, which I'm very passionate about, is another meeting that we've created, again, as with my colleague co-directors, and that, again, is going to be in Hyderabad. Sorry, it's not going to be in Hyderabad, it's going to be in Chennai this year. And of course, the huge meeting, AICD Asia PCR, where we form the core team of educating across the boundaries, should we say, in association with PCR. As PCR gets very complex, and as a patient gets more complex, the curriculum of CHIP has to evolve. And in this editorial, exactly prior to creating the CHIP meeting, I wrote, dedicated, defined, all-round training program is necessary now towards proficiency in complex and high-risk PCI. It's very, very important for us. And the curricular framework, which is what remains the mission of the CHIP CTO and many of our meetings and many of our teaching and training programs, is to do with a lot to do with understanding hemodynamics, understanding calcium modification, left main and complex anatomy, large bore access management, CTO, imaging, precision PCI, giving the best outcome to our patients. But you can't cross the sea merely by standing and sharing at the water, is what Rabindranath Tagore said. So you have to push boundaries. You have to believe in yourself. It means coming out of your comfort zones. It helps us to learn and grow, to know time, and to look at new opportunities, because we have to give the best to our patients. I want to talk about exactly a few slides around women in interventional cardiology, because that's utmost as we sit around here. Interventional cardiology, by the way, is the most male-dominated area that you will ever come across, unfortunately. Only 4 to 6% of interventional cardiologists are women across the world, even perhaps less in this country. Today, I'm so happy to see so many motivated women interventional cardiologists because there are numerous reasons for low penetration and low representation, and we all realize that. While there are specific reasons, which is to do with radiation, which is to do with abnormal working hours, which is to do with various other responsibilities that women has, but can you believe also that one of the most important reasons that it is male-dominated, that it has a glass there, and it's very difficult to grow for women in this area. And that's the reality, but yet the procedural outcomes are the same as men. That's also been demonstrated. So where does this all go? Why do women go in interventional cardiology? And that's been looked at surveys. Do you know why? The women who go into cardiology have look up and aspire towards another lady who's done very well in interventional cardiology, and hopefully some man who's also done well in interventional cardiology. Hopefully the ladies look up to that. But also there's a passion. There's a real passion. And there's a passion, and I'll just explain to you this passion. What is this about men and women? It's very fascinating to me. A woman has the professional career, and of course, there's also the home, which they can't neglect. Children are very important, and children's education is equally important, and the health of the family is women's responsibility. And the husband, always stay behind the husband, the upfront, always. And then husband's parents. Oh my God, but still have to be nice to them, isn't it? We've got to really loving to the husband's parents, even if we don't like them. What about the sisters? They're even toxic. But we still have to like them. But we still have to like them. And then, of course, our parents are, the women says, my parents, of course, really deserve attention. They're important. They've got to be equally important. So there's another stress out there. And then there's more and more and more. I mean, that's the nucleus. They form the nucleus of not just the family, then the nucleus of the country. The health and wealth of the nation relies on women. And what the man? Professional career. Oh my God. That's what it's all about. A bit of children, yeah. Come, talk to them. Nice. I've got 2 children. I've got 3 children. Look, they're growing. A bit about that. And then, of course, wow, today's the match, isn't it? Or did I miss the match? Don't talk. I know I come back late, but still I've got to see the match. Khana kahan hai? Where's the food? I want to see the match. Take the TV. Okay, so the khana gets served. Aaj ka khana to acha nahi tha. Okay, so I'm not drinking. I'm going out with my friends. Today, India won, so I'm going to celebrate. But if India had lost, he still would have gone out to friends, because itna gham hai, कि फिर भी celebrate करना, drink करना. So, and then parents and siblings, yeah, they were important, but not wife's parents. And wife, उसके बाद तो दिखता ही नहीं है. उसके बाद तो unreadable हो जाता है. Lot of work, but it's all. And that women are always therefore going to be larger than men. That's the truth of life. Except women miss out. And they miss out because they just haven't got one property in their life. And that is this, ego. Man's ego swells up to the extent that we're always going to be big and huge, irrespective of that we do nothing apart from look after our profession and a few other things in life. So I do believe that when I say, how should women get into interventional cardiology? It's a dream, it's a passion, it's a mission, but it has to be a mission for all of us here. Everywhere, in every cath lab, you'd be happy to know that of our fellows, what we've got, we today have appointed, in the last 2 months, we appointed 3 lady associate consultants, which actually makes it 4:3 of ladies compared to men. And I'm proud of that. My fellow at the moment today, associate consultant, a DM from Jaipur, came to me 5 months ago, and I asked her one single question. You've been around and looking at interviews, you come to Dr. Ashok's seat, and you think you walked into a temple Why should I take you? Do you think I'm going to take you? You know, I've just interviewed 5 guys who seem to be really, really very good. They didn't look as smart as me, but they were still good. But why would I take you? And she said to me, I think you won't take me. I don't expect you to take. You've interviewed 5 other guys. I've not been taken anywhere else. And I don't think you'll take me, but I still took my chances. And I said, this is the girl I want to take. She cannot believe in her passion that she's come 5 times and still wanting to do interventional cardiology. And if she has got that passion, then I have to be aspirational and inspirational for her. So we have to be together in this. If anyone can, if passion is like you all say, I used to say this for myself, if anyone can do it, I can do it better. So you say, if anyone can do it, we can do it better. I used to say, if anyone can do it in the world, I can do it. You say, if anyone can do it in the world, I can do it, but I can do it even better. So the 4 C's I finally finish with is all of us have to imbibe. Men or women in interventional cardiology. As we progress, we've got to have conviction, we've got to have competence, we've got to have confidence. Confidence in speaking in front of a hall full of women. If that's a confidence, I know you can have all that confidence, speaking in front of a hall full of women. I need that confidence. And of course, you have conscience. Ethics. Ethics do matter. Every time when you push the boundaries, somebody, somewhere, at some stage will die on your table. And if he dies on the table, you have to walk out, and that's the difficult walk. And then you have to tell that relative that he's no more there, because he had few options, but you had the competence, you believed you had the courage, and you believed you were pushing the boundaries with a new technique and new technology. The only thing which saves that is that if you were ethical and you had the 4 C's already ingrained in you, to the extent that you could say that if my father had the same, I would actually use the same device in the same manner, even if it was the first case ever. Then you got the conscience, because you do it to your father, you do it to your mother. So finally I say, when we push boundaries, we owe it to our patients, we owe it to our colleagues, we owe it to our juniors, and we also owe it to our families, because we are here, because they sacrifice a lot, whichever part of the family we talk about, and especially our children do. So you trust in your God. That's my final thing. Our glory and our success is never going to be ours. It's a perception. A single fall down the stairs, I would bleed in the brain, and the greatness of Ashok Seth will be no more. You have invited him for a lecture, and he will not be there even in another 20 minutes. So that's a perception. There is no greatness. It's just a belief in the power who guides and looks after us daily, but even more so, he looks after our patients daily. Thank you.
Thank you so much, sir. Thank you for such inspiring words.